and this enhances lipolysis. So as we say in Hindi, loha lohe ko katta hai, you're going to give fat from outside and use that to burn endogenous fat. And this induces the process of ketosis. Low carbohydrate level in the liver is a huge trigger for ketone body production. Now bear in mind, I just want to tell you we are very safe. In a normal diet, the ketone bodies are 0. When you go into diabetic ketoacidosis, those levels are more than 25. What we induce is just a trace level of ketosis, and if we were to measure the BHB levels, they would be in simply this safe range. And ketosis hence works in a very diagrammatic way by inducing this fatty acid level that travel to the liver, and you actually start removing fat from your organs. It's the best way to displace visceral fat. And keto adaptation will happen about 1 or 2 weeks into the process. So we typically ask our patients to at least do the first round of ketosis from anywhere from 2 to 3 weeks, and we'll talk about the practical aspects. Now, what does the data show you? Here is a study, hot off the press, my friend Giovanna in Italy, who does this. This is just from 2022, just last week. Very low carbohydrate ketogenic diet, a real-time safety study. So they looked at 106 patients. What's interesting is more number of women, about 94 women. You can see they are all obese. And they put them on a very low calorie as well as a very low carbohydrate, about an 800 calorie diet. And what do we see at the beginning and at the end of the phase 1? So the anthropometrics, you can see dramatically and statistically significant weight, BMI, and waist circumference goes down. The blood glucose did not go down significantly. These are not diabetic patients. These are obese patients. But it was trending towards significance. Lipid parameters, I'm always asked about that. So you can see the total cholesterol levels go down. The HDL, LDL cholesterol levels also went down. HDL cholesterol remained the same and triglyceride was not affected. I will show you other studies where the triglyceride levels drop down and the HDL cholesterol also rises. Now, what about the metabolic syndrome? So this is taken from Dr. Wallach's study, who is also doing a lot of research in keto diets. What they did in the first study, they had a very active, very low calorie phase. Over here, what they do is what is more akin to what I'm doing in my practice. The patient comes in, you have a regular diet run-in, followed by a low carbohydrate period for 2 weeks, 3 weeks. Then you do a washout with regular diet. Then you again kind of subject them to a moderate carbohydrate diet, and then you will release them into a regular pattern of dieting. 16 obese patients were studied, and a picture speaks 1,000 words. This is before. You can see the prevalence of metabolic syndrome, and what do you see? To the right of your panel, metabolic syndrome disappeared in all of these patients. You can see that the low carbohydrate diet did the best, but when they start going back on carbs, some of them recurred. But this was fantastic results that you're able to maintain this even later on a regular diet, so there is something happening. Now, these are small studies, so I'm showing you a meta-analysis. Does this work in larger groups of patients? So this is comparing now. It's low carbohydrate versus a low fat diet. And the low carbohydrate group, you can see over here, their carbs were down to 60 grams, so it's a little bit higher than the ketogenesis. Again, what you see over here, the baseline is similar, and the patients did very well in terms of reducing their weight, in terms of reducing even their cholesterol levels. Let me just go here. And the dietary intervention, again, is clearly shown over here. So here, let me show you the weight, the primary outcome. In all of these studies included in the meta-analysis, majority of the study favored a low carbohydrate versus a low-fat diet. So fat is not the enemy when used in the right way. And again, showing you a breakdown wherein we can just go to the next slide. It's easier to see it over here. In a diabetic population also. So now we are moving from pre-diabetes, overweight, to obesity, metabolic syndrome, to diabetes. What happens if you start using the VLC diet or the very low carbohydrate ketogenic diet in diabetic patients? Small group, 21 patients. Reduction in HbA1c in all of this. Before intervention, 7.4%, and after intervention, 6.3%, with almost a 50% reduction in the medications they were using. Okay. So moving along, another longer-term study. So what I showed you previously were smaller studies, shorter studies. Now let's look at a 12-month outcome study. Randomized trial of moderate carbohydrate and using very low carbohydrate diet in patients with type 2 or pre-diabetes. Again, as you can see, moderate carbohydrate also does well, but the very low carbohydrate diets had a very good HbA1c reduction, and this is over the course of 6 months, which was then maintained at the end of the study by 12 months. Looking at another group of patients, the VERTA results, Dr. Saslow's results, almost akin to a 50 to 40% remission, partial remission of type 2 diabetes, which means you're able to bring the HbA1c down below 6.5% with about a 50% reduction in medications. So putting all this together, this is a systematic review, again, just recently out in press, and you can see there are various studies looking at HbA1c, markers of insulin sensitivity and production, such as the HOMA indices, waist circumference, other metabolic parameters, such as LDL cholesterol, triglycerides, and all of this have shown an efficacious and safe nature of the ketogenic diet, which is purported as a very high-fat diet. In fact, this has forced our guidelines to change. The American Diabetes Association in 2019 said the patients with type 2 diabetes who are not meeting glycemic targets, it is a priority that you can use a low or a very low carbohydrate diet plan as a viable approach. So this is something that is being recommended. So going back to the fact, why does it work? Of course, we all know it's calories in versus calories out. So I'm not saying that you can have unlimited amount of calories, because remember, a gram of fat is 9 calories versus a gram of carbohydrate or protein, which is about 4 to 4.5 calories. So you have to bear that in mind, that when you're using fat as your primary source, you have to count the calories also based on your patient's needs. But what we are truly doing over here is we are flipping a metabolic switch. We are using the whole concept that giving less amount of calories from outside is forcing your body to use the remaining calories as fat. And we also need to think, though, what happens when I see a patient with type 2 diabetes? He comes to me today, and within a week, I'm able to reduce 50% of his medications on the ketogenic diet. Has weight loss happened yet in 1 week? No, not really. How many of us have tried to lose the 5 kgs in 1 week when we have to go for a wedding or something? Raise your hands. I think most of us. So yeah. So the weight loss has not yet happened, but we still see the improvement in diabetes. This should make us think that what is it? Is it the calorie restriction? No. Is it the weight loss? No, maybe. Is it the fuel switching, or are we triggering some other important pathogenic mechanism? And that's what we'll look at in the next few slides. We know that low carbohydrate diets help to improve glycemic control in type 2 diabetes beyond the weight loss benefits. So this is from a particular study wherein they show that in spite of the percent change in body weight not being that high, you can see the HbA1c reduction is much higher in low carbohydrate diet versus the low fat diet plus orlistat. So these are significant things to keep in mind. What we now know from various studies is that the fat factor, the ketogenic factor, triggers the growth of healthy gut bacteria. This gut probacteria, we know that the probiotics that we use, the microbiota, has a huge impact on our metabolic structure. Now, other metabolic pathways. So try to kind of follow along with me what the ketone diet does. The ketone diet is always considered a moderate protein. We don't give any protein supplements from outside, because all our walnuts, seeds, oils, they all have high amount of protein. They seem to trigger the thymic effect of proteins and satiety hormones. This improves your energy expenditure. The ketone bodies by themselves can cause a direct suppression of appetite and inhibition of NF-kappa B, activation of the GRP pathways, inhibition of NLRP3, and histone as first or the very active stage. They give the patients only 800 kilocalories per day. So there is a lot of meal replacers, and this goes on for about 3 weeks. Followed by this, they put them in a low calorie, low carbohydrate stage, and they try to maintain their target weight, which they have lost already. And in the maintenance stage, they teach them again, and they give them a balanced diet, and this is what they call their phase out or phase 7 process. And during this, you need to be monitoring them every weekly or bi-weekly if they are diabetic, with anthropometric parameters, as well as certain lab assessments done at the beginning and at the end of the study. We use urinary keto sticks for our patients. This is what we do in my clinic. We actually, when they come in, we assess if they are eating about 300 grams of carbs a day. We ease them in. We start with a moderate carbohydrate or a 150 grams of carbohydrate low carb diet with a low fat, and we keep them isocaloric. After the first week or 2 weeks, we then take them into a ketogenic diet wherein we bring the carbs less than 50 grams per day and not 30 grams. In our patients, we have been able to produce ketosis with 50 grams because they were already taking so much more. And then we take them back into a low carbohydrate and try to see if we can maintain them. And we repeat. That's why our intervention is called the 12-week cyclical ketogenic diet. So this is our cyclical ketogenic diet protocol is what we are following. And this is from my study. I'm just showing you some data of 22 patients. So you can see that significantly we had great weight reductions from baseline to 3 months, great impact on the BMI. Also, fasting sugar and HbA1c both dropped down significantly. We were able to take the patients off their medications and maintain this. So putting it all together, type 1 diabetes, please don't attempt it. Carbohydrate counting is the way to go. We do not have good dietary research. What's new from 2013? The guidelines recognizing very low carbohydrate diet as a safe, viable, and important option for your patients with diabetes, targeting for 5% or more than 10 to 15% weight loss for trying to reduce the medications and complications of diabetes. Takeaway messages. I just want to focus on the last sentence that I have put. You may start off with a very low carbohydrate diet, but remember the term therapeutic carbohydrate restriction, TCR. In the future, you're going to see more and more papers on this, thinking about 100 to 130 grams of carbohydrates per day for your patient, which is more sustainable, and I'm hoping we will have more and more data showing the benefits. So are you ready to make this switch? If you are, then please take the leap of faith and also promote it to your patients, using not just medicines, but your kitchen as a source for your patients to get better and improve their health. Thank you very much for your attention.
Didn't we promise you a comprehensive and an excellent talk on ketogenic diets? So that's what we had delivered. Thank you very much, Dr. Rucha. Due to shortage of time, can we allow just one question? Okay. Please.
Oh. Very quickly, yes. Yes. So contraindications. But in your type 2 diabetic patients who has significant renal failure, so I can't give you a GFR number, but I would suggest that if they are already having baseline nausea, vomiting, any of those symptoms linked to a reduction of their renal function, that would be a contraindication. If the type 2 diabetic patient has significant, so we are seeing a lot of fatty liver with cirrhosis. So staging of their liver disease has become increasingly important as the MELD scoring and everything has changed. So there are no guidelines as such, but I always worry about underlying significant heart failure, underlying kidney failure, liver failure, those target organ damages. The newer molecules, if your patient is on SGLT2 inhibitors, which already induce ketosis, so I would say use them to your advantage without getting scared, but a diabetologist, endocrinologist should be doing it, or any dietitian on board with an MD physician. The SGLT2 inhibitors will allow you to put your patients into ketosis faster. The idea is when you start the diet, you want them to go into ketosis in 2 to 3 days. So we really monitor their fat intake and their diet very closely for the first 3 to 4 days. And if you have on board an SGLT2 inhibitor, you might go into ketosis much faster without going into diabetic ketoacidosis. But a word of caution for those who are not. And then, of course, if your patient has any other significant ongoing cancer therapy, all the usual things, immunomodulatory therapy, you would have to worry about it. But if you had something else you have thought of, please do share with the... Yes, okay, great. Thank you, sir. And I don't know if Shilpa can, if it's a short question, I can... So I do, Yes. So that's of course a very relevant question is what is the sustainability? And I can say we do have, I'm not showing the data today, but hopefully I'll share with you on one-on-one basis is we do have patients now that we've been following for the last 4 years. And for most of the time, once we have achieved the goals with the ketogenic diet, they try to maintain 100 to 150 grams. But in India, which is, we have festivals, we have everything is celebrated with food, holidays, birthdays, death anniversaries, wedding anniversaries, everything. So therefore it becomes difficult. So we do tell them to balance out. The idea is when you're in moderate carbohydrate diet, you are not in ketosis. So it's not going to throw you out of the whole pathophysiological circuit. Our benefit is during the ketosis phase. That is when we tell them these 15 days of, you cannot cheat. You need to stay in ketosis to get the maximum benefit for what you're doing, which may not be weight loss, but more the metabolic changes. Then when they go back into, they kind of tell us, they predict that we have this coming up or we're traveling. So we allow a little leeway. So, but that's a very relevant question, or we may balance it out with dietary counseling. So I know Purvi is getting anxious, so we'll talk one-on-one. Thank you, yes.
Thank you so much. As chairpersons, I think we have a very cruel duty of trying to keep on time. And so let's move forward to the next talk. And for all of you, Dr. Rucha is very much here with us. And you can pick her brains as you want through the day. Dr. Rucha, there's a memento for you.
We want all together, yeah.
Moving to the next session, I am honored to introduce Dr. Nk Singh. Can I have a slide, please? Dr. Singh is MD, FICP and FACP. He's a diabetologist physician at Dhanbad. He's a director of Diabetes and Heart Research Center at Dhanbad. He's a chairman at RSSDI Jharkhand. He was an ex-governing body member at National API, ex-chairman API Jharkhand and CCD SIBJ, edited a Millennium Book of Medicine, Associate Editor, Postgraduate Medicine 2021. He has over 30 national and international publications. He's an admin and founder of CME India WhatsApp group. He's also editor at cmeindia.in and diabetesdhrc.com. He has a fellowship in WHO and Diabetes India. He's going to talk on the topic, the customized exercise prescription. So over to you, Dr. Singh.
Good morning. I think, first of all, a great appreciation for this unique conference with Dr. Sanjay and Dr. here, Sarda and all the team members. I think this is a very unique concept these days, again, that we should have some customized exercise prescription. Similar to a drug, exercise has to be prescribed in modality, dose, frequency, and not only a pathology, but also a personalized patient approach. And new data are needed to make this new science not only evidence-based and personalized, but also a precision approach. So this is a very, very important statement from the American College of Sports of Medicine. I think Plato in 400 BC told that in order for man to succeed in life, God provided two means. First, the education and the physical activity. Lack of activity destroys the good condition of every human being. While movement and methodological physical exercise can save it and preserve it, it is so true these days also. And if you see here that for every 1 hour of aerobic exercise you do, you add 2 hours of your lifespan and your general health. So there are amazing science of exercise these days going on, but that is not the problem. Problem is, why do we fail to follow? And I urge you not to just to listen my lecture here for your knowledge sake, for experience it, know the science, and adapt in your life. That will be the motive of my lecture. But definitely exercise prescription is not a new thing. Even the Susutra in 600 before the CE of India, he was the first physician to prescribe moderate daily exercise to his patients. And the modern time, the Hippocrates even, he gave the father, we know the father of science of the medicine, who was the first physician to provide a written exercise prescription. So this is very, very important issue. Whenever we generate a prescription for exercise, there are few key elements. You assess your patient, determine the priority, what are the priorities of the health issues. The third is identify patient capacity and intervention suitability, and then you generate exercise prescription by total exercise dose. It is just like a medicine dose. The mode, what should be the intensity, what should be the frequency, what should be the duration, and how it will progress. And then you should monitor education and bring the behavior change, and then reassessment and prescription modification. So these are very, very important issues these days, especially for the type 2 diabetes and many other comorbidities, associated conditions. So I told you that the components of exercise prescription, and we will deal for that. What should be the type of exercise? Should be walking, swimming, cycling, or some specific workloads, and duration and frequency, how much? And then the intensity guidelines are the target heart rate, and these days the RPE, that is very, very important. RPE, that is the preserved, perceived exertion experience. That is very, very important. So we'll discuss that. So first we need to generate exercise prescriptions. Even though exercise prescription has become a popular topic these days, it is still a novel science that needs to be developed, remember. And today there is lack of evidence-based clinical practice and conclusive guidelines. In the light of that, suppose in my clinic I have just generated one prescription like this, where I give 10 minutes to my patient. First thing is the fit, the frequency, intensity, type, and time. And then we see the status, not active, it is not active or not, even the intention is there or not, or some activity but not enough. And then lastly, the recommended about the food care, aerobic type, resistance type, heat, or yoga, or whatever it may be. As you know, the minimum of 150 minutes of moderate to vigorous intensity aerobic exercise has been advised or recommended by the ADA and other important guidelines. But the question is, what is missing here? So what is missing is the MOBE. That is the move to optimize your vitality and enjoyment. If you simply give a prescription like this, you just write, you do a 30 minutes of walking and this and this and this, patients are not going to follow that. I think a famous diabetic eminent person from the Mumbai, Dr. Bhaskar, he once told me, and he has also written that, all the diet charts we formulate for our patients, most of are going to the dustbin. So I don't want that this prescription also go to the dustbin. So what to do? You add the enjoyment and effectiveness of the exercise. That is the most important element. So that is these days known as FITTEE. Fit EE, that is the enjoyment and effectiveness. So this, I think, could work. You choose to move, and you just ask your patient, what do you like? You like walking, you like swimming, playing, dancing, yoga, gym going, gardening, what do you like? And accordingly you do for that. And then you assess in the beginning what could be the positive adherence variables and what are the negative adherence variables. Adherence regions for communicating there could be the physical fitness, weight and figure control or relaxation, enjoyment or fun, I told you, and then the non-adherence fact regions, you give some time for that. The time restraints, lack of self-motivation, the seasonal conditions. Patients will say you, most of my diabetic patients, when they come, sir, you tell to do exercise every day, and I tell for 60 minutes. अभी बरसात है, उसके बाद फिर गर्मी है, और उसके बाद फिर जाड़ा है. So it is so cold, so heat, so raining, so what to do? So that is it. Also the boredom of the dislike of activity. So think about it. Then you assess about, in your diabetic patients, whether they are suffering from some nervous system disease, metabolic system disease, or urinary system disease, and accordingly we will deal and we will tell you what to do. So first thing is, in our practice, we have some sort of medical clearance. Like individuals should not begin exercise if the blood glucose is more than 250, if moderate or high levels of blood or urinary ketones are present. So these are some of the things which has been given. And for anyone, usually insulin or taking sulfonylureas, it is important to carry rapid-acting carbohydrate source to prevent the hypoglycemia. And then I told about the RPE, that is the rating of perceived excursion, and that rating has been basically 1 to 10. And that is very important. If a patient is thinking he is doing very light activity, it is 1, or if it is doing very vigorous activity, and he is thinking, I am doing very vigorous activity, it is 7 to 8, and like that, it is very easy to follow it. The next part in my exercise prescription, before I tell them that you go for 20 minutes or 30 minutes or 60 minutes, tell a bit about science of exercise to your patient. If you are not explaining this, the whole problem will persist and your exercise prescription will doomed to fail. So in very short, you tell them what is happening. Exercise is $1 billion drug and never gets prescribed. This gentleman, the Phil Sutherland, is a type 1 patient. And he has written a book known as Not Dead Yet. I think I will urge you to read that book, how he has formulated a type 1 diabetic novo, this team, and he has done this patient has done so many work that we are following in our ADA guidelines these days. There are lots of exercise benefits you know. So you tell that insulin is not, I tell, look, when you do exercise, insulin is not required for glucose to enter into the cell when you do exercise. This is a form of non-insulin dependent glucose uptake known as, remember, CMGU. That is contraction mediated uptake occurs when you do exercise. This is a great thing, great knowledge. That insulin is not at all needed when you contract your muscles. And जब पेशेंट्स के साइक में अगर आप इस चीज को घुसा देते हैं, वो समझ जाता है कि when the muscle will move, insulin is not needed, the sugar will burn and glucose level will come down, he will do exercise. So essentially, muscle contraction allows glucose to enter the cell. The second thing that there is a misconception that only doing aerobic is okay. This is not okay. The science is telling you that resistance exercise is very, very important. And this resistance training is more effective in improving this GLUT4 number and the function, and highly effective in slowing sarcopenia. These days, Dr. Rusha was also showing you the sarcopenic obesity, like a just epidemic. So thus to slow the sarcopenic obesity or sarcopenia, which has a close association with type 2 diabetes, you need resistance exercise. And you can see here what are the benefits with aerobics and what are the with resistance. If you see the strength, muscle fiber size, natural adaptations, exercise performance, there are many things where only resistance exercise can bring the advantage, not the aerobics. So what to do? Even if you want in these COVID days to boost your immunity, you see here what is happening. billions of lymphocytes are mobilized in response to just a single bout of exercise. Are you aware? Billions of lymphocytes, particularly if the exercise is a dynamic and taxes the cardiorespiratory system, like running, cycling, or rowing. So this is a very, very important thing. And I show this cartoon to my patients कि तुम्हारा mitochondria जो है ऊपर में देखो कैसा है without activity, and if you are doing exercise daily, it becomes green. So my slogan is make your mitochondria green. वो पेशेंट को समझ में आता है कि something very important is being told. So there is a science here. I will not go in details, but definitely this happens. Then I tell about the type of exercise. If you see here, even the short-term aerobic exercise improves insulin sensitivity, improved mitochondrial function, and if you do vigorous aerobic exercise for 7 days, they may improve glycemia without lowering body weight. Short-term aerobic exercise in individuals with obesity and type 2 improves whole body insulin action through gains in peripheral insulin sensitivity, more so than the hepatic insulin sensitivity. Then the second thing is the resistance. I told you about that resistance exercise training in type 2 diabetes typically results in 10 to 15% improvements in strength, bone mineral density, blood pressure, lipid profiles, skeletal muscle mass, and insulin sensitivity. So which one is better? This gives you the whole picture of what resistance exercise is doing, but which one is better? Definitely the combined is better. There will be a greater reduction in HbA1c, and it will be superior to either mode alone. You can see here, if you're only doing aerobics, it enhances insulin sensitivity 20%, remember 20%. And even the reduction of the HbA1c, 0.4 to 0.5%. But if you do combine, the insulin sensitivity increases by 70%. And you see here the lowering of HbA1c occurs 0.9%. It is better than any drug. It is better than any drug. Now, what are the physiological components of common exercise activities? You see here, if you are doing yoga, walking, jogging, cycling, dancing, how much resistance it is bringing to you, and how much aerobic components. And these days, लोग बोलते हैं मेरे को समय नहीं है, 10 मिनट ही समय है. Tell them to do the HIIT, that is the high intensity interval exercise. Only 10 minutes, 5 minutes, 10 minutes. Go and read about it. Considered superior to low intensity training. So this is a very, very important concept. And even the moderate intensity continuous training is very MICT, or sprint interval training, all are very, very important concepts. About running, people do not talk about that. But remember that only running every 5 to 10 minutes per day, and even a slow speed, 6 miles per hour, is associated with markedly reduced risk of death from all causes and cardiovascular disease. And this study may motivate healthy but sedentary individuals to begin. So this is run if you can. If you don't have time, just run for 5 to 10 minutes. That could be important. Again, in rainy days and even every day, I think the yoga has been being promoted, and now lots of research is going on, even the USA, that yogic practices improve insulin sensitivity and reduce the insulin resistance. And if you can do nothing, I think sometimes your patient will tell you, I don't have 20 minutes, 30 minutes, what to do? I tell, you only give me 5 to 10 minutes, you do the 12 rounds of Surya Namaskara. So important. And this is totally scientific studies based, whatever I'm talking about you. It is a very, very big science. By doing Surya Namaskara, you get aerobics component, and also you get the resistance component, which improves everything. Then intermittent sitting. लगातार बैठने का जो habit है, that is killing us. So 1-2 घंटा बैठ के, this is very, very important. The trials has shown these days, this interrupted prolonged period of sitting with 15 minutes or walking after meals even is important, so you go for that. And there are lots of science for that, how even the intermittent sit, this movement is so important. If you patient can do nothing, you tell about the daily movement. Many wives comes to our patient as a patient, बोलते हैं मेरे को सर दिन भर टाइम नहीं है कि मैं काम करेंगे. But when we ask about what you do in your house, amazingly they are doing lots of daily works. And that is even very, very important. Lots of studies are there. Even there are some studies showing that dog ownership and physical activities has some evidence. It improves many, many things, and because it motivates also you. So this is a very also important. So I will not go in detail. This 2020, what are the exercise, physical activity, and type 2, there are consensus statements regarding the aerobics, resistance, flexibility, balance. Everyone saying you 150 minutes of walking per week. I don't think this is good for India. My slogan is at least 60 minutes walking per day. This will bring you the desired changes which we want, because we are taking lots of carbohydrates, and we are already, there are some genetic components, other things, so 60 minutes, remember. So these are all available. Now the patients will again ask you, sir, किस time में करें? सुबह में time नहीं मिलता है तो क्या करें? Now the research is showing that even the evening workout is very, very important. I will not go in detail, but the research is there that the afternoon exercise is more efficacious than the morning exercise in improving the blood glucose levels in an individual with type 2 diabetes. You can see here what is happening with the morning exercise, and when the same amount of exercise with same intensity being done in those cohorts, getting better control of the glucose and other parameters with the afternoon exercise. So, I think the take-home message will be, whatever time your patient gets, tell him to do. Even at 12 at night, no problem. 8 o'clock, any time. So this will be better. So, but anyway, the science is saying you that the afternoon exercise is more efficacious, because the glucose tolerance, insulin sensitivity, and muscle oxidative capacity, so circadian oscillations. So that is the reason why it is more efficacious. Now the patient says, kitna kare? And if I ask you, which one is more important, intensity or duration? Which one? ज़्यादा इंटेंसिटी का एक्सरसाइज करें कि ज़्यादा देर तक करें? The current research clearly says that intensity is more important than the duration. At low intensity for an extended period of time, the fat becomes the primary fuel source, and this is far less efficacious at the lowering the blood glucose levels. And intensity ranging from moderate to high utilize more carbohydrate for fuel, therefore are more efficacious at lowering the blood glucose. Madam, please tell me 2 minutes before. Yeah. Now the last point or last part of my talk will be, kitna kare? And if you see this story, why these Pheidippides die from the marathon itself. The Greeks sent there the fastest runner, Pheidippides, to carry home news of the victory. He sprinted 26.2 miles from the battle site to the city-state of the Athens, and he arrived and said, "Rejoice, we conquer," and died from the exhaustion. The marathon race is named after this event, you know. So we need customized exercise prescription. This is the reason. And in our diabetic patient, the dose matters. Like there are lots of scenarios of patients are coming. Could be the newly detected, no comorbidities. The second scenario could be osteoarthritis of both knees, could have the proliferative retinopathy, some might have the CKD, some might have the CHF. So there is science these days, having autonomic neuropathy, peripheral neuropathy, with pregnancy, many cardiac issues, you need to apply those signs. Even you have to concern with the hypoglycemia, how to prevent that. And concern with the hyperglycemia, when not to do that. And non-diabetic medications, like someone is taking like beta blockers, which blunt the heart rate response to exercise and lower the maximum aerobic capacity to 87% of expected negative inotropic effects, or beta blockers or other things. So this knowledge is also important. But the important points are the autonomic neuropathy, be aware of an increased likelihood of hypos, abnormal blood pressure responses, and impaired thermoregulation, as well as elevated resting and blunted maximum heart rate. So take steps to prevent the dehydration and hyperthermia and hypothermia in those cases. So there are some of the things you will get in all the ADA guidelines, and they are in all the sports medicine guidelines. in autonomic neuropathy what to do with the peripheral neuropathy, where they limit the exercise participation that may cause foot trauma, not weight bearing exercise. But I will only touch about like diabetic retinopathy is very, very important. But remember, the moderate intensity physical activity is associated with a lower risk of diabetic retinopathy. And mild non-proliferative retinopathy, all activities we permit, but early IMC needed. For the moderate non-proliferative disease, activity like powerlifting, which may significantly increase blood pressure, should be avoided.
Sorry to interrupt, sir.
But so in nephropathy, then also it is very important to improve your erectile dysfunction, which is a huge problem these days. But it improves exercise, and most of my patients, I don't use any medications. I only do this, tell about to do that, and this improves their function. So it also improves the sex drives of women and also men. Only 2 minutes. And type 1 diabetic also, there are lots of things what to be done and what to be not done. You should be aware about that. In the hypertensive cases, in the diabetic kidney disease, so everywhere there is role of even the CKD with a stable angina, with pacemakers, with post-coronary neoplasty, lots of in pregnancy also. It is very, very important. You should be aware about all those things. I think for next 2 or 3 slides I will show you, and I will end here with the exercise and diabetic foot ulcer. But last point is, here, see here, the exercise in older adults and diabetes. This is again a huge gray zone. And I think you will remember this poem by our great ex-Prime Minister Atal Bihari Vajpayee, जिसने कहा था कि उम्र घर चाहे जैसा भी हो उसके एक कोने में खुलकर हंसने की जगह रहना उम्र की जैसी तैसी, and this is also very, very important. So final points are, each type 2 diabetic patient or type 1 diabetic patient is unique. Do assess what sort of exercise suits. Do encourage aerobics, resistance exercise and yoga. Do generate an exercise prescription. And do not sit if you can stand. Do not stand if you can walk. And do not walk if you can run. Thank you very much. Thank you.
Thank you so much, Dr. Singh, for a wonderful and practical session. I think as all medical practitioners, we should utilize to prescribe exercise as a medication. And as doctor said, we should focus on the type and the duration and explaining our patients to the basic science behind that. So that will be really important for the better health outcomes. Thank you so much, Dr. Singh. I would request Dr. Chawla to give a small gift to... I think, okay. We can have one question, ma'am.
Yeah.
That is something we encourage patients, but you showed where HIIT or high intensity, not HIIT, would be beneficial for type 2 diabetics to lower blood glucose. But what I am in favor of, and I wouldn't say there are studies to support truly, is using low intensity, longer duration. Just because, as you correctly showed, it induces fat burning when you're in aerobic zone with heart rate monitoring. And that would have a long-term benefit in reducing hepatic glucose fat, hepatic glucose production, and longer benefits on heart function, mitochondrial, mitophagy, everything. So I don't know, what are your thoughts on that?
Actually, there are some recent research that are definitely showing that HIIT is more efficacious than those combined aerobics and the resistance exercise, even the type 1 diabetes cases. So I can show you all those papers. So there are definitely things are changing. So HIIT is very, very important.
And for both our type 1s and type 2 HIIT, even for non-diabetic patients, I like to not recommend more than once a week, because that's very high intensity. So on a daily basis, I would say that shorter...
It depends on the personalized medicine, because if your patient is happy with the proper aerobics and resistance, go for that. If there is no time, then definitely the HIIT could be much better. But definitely there are lots of contraindications for the HIIT. In all our diabetic patients having the peripheral neuropathy, some cardiac problems, some CKD, you cannot tell them to go for the HIIT. So you have to, but for even the non-diabetic patients, a healthy patient, HIIT is very important if there is no time for doing the exercise.
Can I ask a question?
Out of time duration, we can have only one question, ma'am, please.
So, just a question, sir, about exercise and type 1. Because you said HIIT is also good for type 1, but increasingly we see that the insulin requirement actually increases when type 1 patients start exercising, especially during exercise and couple of hours post-exercise. So,
Yeah, that is a very, very pertinent question. I didn't touch about the lack of time of the type 1 diabetics. And so at the next Jaipur conference, I told the organizers to only keep the exercise for type 1 diabetics. That is a huge
yes.
science for the type 1 diabetics and exercise, how to prevent the hypoglycemia, what to do with the insulin pumps. So there is a huge problem with the type 1 diabetics. So we need to discuss all those things. I don't think we have time to discuss here that. But anyway, sometimes, if the time permits some time, we will discuss about the type 1 diabetes also. But your point is very much important.
Thank you, Dr. Singh, once again. We would like to proceed with the next session.
After that great kickstart to the nodal update, we have now we have a very, very experienced speaker coming up, Dr. Nitin Patankar sir, who's a physician, and his postgraduate training from Bombay University. He has great experience for lifestyle disease management from Johns Hopkins University in the US, and also Duke's University, North Carolina from the US. He practices as a consultant, diabetes management with diabetes reversal especially, and also obesity management and metabolic disease reversal at Jupiter Hospital, Thane, and has more than 30 years of experience. Several publications, chapters, and in the textbooks, and also papers on caloric restriction and metabolic profile in his name. He also publishes extensively in Marathi especially. So without much ado, let's hear it from Dr. Patankar on different case studies and how can we personalize dietary therapy in obesity.
So Dr. Purvi, thank you so much. And my job is relatively easy because if you look at dietary research, it is very short duration and very non-exciting because there are no hard endpoints. So when we go to medical conferences and I have seen Dr. Neeta presenting cases, they are like James Bond movies. So the diagnosis is difficult, then the treatment is more difficult. But when it comes to diet, it is like a slow Agatha Christie stories. So, and secondly, because I'm going to present some case studies, the job is much easier because I don't have to present a lot of evidence because what has happened in those cases, I'm going to present. And luckily, the topic given to me is how to personalize the therapy. So when we say personalization of dietary therapy, there are three pillars on which we need to personalize. One is the pathophysiology of the disease. So basically, we are talking about obesity, and obesity is called as mother of all diseases. So obesity may be accompanied by diabetes, obesity may be accompanied by hypertension, heart disease, kidney disease, hyperuricemia, dyslipidemia. Then all mechanical problems may be associated with it, and in the later part, there may be some malignant component associated with it. So there is a pathophysiology, and pathophysiology demands certain inclusion of foods and exclusion of foods. And I don't think we need to discuss anything because I'm seeing a lot of dietary experts here. And nowadays we have Google, we have got a lot of ready reckoner references so that we can always say which foods to be included, which foods to be excluded. Then it comes to the caregiver, that is the nutritionist, dietitian, doctor, who is going to actually prescribe the diet. And the third most important part is the patient. So let us look what are the factors that we have to look. So this pathophysiology, we have to decide first how many calories to be given in a day. So you must be remembering that in medical colleges, I don't know about when the nutritionist actually goes through their courses of nutrition, but in medical colleges, we were having diet as a 4-mark question in second MBBS, at least in my times. So the only exercise that we used to do was there is a right-hand side, left-hand side. These are the requirements, protein, carbohydrate, fat. And ultimately, they never used to match in the bottom line. So somehow you used to match them like the chartered accountants do in accounting. So expenses and intake, that is matched. But nowadays, we say that the present calorie intake, and that is the most difficult thing to calculate. They talk about the diet recalls, the 7-day diet recall, whatever, all those gadgets which maintain. Nowadays, even we have got photographs and which will tell you the calories. And ultimately, they say you have to have some 300 calories minus present diet or 500 calories minus present diet. But I don't know how actually this is done. Because if you calculate the diet recall, the dietary calories consumed by any patient is around 800 calories. And the most common answer given to diet recall is, I don't eat anything. That is the common answer. So how to reduce 500 calories from I don't eat anything? Secondly, they say that you have to give a low carbohydrate diet, low calorie diet in terms of 600 calories or 1,200 calories. So personalization, it is basically a interaction or a karate match between a dietitian and a patient to decide how many calories to be taken in a day. Then frequency of feeds is like a hydrogen bomb. Some people they say only 2 meals a day. Some people will say every 2 hours you have to eat. And then everybody has got a lot of scientific evidence stating that how insulin works, how glucagon works, how anti-insulin hormones work. And so the match ultimately ends in a tie, and nobody knows exactly what is the frequency of the diet. But when you see the research, American Heart Association has studied all these forms of diet. And they were looking at what is the new onset of diabetes, new onset of hypertension, and they found out that 3 meals a day is the best pattern, the breakfast, lunch, dinner. And even if you go at 2 or 1 meal a day or starting from 4 meals a day, the chances of risk or hazard ratios are a little higher to develop these new onset of diseases. But they don't talk about what are the previously if the patient is diabetic, what will happen. So the frequency of meal again is decided between patient and dietitian. Then include-exclude list is a fixed thing. And how frequently you need to change a diet. That is again a $1 million question, whether patient gets tired of the diet, whether the dietitian gets tired of the diet, whether the dietitian wants a new visit from the patient so that she can change the diet. So there are so many factors involved. Then the patient factors. Patient factors are very important because patient's environment is the biggest cause of concern. Person who is like in Mumbai, somebody is staying in Badlapur and goes to VT, that's a 2-hour commute on one side. And then 10 hours work and commuting back. And then he will say that I have got a family of 5 or 6 members, and if you tell me to eat every 2 hours, it is not possible. Or if you tell me to eat only twice a day, so there are some concerns about that. So environment is most important. Then mindset of the patient. There are some patients, and the last thing is like his knowledge bank from his friends, colleagues, WhatsApp, Google, Instagram, influencers, all those people decide how the person should be planning a diet, what things should be included. And there are so many things which are included. If you know paneer phal, shahalgam, all those, so many weird things are included in diet, and many times the dietitians don't know what these things mean. So we have to take that into account, what is the mindset of that patient. Then patient has got strong belief systems. There are people who say that like, how much my grandmother used to eat, I want to eat like that. Somebody says how Tom Cruise eats, I want to eat like that. So there are so many mindsets which are created. Then there are prejudices, because some persons are prejudiced for a certain kind of a diet. So that has to be taken into account. And I label something as the health quotient of that patient. Because there are some people who are really, they are unable to understand what is the importance of diet in their health. What is the importance of medicine? What is the importance of lifestyle? So you have to go down to that level and explain to them. It is like a student or a child in a 4th grade, and if you want to explain them vitamins, minerals, everything, it is not possible. So health quotient of the patient has to be taken into account. And then there are the dietitian factors also. So under whom they are trained, that is very important. I know Shilpa Joshi here, so her students have got a certain mindset. So they will write down diet or they will form therapies according to what she has been practicing. Then again, their mindset is also important. There are certain people who are called as keto queens, certain people who are called as different names. So the first thing that comes to their mind is writing that kind of a diet. Then their own belief systems also at work. Then their prejudices, their past experiences of writing diets and getting successes. The most important thing is time available to them to negotiate and train the patient. Because as the dietitians become senior and there are more patients come in, it is inversely proportional to time available to discuss with the patient. So that is also important, and set patterns. There are some people who strongly believe in Mediterranean diet, some people who believe in intermittent fasting, some people believe in keto, DASH diet, VLCDs, paleo diets, vegan diets. So these are the 3 pillars, and with all these steps, then what happens? So I'm just jumping into the cases. This is a case, Anita, on day 1. This is her parameters. She was 40 years of age, height 5'5", that is 1.65 meters. Weight is, she has lost weight from 88 kg to 79 kg, and BMI has been from 32 to 29. Now, what are the pathophysiological factors? She has got family history of high blood pressure and breast cancer in mother, then her mousie, and very strong family history of breast cancer. No prediabetes, no prehypertension. Other biochemical parameters are normal. Patient factors have lost 9 kg with Dixit diet during work from home days. And now daily 2 hours of commute and 8 to 10 hours of official work. She continues with the same diet with still reduction of portion sizes, and for last 6 months she has not lost weight. So we have to go into negotiation, because the whole point in personalizing diet is negotiation between these 3 factors: pathophysiology, the patient, and the dietitian. So this is like suggestions and replies. So the dietitian takes the shortest route. She says that already you have lost 10% weight. 10% weight loss can give you 86% of health benefits. So you maintain that weight. No need to lose weight. The patient is Google scholar. So she says, but mother has breast cancer, and I have to come down below obesity zone or overweight zone so that I can prevent my chances of developing breast cancer. So I have to lose weight now. So the second suggestion comes that then we will change the meal frequency. You are eating only 2 meals a day, that 55 minutes pattern. And try multiple small meals, because it's the opposite end. The patient says, I am very happy with the 2 meals a day and has given me good results, so why I should change? Then the dietitian suggests that we have to include higher protein and exercises so that we'll increase your metabolic rate. This is again a very cloudy concept of metabolic rate. Every patient believes that his or her metabolic rate is low, while the science says when you have got higher weight, your metabolic rate is higher. So, and there are no drugs or no diets which can really increase your metabolic rate. But I have seen people prescribing black coffee with some butter and calling it a bullet coffee, and which will increase your metabolic rate. So there are a lot of magic things are available. But this dietitian, being a very, what you can say, a conscientious dietitian, she doesn't want to say that. She says, I will increase your protein intake and exercise. The patient's response is, their working schedules are so tight, I don't have time to exercise. So then we say, the dietitian says that you reduce your calorie consumption then. That is the only alternative. So reduce portion sizes further. So patient's response is already have controlled portions with difficulty, high control hunger pangs between the feeds. So this is a standstill now. So what should be done? So here the personalization, and I would say, like patient says, I have got cheat days in diet. We say there are cheat concepts which are sold to the patient so that we can get some results. So the personalization is, this is what we have done in our clinic. Like Dr. Singh said, that exercises. So exercises in situ, that is we have develop that concept. Situ means not in, it is in sitting position. So use the group of agonist and antagonist muscles and increase the tone and decrease the tone, and you can use all group of muscles. So while you are traveling, you can do all these exercises. While you are in a meeting, you can do these exercises, and they work as almost like tone gaining exercises, and which can increase the metabolic rate. So this was prescribed. Then meal supplements was used, but was told to the patient that we are giving you as a medicine. So patient was okay with taking medicines. So a nutritional bar, a 10-gram protein bar was given as a breakfast time. So as a medicine, it was not a diet, it was not a meal supplement, it's a medicine as a given. And we included meal supplement soups before their 2 meals, which was taken in those diets, so that the concept sold was this contains protein, which contains even casein protein, so that casein is a phosphoprotein, which takes long time to get digested, so your satiety is longer and next meal hunger is reduced. So these are the concepts which are sold, which are not false concepts, but these are sold to the patient, and so the calorie count is reduced further. Patient does some exercises, patient takes 1 breakfast, so meal frequency changed, but this is packaged in a new bottle, and this is what happens from 1 day to 52. Again, weight has now from 79 to 72, and BMI has come from 29 to 26. So this is how we have personalized for this patient. Now this is the second patient. Again, day 1, age is 48, height we have taken same, 165 centimeters, weight is 88, and BMI is 32. Now this person has got a family history of ischemic heart disease. The father died recently of a ischemic heart disease. He has got fatty liver grade 2, HbA1c 6.4, triglyceride 221, cholesterol 201, HDL low 29, SGOT 66, XGPT 62, and GGT of 90. Now, patient factors are, he's a frequent traveler. And those high profile IT clients, which many times we see, then when we talked about alcohol, he said it is need my profession. I am a marketing guy in IT, and I have to take alcohol with my clients. If I refuse, I may lose my business. So, पापी पेट का सवाल है, either liver को ऐसे खराब करो या starvation से खराब करो. So, I need alcohol, and multiple failed attempt to lose weight with various diets and other modalities. So, he has joined gym, he has joined some those nerve conduction or nerve stimulation exercises, high intensity training, but never stuck to something. So, negotiation was planned for a Mediterranean diet because he's got history of heart disease. Then he says that this is possible when I'm at home. But when I travel, I don't have any control on my diet. So I want a different diet for traveling time and a different diet when I'm at home. So I'm ready for a Mediterranean diet at home. And fatty liver needs alcohol cessation. Patient says flatly no. It's professional need. So I will change from whiskey to beer. Now, he asked, okay, and this is a common notion that beer is very mild, and beer may not cause so much harm as whiskey, rum, or all those stronger alcohols can cause. So, personalization, 1 session was devoted to just explain the role of carbohydrate intake in relation to fatty liver. So, his notion was fats can cause fatty liver, but we were could devote that time, and he understood the role of carbohydrates in developing fatty liver. Then he was given Mediterranean diet at home and low or no carbohydrate diet for travel, because luckily he was a non-vegetarian, so he could eat meat and salads when he was on travel, and that is really available everywhere. Salads only with alcohol. That was a compromise that was reached, and we told him that you can have any kind of a salad with mayo or with some other dressings, but you have to feel full. Your stomach should be full. 2 bowls of salads, and then instead of taking beer, you have on the rocks neat single malt whiskey. So there is a cost involved, plus there is a quantity also involved, and we taught him literally how great people drink whiskey. So then he was charged up, okay, then I will have sip by sip, I will restrict to 1 peg a day, and 2 bowls of salads, and cetylistat and glutathione was included because of his GGT problems. And in 3 months, he came down from 88 to 75, and BMI has come to 27.5. So his personalization was a little different. Maybe you can tell me when to stop, because there are different cases. Yeah. Yeah. So third case is this Ayesha. Day 1, age is 58, height is 1.6, weight is 85, BMI is 33. Now, pathophysiological factors. She is non-diabetic, non-hypertensive, normal lipid profile, but she has got mechanical problems, back and knee pain, and she has advised bilateral TKR. And mother has got early Alzheimer's disease and has started forgetting things and has got a lot of gloomy feelings. So she went to psychiatrist, run some tests, but then they said there is no clinical depression. So patient is highly educated. She was saying that, is it subclinical depression? What I can do, and I want to lose weight early because my movements are restricted, and this is going to cause me a lot of problems, and I want to get TKR done as early as possible. So wants quick weight loss so she can become fit for TKR. So there was no need of any negotiations. She was ready to do whatever, and our dietitian chose keto diet. Now, keto diet was chosen. The reason was the history of Alzheimer's disease in mother, and keto diets, when planned properly, are known to give rise to mood elevation and can prevent cognitive decline. So this diet was chosen. This can give little quicker weight loss. Mood changes and cognitive improvement can occur. The only thing that we do was, there is now keto meters are available, keto freaks and keto meters. So we wanted to really see whether our patient is in nutritional ketosis. So the ketone levels, BHB levels, were maintained around 2.5 to 3, so that patient won't go into ketoacidosis, or patient won't be just like a placebo keto diet. So this was maintained, and from 45 days, she came down from 85 to 77 kg, and BMI from 33 to 30. The fourth case is, again, 50 years old, again 1.65 height, 74 kg weight, and BMI just 27. Now, the reason for her weight loss was she has got fatty liver. And we calculate in our hospital, we work in liver transplant unit. So we have got a lot of cases where the patient recipient is sick. He wants liver donation as early as possible, and a lot of time is wasted in finding out a live donor. And when the live donor, who is a family member, usually has got strong fatty liver. So the simplest measurement on CT is something called the liver attenuation index, and that has to be +5 or more so that the patient can donate liver safely. So this patient's LAI was -4 and was prospective liver donor. Her husband needs a liver ASAP. Patient was in hospitalized and decompensated liver.
Sir, can this be the last case?
Yes.
Thank you.
So here we gave 600 calorie diet, not more than 30 grams of, this is mistake, 30 grams of carbohydrate. So this may be again a shocker for many, but 30 to 40 grams of carbohydrates are sufficient. Complete meal and food replacement for 2 weeks, and within 2 weeks her LAI came to +6. So that can happen. So that our hospitals is very happy with us because we have got increased the turnover of these patients because donors can be prepared quickly. This is the last case I am presenting. This is a group of yoga teachers. The average BMI is beyond 30. The belief system is that they want to lose weight, but they want to stick to something called the chakra system. So now that is their belief system. So what we went through is they gave me a dietary choices, that these are the food to be included in the diet. And this is a system that they have got strong belief that if Mooladhara chakra is affected, then you have to have certain red color foods. If the Anahat chakra is affected, you have to have green color foods. If verticular chakra is affected, you have to have yellow color foods. So we said, no problem. If you are ready to take proteins, we can add colors because nowadays natural colors are available, so we can make proteins in a colored form. You can do 20 minutes of aerobic activity, baki yoga activity you continue, and we can choose calories from the foods that you are telling us. So let us calculate calories, you give us food choices. So that's what we have done. And That's why the average BMI has come down to 25. So what have we learned? Fads and fashions in diet prescription is here to stay and is ever evolving. So it is difficult to counter the force of marketing and force of faith. So adapting to these while sticking to basics of dietary principles is the key in personalization. So it's a more of an art on understanding the patient, respecting the patient's expectations, adapting science to patient's perceived reality, and keeping patient's benefits as our ultimate goal. Thank you so much.
Thank you so much for that excellent purview of all the cases. We can have one. Yes, please. Right at the back.
Along with nutritionists and use glucocorticoids or peptides or other medicinal drugs to treat certain such patients rather than making it just a nutritionist job.
No, we have to use a lot of medicines for that because we don't want to make them lose their muscle mass.
Yes, sir.
Because we have to give them 600 calorie diets.
Yes, sir.
Secondly, as you said, the acidity problem, constipation problem, or low bowel movement. So we have to take care of that.
Yes,
I have not described all these things, but the dietary component and the carbohydrate component has to go down to that low level so that it is 600 to 500 calorie diet for 2 to 3 weeks. And if you read the Banting Memorial Lecture on 2012 by Dr. Roy Taylor, he has said that low carbohydrates, sudden profound calorie loss can reverse diabetes also. And in that reversal of diabetes process, he has said that in 2 weeks, the liver is cleared. Within 4 weeks, pancreas is cleared of fat. So if the fat is a dominating component in these conditions, that is cleared. So you have to use all other medicines, but I could not describe it here because it was not a platform.
Sir, just one question more. If we are restricting the calories and making it into a calorie deficit, but like you gave 600 calorie example, if we'll go below that, and sometimes the patient won't lose weight. So if we are getting to an extent where we are just focusing on calorie deficit, won't that increase the chances of malnutrition?
No, because that's what, see, when you are talking about nutrition, you, in that 600 calorie, you take care of essential fatty acids. Then you have to have 0.6 to 0.8 grams of proteins per day. And remaining things can come from fiber and complex carbohydrates. So the chances of somebody going into malnutrition when you are taking care of these components, because carbohydrate is not really essential. You can make carbohydrates from so many other places. So this is more than sufficient.
Okay. Thank you, sir.
Thank you. Sir, I have one question. In our elderly diabetics especially, it's very difficult to make them lose weight when they need to. What do you suggest?
Yeah. So basically, for elderly diabetics, there's a Tufts University study. They say that there is something called as a sarcopenia and dynapenia. And that's why they don't lose calories through muscles, and which is a major organ to lose muscles. So you have to increase the activity of the muscles. And so starting from passive exercises to active exercises, and they have tried it on 95 plus old patients who were bedridden for more than 6 months. And they started losing weight, they started getting mobile. So here the more than calories, because as such their appetite is so low. So basically strength training, assisted strength training in older population will really help them to lose weight.
Very interesting. Thank you. Thank you so much. I request Dr. Priya to felicitate Dr. Patankar.
I would like to invite our next speaker, Dr. Naval Vikram. He is a professor of Department of Medicine, Metabolic Research Group at AIIMS, Delhi. His specialties or interest is obesity, metabolic syndrome, atherosclerosis, type 2 diabetes, and NAFLD. Dr. Naval Vikram has contributed to more than 125 scientific publications in which are well cited. Some of his noted research contributions include studies on correlates of insulin resistance, subclinical inflammation, metabolic syndrome, type 2 diabetes, and NAFLD in Asian, Indian adolescent and adults. In recognition of research work, he has been conferred various awards. So welcome, Dr. Vikram. He is going to talk on topic obesity pharmacotherapy, the present and the future. Over to
Thank
you,
you,
Doctor.
ma'am, for the kind words. And I would like to thank Team IDEC for this wonderful conference at this wonderful venue. So you have heard about the intricacies of diet in the management of obesity and the intricacies of exercise. When both of these fail, and they do fail over a period of time, there comes the role of pharmacotherapy. So I'll be briefly talking about what do we have now and what is there in the future about the pharmacotherapies. Now, this is a very simplistic view of obesity, when the energy in is more than energy out. If it was this simple, then this would not be a big problem. However, obesity is a multifactorial disease, and several factors, neurobehavioral, endocrine, environmental, immune, several factors here are at play, and which make this a very complex and a chronic process, not easy to manage with single or one or two modalities. Why do we need to manage this? We all know that managing obesity reduces the risk of several metabolic problems, the risk of diabetes, and possibly the risk of cardiovascular disease. I don't need to tell about this further. Why pharmacotherapy? Now, we all know that it's a chronic problem, and over a period of time, diet and lifestyle, they fail over a period of time, and even if they achieve results, it becomes difficult to maintain those results over a long period of time. So maintaining the weight loss or maintaining the gains what one has achieved with exercise, diet and exercise strategy over a period of time with having further weight loss. And once body starts to lose the metabolic adaptations and the body's own system starts to activate, and that limits the weight loss. We all know that. Now we have to overcome that barrier, and that is where the pharmacotherapy comes. Now these are the treatment options as for the BMI which they're recommended, and according to the international cutoffs, pharmacotherapy is advised if there's BMI more than 30 in the presence of complications, or even more than 27 with complications, and more than 35 without complications. However, in the Indian population, it is recommended that the pharmacotherapy may be started at a lower BMI as compared to Western population, since we tend to develop more problems at an earlier stage. Now, before going on to discussion about any pharmacotherapy, this is a very important diagram. This here shows the central regulation of appetite. Here we see that there are several factors which are being produced by the liver, the intestine, as well as the adipose tissue, which lead to stimulation or activation of various centers in the brain through the vagal afferents or through the circulation, and that is what leads to several changes in the form of changes in the appetite, changes in the patient's craving for different kinds of food. So these are the factors, and most of the pharmacotherapies are playing around or helping to activate some of these factors. Now, this is the timeline of development of pharmacotherapy, and way back from 1959, when phentermine was first started, there are several other drugs which have come, and few of them have come and gone as well. The ones in the red, they came and they have gone. They were withdrawn from the market, though some of them are quite good, especially sibutramine and leucoserin, but now they're no longer available. What we have now is, in India we have is orlistat, and we have is liraglutide, but not the liraglutide 3 milligrams, which is actually recommended for obesity. We have the other liraglutide, which is recommended for diabetes. And the next one is semaglutide, the oral form of which has been launched in India, but that is indicated only in diabetes. But it has also been approved in 2021 for management of obesity. So we'll discuss very briefly about all these. So basically drugs act by two mechanisms. One, they decrease appetite or the nutrient intake by acting on the central nervous system. Second is they act on the GI. They inhibit absorption of the nutrients. Now this here shows the efficacy of weight loss interventions. As we see that the various lifestyle interventions lead to weight loss, maximum maybe up to 10%, not more. Whereas the bariatric surgery, that leads to weight loss maybe 30% or more than 30%. So there is a gap between the weight loss that is achieved just by lifestyle alone and that which can be achieved by the bariatric surgery. And possibly these new medications could fill that gap. So these are the pharmacological options which we have, which are available. As I said, orlistat and liraglutide are the only ones which are available in India as of now, approved for the management of obesity. Liraglutide is not, but orlistat is the only drug, I would say, effectively. Now, this here briefly shows the various modes of action and the adverse effects. I'm sure this you can find from the literature. Now, this diagram here shows the effects of GLP-1, GIP, and glucagon. Because most of the drugs which are coming are playing around these peptides or these hormones. Because GLP-1, the newer drugs, all of them, most of them are, I think all of them are based on GLP-1. They are activating GLP-1, they may be activating GIP, they may be activating glucagon. So they are playing around the effects of these key, let's say, hormones. So GLP-1 based therapies which are there, which we have, are the semaglutide, and there are several others which are in the various phases of development. Liraglutide 3 milligram, just briefly mentioning here that it has been shown to lead to up to almost 8% weight loss as compared to placebo. Semaglutide is the new kid on the block and is much talked about. This is a GLP-1 analog and has a 90% homology. It acts mainly on the hypothalamus by direct activation of hypothalamus, as well as the direct activation of the hindbrain. That is the area postrema and the nucleus of tractus solitarius. So these are the areas which are involved in the appetite regulation. Now this leads to decrease in the appetite, decrease in the cravings, as well as it leads to a decrease in the energy intake and weight loss. Plus it also has a host of other metabolic benefits. Now these are the various trials, briefly summarizing the step trials of using semaglutide, where it has been shown that it led to almost 16 to 18% weight as compared to placebo, which is a quite significant weight loss. Beyond weight loss, there was also seen reduction in the waist circumference, abdominal fat area, as well as the total body fat. Also, there was improvement in the other metabolic parameters, including blood pressure and the lipid parameters. So it goes beyond weight loss. Acceptability profile, it was the main adverse effect as with GLP-1 agonists, because they all stimulate the area postrema, and that is where the receptors for this are there, and that is the stimulation of which triggers nausea. So that is the one major side effect which is common to all GLP-1 agonists, and this was also the same with this, but over a period of time it subsided. So acceptability was pretty good. Now coming to the potential actions of both GLP-1 and GIP, what if we combine both of them? GLP-1 has been the target, but now GIP also is thought to be the target. Initially, why GIP was not developed for treatment was that, one, in patients with diabetes, the overall response to GIP was blunted. That is why even if you give more amount of GIP, no benefit was occurring. And the other concern was that it could be potentially obesogenic. Now, if you are trying to give for treatment and it causes weight gain, that's counterproductive. But now the premise is that, the hypothesis is that when you give both of these together, is likely to act on the brain and decrease the appetite. However, whatever potential obesogenic effect of GIP may be counteracted by the effects of GLP. So beneficial effects will be augmented, the harmful effects will be counteracted. So that is on base of this presumption, dual agonists have been designed, and tirzepatide is the one agonist which is now, we have seen a recent study which has come out, and which these surmount trials, and which has shown almost 21% weight loss in individuals with tirzepatide. So this is something remarkable, acting on both these receptors. Now this is another medication which is cagrilintide and semaglutide. So cagrilintide is the analog of amylin, and semaglutide, as we talked about. So combining these two together also leads to augmentation of the effects on the brain. So semaglutide, as I mentioned earlier, acts on the hypothalamus and the brainstem, and cagrilintide also acts on the same. So cagri-sema is one combination which is undergoing trials and has shown potential to provide additional weight loss without compromising the tolerability. Now coming to the combination of GLP-1 and glucagon agonist. Now the main concern out here would be, somebody would say that why you are giving a glucagon receptor agonist? Because GLP-1 acts on the effects which decrease the effects of glucagon. Glucagon increases your blood glucose, increases gluconeogenesis. So why would you like to stimulate that? But glucagon increase in the glucagon effect also leads to increase in the energy expenditure. It leads to decrease in appetite. So again, the premise here is that increased insulin, a decrease in the appetite and increased energy expenditure, both these effects will be augmented, and whatever increase in the glucose will be there by stimulation of glucagon, that potentially may be counteracted by glucose-induced insulin secretion by GLP-1. So the harmful effects will be neutralized, the beneficial effects will be augmented. So this combination is also undergoing several trials. Animal trials have been done, and it has been shown that they lead to somewhere around 20 to 30% of weight loss. And human trials are beginning, so let's hope we get this. Now, what if we stimulate all the three receptors together, GLP-1, GIP, and glucagon? So this is a step going ahead, that we are seeing benefits with GLP-1, we are seeing potential benefits with stimulation of two receptors. Why not make a molecule which stimulates all the three? Well, that is also being done, and these medications, some of them are under trial, and in animal studies, again, they have shown beneficial effects with the weight loss ranging from about 20 to 30% over a short period. In the rodents, they have shown about 30% weight loss over a period of 30 days, which is remarkable. If they can lead to this much weight loss, then that is really good. Now, other medications which do sometimes cause weight loss but are not actually indicated for weight loss, metformin, or good old metformin, it may lead to weight loss, particularly in individuals where the weight gain is because of antipsychotic medication induced. SGLT2, very frequently used. They have a host of other cardiovascular benefits. They also lead to significant weight loss. So in individuals with diabetes, when there is no contraindication, these are the medications which may additionally help in weight loss. Now, some medications of the future are the beloranib. These are just for completion's sake I have added, because they are undergoing different stages of investigation. And this drug is an analog of imagelin, and selective methionine aminopeptidase inhibitor, decreases fat biosynthesis, increases fat oxidation and lipolysis. And another one, bupropion zonisamide, which is similar to the other combination which we have. This is also undergoing the treatment, undergoing the investigation. So tizofensin, cetylistate actually is not a drug of the future. It's now available. It is being used maybe more, as good or better than orlistat with the better side effect profile. Fibroblast growth factor, this is expressed primarily in liver, mainly, but sometimes it may be expressed in the pancreas and skeletal muscle as well. It acts as a metabolic regulator. So drugs which are acting through this may be helpful in having a better control in the weight. Now, these are the several strategies, I would say, which are being targeted, like stimulating glucagon receptor, glucagon analogs, leptin sensitizers, or giving synthetic leptin. Drugs which are targeting the ghrelin pathway, because we know ghrelin is one important hormone which has a role in obesity. And now there is a talk about vaccine for obesity, because there are some, long time back there was a research from Pennington Biomedical Center that adenovirus is an important cause which might be leading to increase in the BMI. So if some organism is involved, or we can make a vaccine against just some hormone or some peptide which has an important role. So the vaccine is, the targeted vaccines against ghrelin, they are being investigated. So you have a vaccine against ghrelin, possibly you have decrease in the appetite, and that will lead to better control in your, better management of your weight. So several of these are being investigated strategies. Now there are some factors which will determine how much the drug is going to be effective. So whatever drug you are giving, the weight loss in the first 3 to 6 months is likely to predict how long, how much weight loss will be there over a longer duration of time. And that has been shown in several studies. Now, some factors are there if the patient has, say, intense food cravings and or depression. So then centrally acting drugs like naltrexone, bupropion may be a better option. And in patients with diabetes or pre-diabetes, or as such in obesity, we may have liraglutide or the GLP-1 agonists. Obese individuals who have high fat intake, the orlistat or cetylistat may be a better option, which may give a better results than the others. So in summary, obesity we know is a heterogeneous condition with various neurobehavioral and endocrine factors which regulate the food intake. Lifestyle management remains the cornerstone, but it may fail over a period of time. Now the pharmacotherapies which combine the weight loss efficacy, the long-term safety, that was safety is most important. Many of the drugs who were initially launched, who were later withdrawn, had a wonderful effect in the beginning, but over a period of time, over a few years, we came to know about their potential adverse effects by decreasing complications. So as of now, the GLP-1 receptor agonists have shown the robust clinical evidence which fulfill all of these criteria as anti-obesity medications. Let's hope newer medications we see in the future which are targeting different strategies, and the more we understand the physiology of obesity, and the more we are likely to develop the further drugs. With that, I would end my presentation. Thank you very much.
Thank you so much. Appreciate that we are done in time. So this provides us, if you have any queries, we can have 2 questions.
Yes, sir.
But somehow you know the story of rimonabant. Now what to do at present? What is your experience with the Cana 300? Because although this is the oral drug semaglutide, I have used in some cases, and in 2 months, I have seen 5 kg weight loss. So I think although it is not approved in India, but I think FDA has approved it for the US, the injectable.
Injectable has been approved, 2.5, weekly dose has been
So
approved.
what do you see the future of the drugs which in India, like the injection tirzepatide you told, That is excellent. I mean, that will come to the India. That will brush the market, I think.
That I think the companies will be able to tell better. But as of now, but I think Novo Nordisk is bringing the oral forms and injectable form in India rather very quickly. I would say in the next, I think, 1 or 2 years, possibly we are likely to see. But as far as tirzepatide is there, it may take more than 3 to 4 years, possibly. And as you said, the oral form, which is Rybelsus, which is available as of now, the semaglutide, it is not approved for obesity. It is approved for diabetes, but it is definitely showing very good results in obesity when I have used for in my obesity clinic. And people who are tolerating it well, they are showing very good results with that. And rimonabant, yes, because it was a central acting drug. Now what is under investigation is the peripherally acting drugs which act on the peripheral endocannabinoid receptors. That was a central endocannabinoid receptor acting drug. So now people are developing so that the drugs act selectively on the periphery and they cause all the effects. They don't act on the central receptors. So those drugs are also being investigated. Let's hope we get something.
It's very amazing. A conference in a medical college. Usually we all gather in a 5-star hotel and endocrinologists from all the institute. See, the obesity treatment is very depressing. Okay, many side effects. And you highlighted this antagonist. But recent reports about the worsening of retinopathy, would you like to come use an unmet need as if you're an academician or you work for any industry that I don't know? But
I'm an academician. I don't work for industry.
Could you please highlight about the effect of all these agonists on retinopathy, microvascular?
Microvascular.
Especially retinopathy. There are reports that it adversely affects the progression retinopathy. Have you heard? Or
No, I have heard. There are a few reports, but see, all of these drugs, so far, whatever the evidence, scientific evidence, let's talk about scientific evidence.
Yes.
Whatever scientific evidence it has shown beneficial effects not only on weight, but also several other parameters. So it reduces the blood pressure. I'm talking about semaglutide only. It reduces the blood pressure, it improves your lipid profile, and it also improves in fact, HbA1c, right? So lipids, blood pressure, and sugar. If these three are improved, then I don't think it should have an adverse effect on retinopathy.
gallstones, we don't bother.
No.
Okay.
Gallstones.
Pancreatitis. See, it is.
No.
See, there are certain contraindications.
Yes.
That has. See, because it's a very expensive drug, so the marketing is very aggressive. See, being an
Agreed,
academician,
sir.
Otherwise these people say that we don't have time to discuss.
Sir.
Get lost. Okay,
No, sir, I agree with you. Pancreatitis is potential adverse effect, but so far with GLP-1 use, thousands and thousands of patients have been treated. The incidence of pancreatitis is very minimal, very minimal. The available GLP-1 agonists, millions, I would say, not even thousands, millions of patients have been treated abroad. The incidence of pancreatitis was there, but it is not there, it is negligible. The risk to benefit ratio once we talk about. And one thing you have to be careful while prescribing these drugs is if there is some history of thyroid malignancy. So that one has to see. Before prescribing a drug, there are certain principles
exactly,
one has
the
to
US,
see.
You would have to be on a malignant registry.
sorry.
Yeah.
Sorry to
You should know
interrupt you,
about
sir.
it, that's all.
What is that? Wait for a minute. And Hoodia cacti, just to conclude, there is just Hoodia cacti. That is a cacti in the Africa.
Okay.
Okay, that was being tried. But the pharma industry, they bought the patents. It is being grown by the Africans. Okay. So the thing is that in obesity, it's not as bad as diabetes. So we may have to wait rather than Humpty number of lectures. So that is like indirectly encouraging your residents. Okay, so it has to be given in endocrinology, in a tertiary care, and there are so many contraindications, even in DPP4 inhibitors, autoimmune disease, which none of you talk about. So this is like a new drug, we'll have to be very cautious, your unmet need, we may have to wait. Is that all right?
Sir, just I will, about it, that it is a new molecule.
Yes.
Principle has been tried and tested for several years. It's a new molecule, I would
Very,
say.
very expensive molecule. In our country,
Agreed.
you can't promote
It is
like,
a
that is the,
molecule.
let the price come down.
Sir,
then
due to shortage of time, we've been requested by the organizers to move on. Yes, sir. So please, you can take the discussion offline. Thank you so much. Thank you very much, Dr. Vikram. May I request Dr. Priya to please hand over the memento?
He is from a premier institution. If you don't have time for this, there is no need to have conference. You can go to the art is there. You need not give gifts. You can give it there.
Thank you so much. So we come up with yet another very interesting talk, and it's a great pleasure and privilege to introduce Dr. First annual conference of RSSDI Jaipur, and has had several held several organizing positions for important meetings across the country. He's also the associate editor of the International Journal of Diabetes in developing countries, and has presented papers not just nationally but also internationally, and has several papers to his credit. And he is an incredible human being. So with that, I welcome you, sir, to talk to us on dietary fats and elaborate on whether they are friends or foes.
Thank you, Purvi, for the nice introduction. Can I have my slides, please? I just request my youngster friends who are sitting there, if they want to go, because if you are coming and going from the hall, then it distracts your speaker, okay? So if you want to go just now, you can leave the hall, okay? Now, what I'll be speaking, let me, at the outset, I thank the IDEC organizers, Dr. Sanjay Agarwal, Neeta, Anjali, and all the scientific team for organizing this beautiful conference at this hilltop of Symbiosis International University. Thank you very much, Purvi, for the kind introduction. And what I'll be giving you the two sides of the coin. What we have been told till date, even I think Rucha somewhat told in the morning that fat is not enemy for us. Rucha told in the morning. And what other people are saying since long, whenever you go to a doctor or somewhere else, fat is an enemy, fat is an enemy. So let me give you the two sides of the coin, whether fat is an enemy or fat is a friend. My disclosures. Now, what is the fat? Fat is the body's most basic building block. This is the most important thing we have to learn what is fat. The average person is made up of between 15 to 30% of the fat, and yet for decades we are unfairly demonized for the dietary fat. Always the curse is going to the dietary fat. What we are diligently followed is a low-fat diet always to reduce the weight and everything. Whether it is correct, dear friends, high refined carbohydrate diet, that is the high carbohydrate and refined carbohydrates, what it does, it increases your insulin resistance. It increases the weight, obesity, type 2 diabetes, several cardiovascular diseases, and several numerous problems. So let us discuss about the fat. It is a Greek word, it is a lipose, and it is the lipose is the fat. And basically they are regarded as the organic substances that relatively insoluble in water. So that is the fat, and soluble in organic solvents, potentially related to fatty acids and utilized by your living cells. It is not polymers, mostly it is small molecules, and it constitutes about 15 to 20% of your body weight. So what is the function of the fat? I am giving you all the very basic things. What is important thing? We have to learn this thing. It is a source of energy. It is vehicle for fat soluble vitamins. Very important thing. If you do not have fat, how your fat soluble vitamin will be there for your body? It supports viscera because it is a supportive thing. It gives you the insulation. It is palatability. Your fat is such a nice thing. The moment you think of the fat, it is a palatable. Otherwise, simply taking carbohydrates and proteins, it is not a palatable. So, some taste and palatability is there. It requires for our growth of the body, structural integrity and the cell membrane is very, very important. The fat is important for that. Decreases the platelet adhesiveness, vascular homeostasis, kidney functions. It is needed for secretion of in the stomach, gastrointestinal motility, lung physiology, all several reproduction, neuronal excitability. These are the several functions of the fat which is required for our body. And what are the signs? If we are not getting enough fat, that is a quality of fat. I'll be giving you the both, good fat and bad fat. There are two types of fat. So what are the warning signs? If you are not getting the good fat, the dry skin, itchy skin, scaling always, flaking, soft, cracked, brittle nails. These are all the signs you are getting when you are getting the less quality fat. Hard earwax, tiny bumps on the backs of your arms and torso. They are all achy, so you are feeling certain lethargy sort of thing. The higher quality the fat, the better your body will function. So, the good quality of fat you need, bad quality of fat we don't need. So, there are certain signs you need good fat. So, but there are other side. It is the most concentrated energy. Rucha told it is 9 calories. So 9 calories per gram. Of course, we need, not too much of fat. Alcohol, we know it is 7 calories. So fat is the most concentrated source of the energy. So what is the dietary fat? Dear friends, dietary fat is more complex than the sugar. Sugar is more dangerous than the fat, I am telling you. So if you see here, there are, some 250 names for sugar, and sugar is more dangerous than the fat. Do anyone looks good? Here. See here, so beautiful. I think your youngsters are so much glued to these particular things, especially the chips. Whenever you get this, you take so much of chips. So what we used to think earlier, for decades and decades, what we were told about the dietary advice is the promise that the high intake of fat causes obesity, your weight will increase, you will be diabetes, you will be having so much of cardiovascular disease, and possibly if you are taking too much of fat, you will be having cancers. Fats were our enemy. This was told not only in 1977, even US Senate, the non-medical Senate people, they declared Americans to reduce consumption of total and saturated fat, increase carbohydrate intake, and lower calorie intake. It was actually discussed a lot amongst the Americans at that particular time in 1977. But in 1988, Surgeon General's report also said the similar things that reduces the fat consumption. So it was discussed a lot in the American, and everybody thought fats are our enemy. Now, what are the facts in favor of the low-fat diet? Low-fat and high-carbohydrate diet. There were certain, actually studies were done, and humans, especially preferentially oxidize carbohydrate over a fat, that is a fact, a process that helps to maintain the blood glucose within homeostatically control this ranges. So that actually is required, that high fat diet sometimes does this type of thing. Carbohydrate consumption acutely increases the carbohydrate oxidation with only a quantitatively small increase in de novo lipogenesis. So lipogenesis from point of view, the low fat diet and high carbohydrate diet is okay. I mean, fat is also high palatable and may have a weak effect on the satiation. So that is one point in favor of the low fat or high carbohydrate diet. Now, what are the evidences in favor of low fat and high carbohydrate? This is, I mean, I'll not go into the details, but yes, there are certain evidences. But there are certain evidences in favor of high fat, low carbohydrate diet. And what is that? I'll give you the things. As dietary carbohydrate is replaced by fat, postprandial spikes in the blood concentration of glucose and insulin decreases. That is the mechanism of high fat and low carbohydrate diet. And what Rucha told beautifully in the morning explains everything when she was explaining the ketogenic diet. So what happens in turn? The insulin decreases, the glucagon secretion increases, and the metabolism shifts to a greater reliance on a fat oxidation. So that is one point in favor of high fat and low carbohydrate diet. So dear friends, there are healthy fats, bad fats and good fats. So there are certain healthy fats, and these healthy fats, now you have to change your mindset that every fat or all fats are not bad. In fact, sugar, it is not the fat which makes you fat. And what is the evidence is? It is in front of you, that the high carbohydrate diet causes high blood sugar, high insulin levels, and ultimately increases your fat storage. So when you are taking high carbohydrate diet and refined sugar and too much of sugar, it causes more fat, more weight gain, more fat storage than you are taking the high fat. So low fat diets tend to be the heart unhealthy. Rather, I'm telling you something opposite. That, and evidences is there. It is actually studies published in the dietary in the Science. That is the most respected journal, very recently published in the Science. And this actually mechanism, that less fat consumption, you tend to eat more starch and sugar definitely, and it forms the small dense cholesterol. And you know about the small dense cholesterol, which is more atherogenic, more causing myocardial infarction, insulin resistance, more metabolic syndrome, and of course, type 2 diabetes. So eating fat can make you lean. This what has been told in the morning beautifully. I'll not go into the details of that thing. Rucha told, if you were there in the morning, she told very clearly the ketogenic diet and eating fat can make you lean by way of the right fats, increases the fat burning, cut your hunger, reduces the fat storage. So dear friends, the dietary fats, they are our new friends. They are not enemy for us, and it supports the cell growth, it increases the energy. I mean, these are the good effects of the fat. And there are certain, I don't think I'll go beyond that pleiotropic effects of the low carbohydrate and high fat diet. Published studies clearly said to that if I can see here, the substrate oxidation. It is an important thing for substrate oxidation for carbohydrates as well as for the fatty acids. Anabolic signaling in adipose tissues, postprandial oxidative stress, metabolic syndrome components like HDL cholesterol increases, your triglycerides reduces, your hepatic fat decreases, coagulopathy decreases, and the chronic inflammation reduces by way of reducing the cytokines, inflammatory cytokines. Ketone updates, I mean already been told, again beta hydroxybutyrate signaling already told, all the things have been told in the morning when she was explaining the ketogenic diet. So fatty acids, so we all know your nutritionists are there. I don't want to go into the details of that. We have 3 types of fats: saturated fats, monounsaturated fats, and polyunsaturated fats. And we need all 3 fats. We don't need a single. Saturated fats also we need. We also need MUFA, and we also need PUFA. All the 3 components are very much essential for our body. And again, the only thing I want to tell is, what are the saturated fatty acids? There is no double bond. Mainly it is in the animal fat, and the sources are most of the cow milk, dairy products, palmitic acid and meat. They are the good sources for saturated. For MUFA, it is actually it is a single double bond. That's why it is monounsaturated fatty acids. And the tea of oil, camilla, olive oil, canola, grapeseed oil, they are a good source for MUFA. And the polyunsaturated PUFA, we have worked a lot, we have presented a lot on PUFA also, and there are different types of PUFA. You must be knowing omega-6, omega-3, and omega-9, but most importantly, omega-6 and omega-3 are very, very important. Unfortunately, they are not synthesized in our body. We have to take only from the outside. And it is the ratio which is very important, omega-6 to omega-3 ratio, and 4:1 is the right ratio for our endothelial cells of the body and beta cells of the pancreas. So the ratio is very important. If ratio goes beyond 10:1, it is very, very dangerous for our all cells of the body, especially the endothelial cells of the coronary arteries and beta cells. So dear friends, omega-3 fatty acids are very, very important. They are not synthesized in our body. We have to take from outside. ALA, EPA, and DHA. N6 again are a good thing, but we require less omega-6, more of the omega-3 fatty acids. And the important thing is the trans fatty acids. Yes, this is the most dangerous fat for our body. Trans fatty acids. Most atherogenic molecule in the world is the trans fatty acids. Please go away, like chips and all these things. Trans fatty acids are not good for our cardiovascular health, for our diabetes and obesity. So dear friends, all types of fats are okay. Yes, some fats are unhealthy, because I told you about just now the trans fats. They are very, very inflammatory, and these hydrogenated vegetable oils present in the chips and other things are very dangerous. Some fats are healthy, like I told you, just like omega-3 fatty acids. 2 things I want to tell you, and I'll end here, that refining, how refining was bad or is bad. It depletes most of your nutrients. It is a source of oxygen-free radicals, and more of the trans fatty acids are there when the refining of the fats are there, and your size of lipoprotein A increases, and it decreases the insulin secretion. So refining is not always good. Second thing, which is very common, so many ladies are here, and frying food. Why the frying food? Especially the frying, refrying. जो हमारे खोमचे वाले हैं, they keep something and they refry, and they give you the hot things. They are very, very bad things. Why they are bad things? Because the reheat of oil is not good. It is and reuse of oil. रात को बच गया और सुबह उठ के वापस आपने उसके ऊपर बना लिया. That is very, very bad. So what it does, actually, the grains which remains in the your oil, and when you reheat and reuse that oil, what happens? It converts into VDP, that is volatile decomposition products, very, very dangerous. And second, some chemical like acrolein develops. So it is not a good idea. Take in a non-frying that pans and that non-sticky pans, they are good. Don't reheat or reuse of the oil as far as possible and they cause colon irritation. And some studies are there which causes a colon cancer also, which people are taking too much of these refried and reheat of the oil is there. Your brain is about 60% of fat. We need good fat for our body, and this is one of the things study done, and which says that the different types of fat and the and the mortality. And if you see here, trans fat is the most dangerous when you are taking, and most mortality is by the trans fats, then saturated fats, then monounsaturated fats, and polyunsaturated fats are very safe, very good for our body's health. And I'll not go into the details of this, but this again reiterates, and this evidence is that the dietary fats, especially the omega-3 fatty acids and omega-6 to omega-3 ratios are very, very good for our not only type 2 diabetes, but also for the hypertension and cardiovascular health. So some fats are good and some fats are bad. There is consensus, and this consensus is there with most of the nutritionists and most of the endocrinologists and diabetologists, that replacement of the saturated fat with naturally occurring unsaturated fat is good idea. Then the industrial produced trans fats are the most harmful substances. The metabolism saturated fat may differ from carbohydrate restricted diets. That is what we have discussed since morning. People with insulin resistant hypersecretion of the insulin glucose intolerance may benefit from a lower carbohydrate and high fat diet. So not all the people, but some people will be benefited with this type of diet. Ketogenic diet I don't want to take, and there are certain controversies. The controversies are there, and there are some controversies are clear, but still certain facts are there, and because of these controversies, they are actually fat were given the bad name. So to conclude my talk here, very clearly what we have learned in last 15-20 minutes is the optimal proportion of carbohydrate to fat sorry, in the diet for obesity treatment and chronic, all the chronic diseases are very, very important. So it is how to balance the carbohydrate, fats, and proteins. That is the most important thing. That is the design. And what Dr. Nitin Patkar has told very clearly, it is a personalized thing. So it cannot be generalized thing I can give, nobody can give. Given the enormous human and economic toll of the diet-related disease, high-quality research actually is needed, is still needed for the clearance of certain facts. Of course, current evidence indicates that no specific carbohydrate to fat ratio is the diet is the best. You have to design your carbohydrate to fat according to the persons, the persons you are treating, whether person is normal weight, obese, or the lean weight. So depending on all these things, you have to personalize your fat. So always think of good fat and bad fat. And the ratio is important. I told you omega-6 to omega-3. I think I'll not give into the details, but the certain oils like mustard oil is the good oil for cooking oil because their ratio of omega-6 to omega-3 is is 1.5:1, which is less than 4:1, which is the healthier ratio. And your certain sunflower oil and some other oils are having 150 to 160:1. Which is not a good thing. So what the nutritionists these days say, go with the modest thing, means moderate path. Blend your oils on a regular basis. That is the best idea. Thank you very much for patience.
Thank you so much, sir, for that very holistic talk. We have time for a couple of questions.
Yeah, just.
Actually, regarding frying, you showed the ghee is intermediate. But suppose we do not fry the ghee, we can also take in the, suppose in the pulses or in other ways, we can take the ghee. So what is the current thinking of the science about the ghee? Because in Ayurveda, they have told that the ghee is the nectar. But in our Indian tradition, still there is lots of confusion regarding the ghee. Can you explain that?
Yeah. This is there in the slide. Actually, I was going a little faster. But if you see here, 3 things are important for the cooking. One is a smoking point. One is a temperature for frying. So these 2 things are important for any fat. So whenever you are actually having the which type of cooking fat you want, so smoking point. For the ghee, it is the intermediate. So that's why I mean, it is not a good idea to have the frying or deep frying by the ghee. Certain vegetable oils are good for the deep frying because of their smoking point. And butter and coconut oil, absolutely not good for the frying or deep frying. So because of, again, the smoking point and temperature, so I mean, because they have the butter and coconut oil is a low smoking point, they are not a good source for frying.
Suppose I don't
Yeah.
fry the butter, then I can take the butter or not?
No dose.
You can take, but the only thing is that that cannot be used for a frying.
Same for the ghee.
Yes, same for the ghee. It is intermediate. So it is the
Ghee also contains omega-3 fatty acids.
yes. So what is the cow's milk, cow's ghees and buffalo's ghee? You will be surprised to know the omega-6, omega-3 ratio is less than 4 and less than 3. Which is, I mean, not very bad. So that's why our ancestors used to take ghee, but they were walking, they were having good physical activity. That is the point. So that is the important thing. So now one thing which जो मैं अपने patients को बताता हूँ कि what is the daily requirement of the person. For an adult, it is 3 teaspoonful or 15 grams per person per day, or half a kilo per person per month, or if you have 4 persons in the house, bring only 2 kilos of total fat. That will never be harmful. That is for sure.
Good to have talk about food. We become what we eat. But we are very good in choosing DPP-4 inhibitors and statins. But in oil, why don't, maybe oil and the other thing is glucometers. There are 2 things in diabetes. Why don't we bring these people who have, maybe in Chennai, we talk about insulin pump, we talk in length. Maybe this is the thing which we will, give credibility to whoever talks about diabetes.
Yes.
Thanks.
Thank you.
Sir,
Thank
I would like to add regarding your query, sir, about ghee. I'm a clinical nutritionist working, I was working with Chellaram Hospital. Now I have practiced my own practice. The thing about ghee is, previously it used to be prepared with a traditional and very authentic method, that is very important.
Bilona
because-
wala.
Exactly. The churning, when we set the curd of that cream, and then we churn it very well, and then we may take out ghee out of that. So that gives very medical effect to that. And as sir said, saturated fat is also important. Ghee comes in butyric acid. So when you do it in very traditional method, then only it is useful. But nowadays, many people or maximum people use the ready-made ghee. So we are not assured about the quality of ghee we are using. Absolutely. So that's the main thing we have to concern when we are advising our patients to eat ghee. I mean, ghee is not a bad thing because if you are having in a good way. Yeah. Thank you.
Just like the McDonald's, they come to India. I think we could as a medicinal property.
Can be, sir. Thank you so much, sir, for your wonderful session. Yeah.
Yeah. Yeah.
Okay. Good afternoon, sir.
youngsters को पूछना चाहिए questions. Right. Good.
Yeah, good afternoon, sir. Thank you for the wonderful session, first of all. Now, regarding the same thing what ma'am was talking, we now have a lot of cold-pressed oils which is coming up. So the cold-pressed oils, since it is not refined, they say it is definitely better, which I agree to. And they also claim that they have a high smoking point, so it can be reused. So what is your take on that, sir?
Yeah, the answer for your query is there are no long-term studies done scientifically on different types of oils, especially cold-pressed oil. There are certain virgin oil, different types of oils. So there are basically no scientific studies are done, and as on today, no published sort of thing. So they are all evidence 3 and evidence 4. So they are not even, so some people say the virgin oil is the best oil. I mean, there are no data for that. There are certain isolated data, isolated studies are there. और अब आप लोगों को करिए आप लोग. You start the studies on this particular aspects and show to the world that what is good and what is bad.
Yes, sir. Thank you.
All these vegetable oil are very, very expensive. And India is facing a crisis. One has to be very, that is why we need, next time we bring a exhibition for oils.
Yeah. अरे भाई हाँ yes आप कमेंट करना है Yeah.
Because when there is cold pressing, there are a lot of polyphenols which are preserved. And that is why virgin oils are used. So EVO, extra virgin olive oil in all your pediatric trial is essentially for the other nutrients in it, which gets spoiled when you heat it. And hence you use virgin oil for salad dressing, or even when you store it, you have to refrigerate it and not store it near your gas. So typically, oil is kept next to the gas, right? So try not to do. If you are investing in virgin, keep it in refrigerator, because the Mediterranean temperature, ambient temperature is 17 Celsius. Ambient temperature of tuna is 40 Celsius. So it doesn't work that. It doesn't matter. Whichever oil you take, the seeds will have polyphenols, which are very, very beneficial. And you buy virgin oil for the polyphenols, not for, I mean, you do buy for fatty acid structure, but typically for polyphenols.
Yeah.
Like we see, people are inflating sunflower, whereas they have more percentage of polyunsaturated fatty acids than olive oil. So instead of running behind olive oil and following the best, why can't we stick to our roots of using sunflower?
Mustard oil. Mustard oil, yes. That's why I told just now, our omega-6, omega-3 ratio of mustard oil is 1.5:1, while the sunflower oil is the 150 to 160:1. But yes, there are omega-6 fatty acids are there, and they are also important. So, I mean, we are not just keeping everything aside on one thing. So, go with the moderate part I told you. You have to blend in your, like हमारे ancestors करते थे. Some vegetables were cooked in mustard oil only, and some vegetables used to cook in other oils. So that was the actually good thing our ancestors knew very well. दादी और हमारी जो नानी थी वो जानती थी. But unfortunately for us, we don't use this type of blending in our day-to-day cooking. Thank you. Yes. Yeah, that is the different thing, because erucic acid is not a good thing. वो उसके अंदर क्या होता है, जब mustard seed आता है ना, वहाँ पे राई जो बनता है, वहाँ पे कुछ दूसरे आ जाते हैं, and that actually causes the erucic acid. This is not the thing. So हमारे यहाँ पे filtered oil ले लीजिए, not the refined oil. Filtered oils are good for our health, not the refined oil. That is the point.
Thank you so much, sir, for a wonderful session. I would request Dr. Chawla to present a small gift.
Thank you very much. This session was from my heart. Thank you. Thank you.
Before we have the next topic, I would just like to make one small announcement. After the next talk, we'll be breaking for lunch, but during the lunch hour, between 1 to 1:45, we will have open mic in the courtyard. So open mic is open only to delegates, and they have 5 to 7 minutes. There are rules in your brochure, and you can speak with or without slides as you wish. In the center over there, you have to register on the spot. So that is so you can grab a quick lunch and go and join there, or do that first and then maybe come and have lunch. So do come for the open mic.
So moving to the last session of this phase 1 of day 1, I would like to invite Dr. Shashank Shaha. He's a director at Lapro Obesigo Center, Pune. He is also attached with renowned hospitals like Hinduja and Lilavati hospitals in Mumbai. He has multiple publications and presentations in national and international journals. He had awarded with multiple honors like Vivian Fonseca Scholar Award by American Diabetes Association. He has also multiple records in World Book, Limca Book, and India Book records, like highest weight loss in the heaviest Indian woman, surgery on heaviest woman, maximum weight loss after bariatric surgery. He has done 45 hernia surgeries in just 10 hours and published. It has been published by Limca Book of World Record, IFSO Award of Appreciation for Great Contribution to the Growth of Federation. I would like to also mention that Dr. Shashank Shah is the first surgeon to have his biography printed in the Obesity Surgery Journal of the International Federation of Obesity Surgery. So welcome, Dr. Shah, and eager for your next session.
Thank you for the kind introduction, and I must thank Dr. Neeta, Dr. Sanjay, Dr. Anjali, and the organizer for inviting me again, and I enjoy every meeting of this. My slides are here. Quickly rushing through here, I must say that it is almost now 20 years, 20th year of bariatric surgery. So we are already in the long-term care, and the long-term care is very different from primary care, and I would focus something more on a different aspect of long-term care. These are guidelines of bariatric surgery for diabetes, but by and large, if you look at the IRDAI and the insurance guidelines, BMI more than 35. Yes. Perfect. For BMI more than 35, the insurance covers, and the good news is today now, all bariatric surgeries for patients with BMI more than 35 are covered. Now, why talk about long-term care? Can I have this? This is not working. Okay. So if you look at long-term outcomes of bariatric surgery, everyone's dream is patients should undergo one bariatric surgery and it should work for lifetime. But the aggressive procedures can give more long-term nutrition and other consequences. So a balance between these is required, and in today's era, probably pharmacotherapy is the solution which can improve long-term outcomes. Even though in this presentation, I am not going to focus on pharmacotherapy because it is everywhere in the conference, but I'll give you some other aspects. The main aim of long-term care is maintenance of weight loss, remission of associated diseases, maintaining the quality of life, nutritional status, and the psychological status. And it is a sustained process all throughout the life. We have to follow it because it's a lifetime disease. As we all know, obesity is a complex multifactorial disease, and we have to treat it for life. With the natural history, there is physiological weight gain, I would say regain. That is because as age advances, metabolic rate slows down. There is adaptation of the body. Hunger gets readapted after bariatric surgery because of various stimuli, right from the compensation of central control to hedonic and environmental psychological factors, and patient does feel like eating, and I wouldn't blame the patient. Multiple attempts of lifestyle interventions may not only work, there is something more needed for that. Now, in the long-term care, it is not only care of the patient, it is also care of the procedure, which I will elaborate because it will be something different for you. There are different types of procedure. In the care of the patient, we need a physician, diabetologist, endocrinologist for metabolic control, nutritional control, and also psychologist for better psychological control. One of the mediums which is used for this is pre-operative counseling in a group and post-operative follow-up in a group again, which can be now digital, and the digital support groups are picking up. Patients participate, explain their apprehensions, and intervention can be suggested. Now, because this is a diabetes conference, I must say, over maybe last 18-20 years, we have done more than 10,000 procedures, more than 4,500 with diabetes. Of course, there is relapse of 18% at 5 years, almost 35% at 10 years. Of course, they are easy to control on OHA because their diet still remains controlled. But a second stage procedure can add re-remission in almost 6% patients. I am not touching it. I am not touching it. So the predictors of those who would relapse is those who have delayed decision for surgery, those who have diabetes duration for more than 10 years, low C-peptide, or BMI more than 50. Relapse most often correlates with weight gain. You want me to hold it? Relapse most often correlates with weight gain. In the long-term care, prevention of significant weight gain is probably most important. This is also not working. So bariatric surgery plus pharmacotherapy probably is the newer norm for long-term care. In so many years, we started with topiramate, SGLT2 inhibitors, and then GLP-1 analogs, and we have some newer molecules to play. Now, when do we initiate pharmacotherapy? Generally, the trend is to initiate once the patient regains significant amount of weight, but early initiation of weight loss is important, and early initiation of pharmacotherapy. The moment the patient starts saying that he is hungry, he's eating more, his behavior after bariatric surgery is changed, that would be probably the right time to start pharmacotherapy and not necessarily wait for weight regain, because once there is significant weight regain, even pharmacotherapy becomes less effective. Some of the clinical conditions where we would start it immediately at the end of 1 year is BMI more than 50, familial tendency, diabetes duration more than 10 years. For such people, even though they have achieved optimal weight loss, for long-term maintenance, we initiate at least small dose of pharmacotherapy at that point, and probably this is a new take home. Care of the procedure is also extremely important, and I must say, you all must have heard that the stomach is converted into a small pouch or a vertical long tube, or anastomosis is done. Volume at a time which the patient consumes is something which is necessary for care of the patient. Patient can eat more frequently because stomach is elastic, there is natural dilatation. Once the stomach dilates, it stretches the anastomosis of stoma between the jejunum, and the effect of an hourglass restriction disappears. Over years, small bowel adapts. And the simple example is, I have treated many road traffic accidents in my earlier years and removed almost 70-80% of small bowel for gangrene resection, and all of them are maintaining their weight. Some of them have diabetes, high cholesterol. That means their intestines have adapted, grown, and they have learned to reabsorb. And that is what happens in the natural history of disease, and that is how we see weight regain, and we need to work on that. For those who wait for surgical decision beyond a BMI of 50, I still see patients with 150, 200, 220, extremely delayed decision. Single bariatric procedure would get their BMI down to almost 28 to 32, which is still not ideal. And over years, either there is weight regain, or we call this BMI of 32 still inadequate weight loss. And these patients can have very early initiation of pharmacotherapy. Of course, in some, it is known that in super obese or those with BMI more than 50, pharmacotherapy still remains ineffective because there are pressure-related mechanical effects. Even though they lose 10%, 15%, and they have very good cardiac benefit, their knee joints, spine still need more significant weight loss. Their sexual function, psychological improvement needs more weight loss, and these patients can have a second stage procedure. I'll give you an example of a lady. This was my picture, probably presented almost 15 years back. She, after surgery, she conceived once, twice, regained weight, the kids have grown, and after 15 years, we have offered her second stage procedure, and this is after the second stage procedure. This is how she was after 2 deliveries. So, carrying the progression of bariatric surgery, primary bariatric surgery, pharmacotherapy, achieve their goals, maybe getting married, conceive, maybe prevent joint replacement, have joint replacement, and once they plateau, we continue with pharmacotherapy, and anytime needed, a second stage procedure can give them the same chance which the primary procedure gives. Second stage procedure is not necessarily a failure. It is progression of a disease, and for any disease, whether it is arthroscopy, re-arthroscopy, re-surgery, replacement, they are stage procedures and stage treatment and not failure of treatment. Another example of the best long-term care is the lady who gave us the World Book of Records. She lost 215 kilograms in 5 years. So the record was itself at the end of 5 years. This is how the lady was, almost 5 feet diameter. And you can see her 7 years after surgery. She underwent primary surgery, second stage surgery at the end of 3 years. Then she was on injectable liraglutide for 2 years, and today she is maintaining on semaglutide. So the best care is nutritional care, psychological support, and pharmacotherapy. That has given us probably the world record, and it's not bariatric surgery alone, and that is probably the newer norm. This is another boy. Initially surgery worked well, then he had slight weight regain, and then pharmacotherapy has maintained his weight loss. He could maintain for many years only on topiramate and maybe sometimes once a week dulaglutide. Only when he is traveling, he has parties, he has stress. Intermittent pharmacotherapy has maintained his weight loss. And this is another lady where diabetes remission is continued with initiation of pharmacotherapy in spite of having a near normal A1C, but we found that her hunger started increasing, volume of food started increasing, and we thought of care of the procedure, and that is how pharmacotherapy was initiated in time. What does a second stage bariatric surgery offer? It improves restriction, that means the amount of food consumed at a time, and satiety, because of hormonal as well as mechanical control of hunger and increased satiety through central mechanisms. Stronger malabsorption. As we know that fat is important, but most of these patients don't eat healthy fat, and therefore fat malabsorption is required. There is improved hormonal effect to compensate intestinal adaptation, and all these are incretinomimetic. And that is how a second bariatric procedure is also a standard of care when needed and should be offered. The second stage procedure for long-term improvement for a sleeve gastrectomy, you can trim the dilated sleeve, you can attach intestines, but there are newer, very interesting designs which we are working on. These procedures only add hormonal and metabolic actions without malabsorption. I will explain that interesting part in the next slide. In a gastric bypass, probably you reduce the dilated part of the stomach, you narrow the outlet so food doesn't rush very early. If the pouch empties very rapidly with a dilated anastomosis, patient can eat larger amounts. And that is why this intervention is done, and increase malabsorption or maybe reduce the length of the limb available for total absorption. Now this is the procedure which is picking up. This is called single anastomosis sleeve jejunal bypass. You can see here food can pass through the duodenum and normal passage. This is what will offer complete normal absorption and prevent any micronutrient malabsorption. However, the small anastomosis will allow rapid transit of food into terminal ileum, thereby stimulating GLP-1, PYY, reduce oxytocin and offer the metabolic benefits. So metabolic benefits without malabsorption probably would be the future of bariatric surgery, and the procedures are evolving in the same direction. The alternatives to second stage are early pharmacotherapy, sometimes endoscopic interventions which are still evolving, addition of band, which I don't like, but it's some mechanical strangulation of the neck of the stomach. But all therapies together probably is the best norm. Start pharmacotherapy, add bariatric surgery, continue with pharmacotherapy. If required, a second stage bariatric procedure followed by pharmacotherapy. This is probably the long-term norm. I am not focusing more on nutritional care because it is extremely standardized. It is just after any gastrectomy for whatever indication, ulcer, tumor, malignancy. Once a year evaluation is necessary, but it is very important to understand that deficiencies can contribute to weight regain. So deficiency correction is extremely important. Correction with injectable therapy when indicated. Whenever we have a malabsorptive procedure, at the end of 5 years, we have a protocol to offer entire injectable supervised nutritional correction, including trace elements, micronutrients, and we find that patients do well with that. So, long-term care, for the long-term care, bariatric surgery and pharmacotherapy should go hand in hand, and that is probably the best way to offer long-term care. Bariatric surgery, pharmacotherapy, psychological support, counseling, lifestyle change, if required, another procedure, and being aware that it's a lifetime disease. You can still enjoy, eat, but you need to follow standard norms. Thank you so much.
Thank you, Dr. Shashank Shah.
Yes.
Any queries?
Any lunatic talks are just my question in future, as lots of endoscopic bariatric procedures are now coming up. So do you think that the day is coming when there will be no role of surgeon like you, or all physicians can do the endoscopic bariatric
Very
procedures?
interesting question. And we have this debate in every World Congress. And I must tell you, first endoscopic gastric bypass, that is a duodenojejunal sleeve, which we talk about, first in human was introduced when I went for my bariatric training in 2003. That is the first time when I saw first in, and it is 2022, we are still evolving. Of course, it will evolve, but even after we resect the stomach and cut it into a small pouch, it dilates over time. If you don't resect, the results of endoscopic therapy are probably almost at par with pharmacotherapy. So if we have pharmacotherapy, probably we use pharmacotherapy instead of endoscopic therapy, but endoscopic treatment plus pharmacotherapy can be better. Robotic interventions, more of magnetic anastomosis will happen, and in future, the same therapy probably could be offered for some patients endoscopically, where even we are waiting for the future, but there are multiple limitations in clinical trial. It is, at this moment, it is still at infancy. The results last for 6 to 8 months only.
We hope that only competent surgeons could treat this, because diabetes anybody can treat. That is the scenario today. The question is about the long-term. There is some pharmacokinetic drugs. So is it even post-operative whether the surgeons can manage, or is it teamwork, or that's maybe incorporate it's possible. The other two is contraindication. There are, because in the West, I think that a psychiatrist or psychologist should be part of the, because sometimes, even after sometimes the surgery worsens the condition. I'm not here to contradict, but so how do you choose? Because in the corporate, it's, okay?
Interesting question. So first, for the first answer is, we have a very good training facility now in India, and the Obesity Surgery Society has protocol for training, and I am on the board of DNB, and we have started bariatric surgery as a super specialty, which will get started in a month's time. So that qualification is taken care of. The second one is psychologist and all other specialists. So this is a multidisciplinary team approach only. Our center is Center of Excellence from the American Society, the Indian Society, and the minimum requirement is nutritionist, one more bariatric surgeon, bariatric physician, endocrinologist, and a psychologist. Every patient is screened by a psychologist. However, we have patients who were on psychiatric medications, who were on intractable disease, but more than 160 kg, unable to take care of themselves. We still cannot refuse them. They can be treated in centers of excellence with a psychologist, psychiatrist for supervision.
We are going to change the diabetes. It's going to become an operable gastrointestinal problem, not endocrine problem.
Any further questions?
Sir.
The new procedure that you have shown, are we not creating a blind loop and giving rise to setting a stage for bacterial overgrowth?
Can I have that slide? Can I have my slides again? Very good question, sir. So in all other procedures, Survenwai, bypass, whatever, there is no blind loop because it is working. But in this procedure, can I have my slides again? Yes, so let me go to that procedure itself. So here, if you see, food comes from the stomach, goes into the duodenum and moves down. So there is no blind loop because it is normal passage of food, and this is a small anastomosis from where food goes into the intestine this way. So entire intestinal passage is used either way. There are two pathways for food. Because this is smaller, only a 20% flux is expected to just achieve the stimulation effect to stimulate the incretins. And this is probably the normal passage where complete absorption can occur. So the benefit of this procedure is there is no blind loop. This is laparoscopically take care.
Because you are dealing a regain of weight after a metabolic
So
procedure.
this diameter is never big. It is smaller than the diameter of intestine because we don't want all the food to travel this way. Most of the food passes through the pylorus, and the effect of restriction or satiety is achieved hormonally and not by mechanical effect. Even this sleeve gastrectomy can be of larger size, but the patient feels full early. Just like how some people who maintain this, like you, maintain their weight for years, they eat very little and they have satiety.
Yeah, I agree. Can this be done by semaglutide orally now?
I just hope that. But I must tell you, they do work. They do give good results. But when we want still results beyond 15 to 20%, this can be offered because almost 70 to 80% excess weight loss, and then we use semaglutide for maintenance.
Condom-like devices, just like semaglutide.
Yes.
Semaglutide is very, very expensive. That's being aggressively promoted. How about condom-like devices?
Any devices are going to evolve, but it is going to take some time for clinical trials, FDA approval, and long-term benefits. Thank you, sir.
Thank you so much. And a very big hand of applause for the audience as well. We come to the end of our nodal update. Thank you, Dr. Shah. And may I request my co-chair to hand over the memento. And you read just in time. I was
Hello.
just catching up on
I request Rucha ma'am and hello. Arvind Gupta sir and Rucha ma'am to present memento to our chairperson. PM.
all are very, talking about diabetes and getting active and, exercise, diet and things like that. But I'm sure after this sumptuous lunch that you just had, you must be just, entering the snooze zone. So just to waken you all up, we bring to you something called as the activity break, or we call it the energizers. So some instructions for you. You would need to stand right now, okay, and just leave all your, anything that you have in your hand, your mobiles, pens, books, just leave it on the desk. Keep yourself free. Keep yourself free. Yeah, push the chair a little behind. You can even come out of your desk if you want, there's a lot of space around. Yeah, wonderful. And we are going to do this with a smile. Nothing very difficult, you can follow me. So you are going to sing along with me and also do some actions, okay? So you are just going to mimic me. So I'm going to do something called as the, something very healthy, okay? We are going to make a fruit salad, okay? It's called the Peel the Banana song, okay? Since we are all, health conscious people. The song goes like this, okay? And you will follow, let's just try how this goes, okay? So it goes, form, 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 banana. Can you do it? Yeah, relax. Don't feel shy. We are only talking about bananas, apples, oranges. Nice, with a smile, okay? And nice. So every time I do this, you will repeat the action and the song, both together. Yes. So let's do this. Okay, you're ready? Yeah, wonderful. Okay, so here we go. Form, 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 banana. Peel, 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 banana. Eat, 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 banana. Form, form, form an apple. Slice, slice, slice an apple. Eat, eat, eat an apple. Form, form, form an orange. Peel, peel, peel an orange. Squeeze, squeeze, squeeze an orange. Form, form, form potato. Form, form, form potato. Peel, peel, peel potato. Mash, mash, mash potato. Form, form, form a corn. Form, form, form a corn. Shuck, shuck, shuck the corn. Shuck, shuck, shuck the corn. Okay, now pop, pop, pop the corn. Pop, pop, pop the corn. Form, form, form banana. Form, form, form banana. Peel, peel, peel banana. Peel, peel, peel banana. Go, go, go banana. Come on, go, go, go banana. Okay, thank you so much. You all were so wonderful crowd. Thank you. Thank you.
Okay, hope you all enjoyed the song. So we are heading to our next session. I will request Dr. Tejas Limaye, Shilpa Shirore, and Prachi Surve, ma'am, to come on dais.
Good afternoon. Am I audible? I mean, I can't, you can hear me, right? Yeah. Good afternoon, everyone. And welcome to a beautiful session post-lunch. It is going to be a marathon with various different topics and excellent, eminent speakers that we've got together today. So before taking much of your time, because the time that we are going to be giving to the speakers is really less. So I will not take a lot of time. The first topic that we have today, under the fact check. Now, fact check symposium, if you see, there are a whole lot of topics that we've clubbed together. And the first one is new evidence on precision nutrition by Geeta Dharmatti. Yes, Geeta Dharmatti is the past president of the Indian Dietetic Association Pune chapter. She is also the National Executive Committee member of the Indian Dietetic Association. She is a gold medalist, a PhD holder. She is a member, or rather has membership to different prestigious organizations like the IDEC, the NSI, Indian Society for Parental and Enteral Nutrition. She has published many articles. She is very humble. She's from there pointing out that don't. A very good friend of mine, and I would like to welcome Geeta. The stage is yours.
Thank you so much. At the outset, thank you, the organizing team, Shilpa Joshi, Anjali Bhatt, Neeta Deshpande. It is wonderful to be here and appreciate your efforts to put so many nutrition themes and topics together, because what we are today is something where I think we are connecting food with us. 7 minutes may not be enough for me to talk about precision nutrition, because, can I have my slide on, please? Yeah, because it is a topic by itself. It's a topic which actually will trigger your mind thinking something different. I always believed, friends, and I still feel that most of us also do, that food is information. Food is connect, food is social, food is happiness. And in such a fact, where we dietitians talk about macros, microns, calculations, somewhere you have your patients telling you that I want to eat to my satisfaction. I want to enjoy what I feed, but I want my body, my mind to help me to learn what I want to eat. So definitely there's something else which we have in us, which may be not so mechanical with the food. So why don't we start looking food as an information and start thinking about something which is called as precision nutrition. Before we get into precision nutrition, I'll just introduce few terms. Because for me, as I was doing nutrigenomics, I started now looking food into molecular based. Food for me now became as food bioactive components. Food became an information for my body, and the dietary components of the food has to have some root, mechanism, and behavior with me. That's why I said 7 minutes is not enough for me to talk about such a wonderful relationship which we share with food. I'm sure the audience agrees with me. So now we've evolved from dietetics, specialized dietetics, to something called as personalized nutrition. And we have A, B, C, D, which we generally do, the anthropometry, biochemical, dietary. Now we have environment, and next we have genetics. So now we have A, B, C, D, E, and G, and this is something which is personalized nutrition. Next we look this as precision. Now, precision is the equation of the food with me. How does a curcumin behave with me? How does a polyphenol behave with me? and how do I behave with it? I think it's such a beautiful symbiotic relation which we are trying to explore. And hence the terms nutrigenetic also talks about personalized nutrition for the response of my body, the phenotype response to a specific diet, and nutrigenomics is the response of the individual genes to nutrients. And we cannot forget the role of environment here. We are born with a set of genes. We always relate it. My mother liked it, so I like this. It runs in my family. We speak so much about it, and I'm sure each of us patients who come to us, diabetes in my genes, obesity in my genes, we fail to identify exposomes, environment, and we always easy to find the blame on genetics. That's 10%. But I think we are ushering ourselves into a newer way of looking ourselves, which is integrated systems biology. A different way of looking at food and body. Today, as I said, I'll sensitize you. So personalized to precision. Personalized, we talked about all the environmental factors. Precision is one step ahead. My gut microbiome, my food-gene interaction, my dietary patterns behavior with me. And I think this needs a lot of technology integration to help me understand what works for a set of population. We are still into an individualized way of looking at it. We started with community nutrition. We are now into personalized nutrition. We are pushing ourselves with the help of genetics to a precision nutrition. And now we want to understand the diet gene role, the diet expressions, the epigenetics. So this is all giving us a newer way of looking at molecules, which is omics, genomics, proteomics, metabolomics, all transcriptomics. So we are ushering ourselves into omics. And I'm sure most of the audience here is dietetics or nutrition background, but I want all of you to start learning the physiology behind the scene. When I eat a meal, what happens to the meal after it gets digested? Absorbed, assimilated, bioactive components, culture of the food which it comes with, the combination meals, because it is not so easy. The equation of the food is different for all of us because, as you know, satiety is different. In a house, one meal is cooked for all. We have a similar meal cooked for all the family. There's no different meal cooked. But then each one of us perceive that meal in a different way. If my son doesn't like that vegetable, my daughter may eat it with happiness. The happiness connect with the meal. And in Marathi, we are in Pune, we say that angi lagta. So that's something we are trying to understand. What is in my body which helps me to connect with that food? The molecular targets of that particular in my health is something which I need to understand. And we are actually more into prevention and wellness. Few evidence, few thought process where we already know the role of food and genes. We've talked about gluten, we talked about caffeine, we talked about saturated fat. We know lactose. These are genes which are studied. These are all into designer diets now, where it is done to understand how does that coffee behave with me. So fair enough, I know that caffeine is not very good for me. If I consume in a larger quantity, then I have genes to tell me. But now I'm integrating all this. I want to know my soil health. I want to know my food. I want to know my genes. And one step ahead, I want to understand my gut microbiota. Complicated it sounds. And there is no one answer for it because this is so, so different. Each one of us is different. So we are now in precision nutrition talking about metabolomics. Metabolomics, to make you understand in this slide, is the last part of the slide after genome, transcriptome, proteome, is the metabolome, where you know that the molecules of food, the amino acids, the functional foods, the lipids, the fatty acids, how do they behave at my molecular level? How does that food behave with me? That's metabolomics. And maybe now going ahead, I'm looking metabolomics as a key tool to investigate the effect of food on my health. I have to start looking at identifying food-derived biomarkers. In my practice, I started looking at the person's interview method where I ask, do you feel this suits you? The person say, no, haldi milk is very well taken by my wife, but when I have it, I feel some gastric. Maybe it's a pinch of haldi. But then the person says, I'm not comfortable with that food. That means at a biomolecular level, the response of your molecules towards that food is not very good, positive. So it's not just hormone, enzyme, 1 + 1, 2. No, it's not that. It is very much in a research stage to prove it, but we have to start looking at it and integrate it. Few research which have been promoted are in the area where you have Fruvedomics study, you can look into it, where it was a three-way of looking 38 participants where they picked up fruit and vegetable group, low carb group, and low fat group. They tried to look into the bioactive components of fruits and vegetables, management of behavior therapy. The behavior, because what's now more important is neuroscience, cognitive development. And we want to know how my mind behaves so differently with food. I want to learn, if I'm in Pune, I have to eat sabudana vada pav in the season. Why specific food? Why we get attracted to sweet, somebody gets attracted to salty foods. So yes, there is an evidence at a molecular level which tells me that at my gut microbiota, there are changes. The behavior management with this Fruvedomics study, you can explore the study. I don't have so much of time to talk about it. The role of fiber in diabetic management. And the last study is very interesting, friends, where it was mapped, the meal pattern, because there's so much talked about intermittent fasting, 2 meal, 3 meal. It was mapped, the algorithm was created to understand what suits a particular individual. And the trend of dietary pattern, and it proved to be beneficial when the technology helps me, the artificial intelligence helps me to understand what is the time of the meal. So interesting congress was held as gut microbiome in Precision Nutrition in USA, Washington. So this interesting congress, which I found was recent in 2022 March, it was held. It was role of gut microbiome. We talked about metabolomics. I want all of you to understand, explore at a molecular metabolite level what happens. The next is to learn about the role of gut microbiome. It was interesting where one of the statements there I found should be highlighted. Nutrition label is for nutrition education. It is a literacy where it tells you what it has, but I don't know how the ingredients will behave with me. It can be toxic. So this was what the Gut Microbiome Congress tried to tell us. Do you want me to wait? माइक दे दो. It did say a few things, interesting things, which I would like to say that the slides will keep coming. After any infection management, where you are on drugs, it can be an antiviral drugs or antibiotics, whatever, body takes 30 days to overcome the dysbiosis it has had with that particular antibiotic. So 30 days of span I am giving to my body to work on dysbiosis. So that was a very important statement which I felt we should be highlighted. Circadian rhythm and gut microbiome. These two in a personalized health. Circadian rhythm is coming into a new way we call it as chrononutrition. Circadian rhythm is something we have to start looking at, the management. There's a clock gene which tells us. But then the food intake, it's not there. So I think we are far now from understanding, going ahead, evolving ourselves to talk about what is suiting me. And I think individual response does tell me what suits me. It was highlighted now that now we map. We map genes, we map food biology, we map soil health. We map soil health. We map all this and combine into integrative systems biology. I think now the next era of nutrition or diet charts in precision nutrition will have a trends which tells me what I should be eating according to my body, food and my interaction. It's a trend, it's an evolution where my technology helps me to learn because I think there's a lot of disturbance, so I'll wait for, can I wait Thank you. Again gone. Should I use this instead of touching? So it talked about multi-layered omics approaches. Maybe this is too much for a 7-minute session, but somewhere I want to tell you, it has gone again. Somewhere I want to tell you that you have to start looking at host, gut microbiome, and food. These three interrelation. We call it as diet gene expression. We need to optimize the therapy depending upon what the food talks to me, what my body is actually behaving with food, and finally, how my genetics are predisposed. In today, what we are doing in personalized or precision is identifying the food if it suits me or not, lactose, glucose. In PKU diets, we do. And in NCD, non-communicable diseases, we talk about metabolites, dietary pattern, keto diets, intermittent fasting. What suits me, definitely a genetic report can tell me. Circadian rhythm. But end of the day, I'm still into an individual way of looking at it. A personalized diet, anyway I was giving as a dietitian, I've integrated genetics into it. I was already identifying environment. Now I think I need to bring in artificial intelligence, data analytics. A precision nutrition has to evolve from soil to fork, which we've been talking about. And I think this is where we need to work on prevention and wellness. So friends, we have to start looking differently to our nutrition prescription. To the young dietitians here, stop counting food, 1 chapati or 2 chapatis. I mean, of course, you have to do that as a calorie management. But 2 chapatis, look at how the body behaves with it. If the satiety says, I can't go beyond 2 chapatis, you need to identify how do I give the satiety to the overall area. So there is a human behavior with the food which needs to be interpreted. And I think a detailed screening, A, B, C, D, E, and G, if you can afford. G is somewhere counts to affordability. And now I think the T technology will take over our diet prescriptions. I don't think the way that we are moving, it's very fast. So I hope in 7 minutes I was able, I don't know 7 or more than that, but I was able to give you a brief way of looking at what a metabolomics and precision nutrition with gene diet expression is all about. Thank you so much for the patient hearing.
Excellent presentation, Geeta. And I think any topic which is new always has some or the other hurdles, which we need to cross. So we came to know a new topic today about precision nutrition, and then there were a lot of technical glitches also that we had to face. So this is something which will always happen, and we come to know something new. Now coming to the next,
One announcement is there. The session in B are started right now.
Geeta, could we have you on the stage for felicitation? I would request Dr. Tejas Limai to thank Geeta for her excellent presentation. Now coming to the next topic, there are so many new products which are coming, new cereals, and give me some time to introduce you. Yeah. So the next topic that we have is on oats, muesli, cornflakes, and quinoa. What do we actually tell our patients? Could I have her, Cheryl's introductory slide, please? Cheryl is a registered dietitian. She's also a humble individual. She's also pointing from there that don't say a lot many words, but we do need to, let the crowd know you well. She's a certified diabetic educator. She has She's a certified sports nutritionist. She has done the low FODMAP course from the Monash University. She is a rank holder in her post-graduation and in the RD examination. She is a recipient of a whole lot of awards which have been listed on stage. I would just like to add one accomplishment, that she has been honored to co-author the guidelines under the ISPAT. So that is something new, and it's an achievement for us, because she, I think, is the first Indian to get the honor. So welcome, Cheryl.
Hello, everyone. Thank you so much, Shilpa, for those kind words of introduction. And at the outset, I'd like to thank the entire organizing team, Shilpa, Dr. Neeta Deshpande, Dr. Archana, Dr. Nitin Kapoor, Dr. Sanjay Agarwal, and the entire team for this kind invitation. And thank you for giving me this very interesting topic, because I think each one of us is faced with this question, even at home or even with our clients, right? You go to a supermarket today, and you're left wondering what to buy, because everything looks so appealing, and there's so much of claims that are out there that this is diabetes friendly, this is cholesterol friendly, this is good for your weight. So you often keep wondering what to buy, and that's when our patients come and tell us or send us these pictures as to what should I buy. And the first thing, sorry, these slides are taking some time. Yeah. So I think oats, I think this is something we all know about. It has the very important soluble fiber, which is beta-glucan, and there's enough evidence there to show that it helps in improving your glycemic control. It helps in improving cholesterol, especially LDL cholesterol, as well as improves insulin response. Now, oats reduces the postprandial glycemic response by increasing the viscosity of the contents of the upper gut, slowing gastric emptying, reducing the rate of starch digestion, and thereby delaying carbohydrate absorption. And again, how much of oats that you should consume? If you look at all the studies that have been done on oats and its hypercholesterolemic effect, 3 grams of beta-glucan, which is equivalent to around 60 grams of oats or 40 grams of oat bran, helps in reducing cholesterol by 5%. Now again, we see, a lot of patients tell us that we've eaten oats and our sugars have shot up, and they're wondering why is the sugar going up because of oats. Again, there are different kinds of oats that are there in the market, and this is very important for us to educate our patients about. You have steel cut oats, you have instant oats, and you have rolled oats. Now, instant oats will instantly rise the blood glucose level. So instant oats has a very high glycemic index, whereas steel cut oats has a lower glycemic index, but it takes longer time to cook. Whereas rolled oats is something that you can make your porridge or your overnight soaked oats, and it has a moderate glycemic index. Now, again, there are studies which have shown that, as compared to rice, Cheerios, or instant oats, steel cut oats and rolled oats showed a better glycemic control. Now, ways to incorporate oats in the diet, because not everybody likes oats porridge, but oats is such a versatile grain that it can go in your idli, it can go in the upma, it can go in your atta. Overnight soaked oats, I think, is very popular now, and children love it. In fact, we do give it to a lot of our kids. You can make an oats chilla, you can make an oats khichdi, and you mix it with dal, and it tastes really nice. Add a lot of vegetables, so again, the fiber content does go up. A lot of people, at least a lot of clients, come and tell us oats is only protein. So I think that's another misconception that most people have, and they'll eat oats and they'll think that that's where they get their protein from, but we know that's not true, and therefore complementation with the protein source becomes important. Now, cornflakes. I think every child loves cornflakes, and they think it's really easy to eat. And I think for most working parents also, this is a very convenient breakfast to give our children. But let's look at the glycemic index of cornflakes. This is 89. Okay, so it has a very high glycemic index, and that's why when we look at the CGMS graphs, we see an instant spike in blood glucose, a very sharp spike in blood glucose after eating cornflakes. And therefore, for most of our patients, especially with diabetes, we often tell them not to eat cornflakes or have it only when their blood glucose levels are low or they're indulging in some rigorous physical activity. But otherwise, cornflakes is definitely not in our list of foods that you can eat more often. Now, because it has a lower moisture content, the available carbs are higher, and as I mentioned, the glycemic index is also high. Now, all bran flakes, you think all bran will be very good for diabetes. And we are also learning. I say our patients are our best teachers. So, they tell us that when they have all bran flakes, also the blood glucose levels really spike. So, not that all bran is better than cornflakes. The spike in blood glucose is similar. Now, this is something that I would draw your attention to. Now, if you look at the food labels, if you looked at the food labels pre-2016, 2018, if you looked at the corn flakes or the all-bran flakes, you would have seen in the ingredients there is high fructose corn syrup. Because that time the FDA regulations are not very strict and you only had to mention added sugar, and sugar was sucrose. So anything else that went in was not really counted in the sugar. So everything got hidden over there. But in 2018, with the Aaj Se Thoda Kam, I don't know how many of you all know about this initiative by FSSAI, and FDA became very strict about the norm, saying that you have to add all the added sugars. So what are all the added sugars? All of this. So all the hidden sugars have to also be accounted for. And that is why today, and the consumer awareness has gone up so much that now the industry has also woken up to the fact and now has started using other healthier forms rather than using high fructose corn syrup. So now if you look at most of the packaged foods, you will not see high fructose corn syrups, at least in the good, well-known brands. Then comes muesli, another food. Again, muesli, you have to be very, very careful. And when you're counseling your patients on what to buy, you have different kinds of muesli. Some muesli really will spike up the blood glucose levels because, again, there's a problem. Okay, anyway, so it'll spike up the blood glucose levels because it has got a lot of, the sugary stuff also in it. It'll have dry fruits, it'll have raisins as well as sugar. So whenever we're advising our patients to buy muesli, please tell them to buy the high fiber, no sugar added muesli, because that has a lower glycemic index. If you look at the glycemic index, it'll vary between 41 and 55. And this is what we've got from the University of Sydney glycemic index data. Now, ways to incorporate muesli in the diet, again, add it to milk or curd and have it, or even you can do overnight soaked, cereal with it. Now, when they looked at, cornflakes versus muesli, cornflakes was having a higher glycemic, in terms of, rising the blood glucose levels, muesli fared better compared to cornflakes. If you're choosing between the two, muesli is better, and definitely the no added sugar, high fiber muesli. And what I usually tell my patients is you buy it like this and you can add your nuts. So you add your badam and the walnuts and everything to it, because then you are anyways enriching it with good healthy fats. You can even add your seeds like chia seeds, pumpkin seeds, etc., sesame seeds, etc. Then we come to quinoa. Again, quinoa is very popular nowadays. It was not so popular in the past, but if you look at the nutritional profile, the protein content is definitely better. And if you look at the calcium also, it scores much better. Now, it is a pseudo cereal, and it's good because if somebody has gluten intolerance, quinoa becomes a very good grain to incorporate. Again, you can make a lot of recipes with quinoa. Not everybody likes the taste of quinoa. That's another thing, not everybody likes it. You have to develop this kind of taste. And you can, again, it's like I said, it's a very versatile grain. The quality of protein in quinoa is definitely better. And therefore, for people who like it, it's a good, grain to incorporate into the diet. And if you look at the fiber content also, it's very high in fiber. For any food to be called high in fiber, it should have at least 6 grams per serving. If you look at quinoa, it has 14 grams in 100 grams. So it is pretty good on the fiber content as well. And the glycemic index is also on the lower side. It's 50. And we've seen with CGMS, it really works well because you can add vegetables, you can add protein, and have it as a khichdi with some raita on the side, because our Indians still like Indian recipes. You just have to give it the Indian tadka, the twist to it. Now, ways to incorporate it, you can have a quinoa dosa, you can have a quinoa pulao, you can have a one-pot meal. I think this is again becoming very popular, especially with working women. It becomes very challenging to cook, like a multi-course meal. So this again becomes very easy. Now, this is something, I often hear a lot of celebrity, so-called self-nutritionists to say, amaranth is better than quinoa. And where amaranth is really good, it's really, really good. But for people with diabetes, if you look at amaranth, it has a high glycemic index. The glycemic index is 97 of amaranth. And if you look at the protein content also, it is more or less the same. So I'm not saying amaranth is not better than quinoa, but what I'm trying to say is in case of diabetes, you have to be a little careful because amaranth has a higher glycemic index. So we have to look at ways to bring down the glycemic index of the amaranth. Again, if you're looking at other grains, you have pearl barley, which is again a very ancient Indian grain. It fares very well when it comes to diabetes because the cost of quinoa is also high. It is around 150 to 280 rupees for 500 grams, depending on which brand you're buying. pearl barley, or even today you have different kinds of millets. We've been using a lot of millets in our clinical practice today. So you have foxtail millet, kodo millet, barnyard millet, and they really, really fare very well. So somebody who's not willing to try quinoa or can't afford it, you do have a lot of millets which are there, which are lower in glycemic index, very versatile, and it really gives you good satiety, as well as keeps your blood glucose levels as well as cholesterol under control. So again, there was a study done with rice and foxtail millet. Foxtail millet is another millet that we really use in our practice, and we've seen it's really good in terms of the glycemic response. So thank you so much for your patient hearing, and I hope I've stuck to time. I'm not sure. Thank you.
Yes, you have.
And thank you for the technology glitch that happened.
Okay, Cheryl, 1 minute. Thank you for an excellent insight in all the different cereals. I would request Prachi Surve to felicitate you.
Our next speaker is Shilpa Joshi ma'am. She is a registered dietitian from Mumbai. She is a consultant dietitian at Mumbai Diet and Health Center. She is also a diabetes educator, past vice president of Indian Dietetic Association, honorary secretary of All India Association of Advancing Research in Obesity, master trainer at Diabetes Conversation Maps. She also awarded with Stree Award from Foxy in 2019. Yeah, over to you, ma'am.
Thank you so much for the kind words of introduction. And good afternoon, everybody. Can I have a good afternoon back? Just to ensure that nobody is sleeping behind. Okay, so I'm going to be speaking on coffee. What is the evidence of benefit? And believe me, when I was given this talk, even I didn't know much about coffee. And this has been indeed a learning experience as to what does coffee have. So interestingly, its origin began in 10th century, where it was originally planted in Africa, in the Ethiopian mountains. But from there, slides are not coming. So you don't need to see okay, fine. So it actually spread all over, and the place where coffee became popular as a drink was Yemen. And actually a priest from Yemen came to India with these coffee seeds smuggled into his baggage, and he planted them in Karnataka. And that is how, he planted them in Nilgiris in Karnataka, and that is how coffee became popular in India, okay? Then there are two main species of coffee. There is coffee Arabica, and there is coffee Senophora, which is also called as coffee Robusta. Now, coffee Arabica is a pure coffee. It's a pure line selection. So coffee Arabica is very, very expensive. It's available everywhere, but it's an expensive coffee as compared to Robusta, which is a kind of coffee which is more resistant to other problems of like pest and etc. Hence, it's cheaper, but it's more acidic in flavor. Now, when I was reading all this, the first thing I wondered is the coffee I like is South Indian filter coffee. So I was like, what is that? I don't know whether it is Robusta or Arabica, and I tried to go online, and then what I found is coffee served in India is usually 80% Arabica and 20% Robusta, and therefore we really have good quality coffee. 80% of it is really good coffee that we are having. Now also, I shouldn't say this in a talk on coffee, but I like instant coffee. I like Nescafe. Okay, and it's not a nice thing to say, but I do like instant coffee. And what is instant coffee? So instant coffee is like milk powder. So what happens in milk powder? It's spray dried, right? So in instant coffee, coffee is prepared and it is spray dried, and hence you have those granules which immediately mix as soon as you add hot water or hot milk to it. So that is the instant coffee, and nobody knows whether it is Arabica or it is Robusta, because different coffee companies, it depends upon the cost of the coffee you're buying. So if you're buying a cheaper one, it's going to be Robusta, and otherwise it's going to be Arabica. Now this is more nutritional. So coffee has a very complex composition constituted by thousands of biologically active compounds, of which the known one is only caffeine. But believe me, that is just one part of a huge matrix. So it has triglycerine, phenolic compounds like chlorogenic acid, diterpenes, cafesol, carvinol, soluble fibers, and there are many, many more metabolites, which I have not said. Then caffeine content, you know, because Arabica is an expensive pure line coffee, it's mild, so its caffeine content is lower than a Robusta. So if you want to sit up at night and study and stuff like that, Robusta is answer for you. And I don't know what happened to the picture here, but there was a very nice picture which showed what coffee can do. So caffeine is absorbed. So there is Geeta here, and this is the first time when Geeta spoke on this in a nutrigenomics talk. And when I was making this slide, Geeta was the only person I was remembering. So caffeine is absorbed into systemic circulation within 45 minutes, and it reaches peak blood concentrations at 1.5 hours. 90% of it is cleared in 20 minutes. Kidney tubules promptly reabsorb the caffeine, and only 5% is excreted unchanged in the urine, but it also depends upon your genetic composition. Not everybody, you know, some people can process it much faster and it can leave the body much faster. So caffeine occupies adenosine receptor site that can act as a competitive inhibitor of brain receptors, and therefore they increase alertness. And that is the reason why we have coffee. Now, what are the physiological effects of coffee? Caffeine has several effects on cardiovascular, respiratory, gastrointestinal, and renal system. It causes a modest increase in systolic and diastolic blood pressure, and at a higher doses, it can also cause tachycardia and arrhythmias. And therefore, if people are getting anxious or they have high blood pressure, typically you tell them, do not have coffee. Coffee also increases GFR, and therefore it exerts a diuretic effect. And that is why when we are traveling, we try not to drink coffee because we need to use bathroom much more frequently. It stimulates digestive secretion, induces relaxation of intestinal smooth muscles, and depresses the lower sphincter of esophagus and produces relaxation of bronchial smooth muscles. I really don't know what has happened. Pictures क्यों नहीं आ रहे? I don't know. There were photographs which are not coming. So, okay. So this is coffee and metabolic health again. These are impacts of coffee on different systems. So in blood pressure, you will see that it increases sympathetic activation and it decreases the oxidative stress. So the impact on blood pressure is that it can cause higher blood pressure. There is data to show that in case of waist circumference also, coffee can decrease accumulation of triglycerides in the body. Glucose metabolism, it increases insulin secretion, it decreases the damage of pancreatic beta cells, so this is the impact on blood sugar. And on lipid metabolism, it decreases lipid synthesis, decreases the beta oxidation in case of lipids. I don't know what has happened to my slides, I don't seem to see them. Do you have the pen drive, Kavita? Just one second. Okay. So these are side effects of coffee. You know, that was a nice slide on what are the effects. I'll talk about side effects before I talk about the effects. So roasting, see, you buy green coffee beans and then you roast them. Roasting causes Millard's reaction, and this Millard's reaction actually causes it to produce many acrylamide and polyaromatic hydrocarbons, and all these compounds, levels of these compounds need to be monitored. Then there is toxic effect of caffeine, especially in psychiatric disorder and on people who are taking psychiatric drugs. So drug interactions is with antipsychotics, hormones, and vitamins. And coffee consumption has been associated with severe gastrointestinal problems, including peptic ulcer, gastroesophageal reflux disease, but some trials actually show different results. And let me see if I can put this and show you those slides. सेव ही नहीं हुआ है क्या हुआ Yeah, the system needs coffee, Shilpa. कहाँ है? Shilpa, Shilpa. There is caffeine, and these are the effects of caffeine. It is regulation of reactive oxygen species production by blocking adenosine receptor and others. Then there is chlorogenic acid, which causes inhibition of protein tyrosine phosphate 1B, and there is cafesol and choline, which reduces the expression of COX-2 and INOS due to inhibition of NF-kappa beta activity, and all of these together actually cause the anti-inflammatory effect of coffee. And this is the better slide where it has shown that there is a risk of diabetes, it decreases risk of diabetes, decreases risk of hypertension, decreases abdominal obesity, decreases triglyceride, increases HDL cholesterol, but one word of caution, this is not coffee with milk and sugar. Huh? This is coffee. Then if you're going to add milk, sugar, cream, and other 1,000 things to it, this is not going to happen. Okay, and these are impacts of coffee. And again, here, if you see, it has been shown, if you see the one on mortality, it's a busy slide, I know, but it has an impact on mortality. But in cardiovascular diseases, more than 6 cups of coffee a day is associated with high risk of stroke and valve stenosis. So that is something that one has to keep in mind. That's it. Thank you so much for a patient hearing, and I'm very sorry about all this confusion.
Thank you, Shilpa ma'am, for your informative presentation. Now I request Shilpa ma'am to felicitate Shilpa Joshi ma'am.
ये निकाल लो.
Niti Desai ji, okay. Our next speaker is Ms. Niti Desai. She is consultant nutritionist practicing in South Mumbai. She is attached to the Kambala Hill Hospital for last 17 years. She is a secretary and master trainer at Association of Diabetes Educator, co-editor of IDEC Clinical Dietetic Manual 2018, and authored chapter for various textbooks. She has her regular column in health and nutrition for 18 years. Over to you, Niti.
Right, a very good afternoon to one and all. On the outset, I would like to thank the entire IDEC organizing team, Shilpa Joshi, Dr. Nita Deshpande for having me here. We have had a collection of nutrition subjects, one more added here. NASH, does that involve carbohydrate or fat restriction? Now, let's hope this is not behaving temperamental. So we all know that NASH is basically the advanced form of NAFL. And here you can see that when healthy liver accumulates fat and then that gets inflamed, we have fatty liver goes into NASH, and then of course there is fibrosis and further cirrhosis. Now, so basically, what has been seen is that there is a bidirectional association in NAFL with metabolic syndrome. And in fact, this is reflected in the very recent recommended change in the nomenclature, where now we call it metabolic dysfunction associated fatty liver disease, MAFL, instead of NAFL. And this is as recent as July 2022. And in fact, this recommendation highlights its metabolic and multifactorial nature. Now, since no drug as yet has been approved for the treatment of NASH, dietary intervention, basically lifestyle modification which involves dietary intervention and physical activity, are at the moment regarded as the cornerstone of treatment for NAFL and NASH. Okay. So the whole conversation today is whether we should be restricting carbohydrates or fat in the treatment of NASH. Now, it is very obvious that when one takes in extra calories, when one is consuming more than required calories, there will be liver fat accumulation. I mean, that is kind of common sense. But it is also clear that the macronutrient composition can also modulate that risk. And when studies were done with hypocaloric diets, the conclusions that have been arrived at the moment is that saturated fat is the primary nutrient which really increases the liver fat. Second comes the simple sugars, and at the moment there is no differentiation between free sugars, whether it is glucose or fructose, they all behave the same. And lastly, it is unsaturated fat, which in fact will be protective, and here PUFA seems to be more protective than MUFA. Now, since it was very difficult to disentangle the effects of extra calories from the effect of different macronutrients, there have been a lot of isocaloric and hypocaloric dietary intervention studies that have been carried out to get some insight into the effects of different macronutrients. And when isocaloric diets were studied, even when the diets are isocaloric, the different types of fat and carbohydrates, they influence the liver fat accumulation in different ways. Once again, saturated fat and fructose induce the greatest increase in intrahepatic triglycerides, which is the liver fat, and of course accompanied with insulin resistance, while unsaturated fat seem to provide a protective role. Again, when hypocaloric diets were seen, low-calorie diets, low-calorie, low-fat diets, somewhere around 1,200 calories, we got the best results where there was 81% reduction in the liver fat composition. So low-cal diets definitely work. Now, whether here does the macronutrient composition matter? Well, at the moment, it looks like that the negative energy balance in general seems to reduce the liver fat content. Specific macronutrient manipulation may have some utility, but at the moment, we are not sure. So if we summarize these three kinds of studies, hypercaloric intake, when the caloric intake is high in obese individuals, the increase in liver fat is independent of the diet composition. Okay? The extra saturated fat and the sugars both lead to increase in liver fat. If you're looking at hypocaloric intakes, low-calorie diets, there is a reduction in liver fat, and long-term studies have shown that it is independent of the diet composition. The calories just need to be low, there needs to be a negative calorie balance, and you will see the reduction in liver fat. If the diets are isocaloric and they are compared, the magnitude of effect depends on the diet composition. And here, the deleterious effects are seen most with saturated fat, followed by the effect of sugars. So then, is it finally carbohydrate or fat who's the villain? Well, by the current evidence taken together, the data supports the use of diets that have a reduced content of saturated fat, free sugars, and refined carbs in the treatment of NAFL. So it's not one or the other, it's carbohydrates and fats that we need to reduce. In fact, a lot of scientific association, the International Association guidelines also have highlighted the fact that we need to target weight reduction up to in the range of 7 to 10% in the treatment of NAFL. And those who are in practice, we know that that is what we generally target. We ask our patients to start with 5 to 10% weight loss. Some of the European associations have mentioned that Mediterranean type of diet is more beneficial in patients with NAFL. However, specific recommendations are divergent. For example, again, the European associations have recommended the exclusion of processed food and sugar-containing solutions, but the American Association and ESPEN do not provide such recommendations at the moment. So, in conclusion, the most important thing is calorie restriction regardless of dietary composition. While low carbohydrate diets have been more promising for reducing metabolic dysregulation and severity of NAFL, this in fact I think is most important in our Indian context, where we are basically a carb-loving nation. We just love our carbs. So we should be looking at replacing some of our carbs with protein. Need to counsel our patients and especially look at the excessive intake of sweets, mithais now in this festive season, and the sugar-containing beverages, which could range from aerated drinks to sharbats to what have you. And also, we need to tackle our fascination with the saturated fats, especially the ghee and the coconut. I mean, we have enough patients who have started using ghee as the only cooking medium, or keep asking that should we be taking 2 teaspoons of ghee every day. So we need to dispel these myths and work on these, because there seems to be enough evidence to prove that saturated fat is definitely devil when it comes to NAFL. Going forward, interaction of diet and exercise with the gut microbiota, as Geeta just mentioned, and precision nutrition will lead to developing personalized lifestyle intervention strategies for people with NAFL. Thank you.
Thank you, Neeti. I request Dr. Tejas to felicitate Neeti ma'am.
Our next session is on time-restricted feeding. And to deliver that session, can I request Dr. Kavita Gupta to come on the stage? Dr. Kavita has done her PhD, and she is a certified diabetes educator and pump trainer. She is the director of Head Department of Dietetics and Therapeutic Diabetes Education. And she is honorary secretary of IDEC Nagpur chapter, Joint Secretary of Association of Diabetes Educators, AD. She has received several awards, like Swarna Padak Award for Oral Paper Presentation at IDECon, Best Indian Diabetes Educator Award, Dainik Bhaskar Women Award. So we are very delighted to have you here, ma'am, and please take over the dais.
So, thank you so much, and my heartfelt gratitude to the entire team of IDEC, and special thanks to Dr. Sanjay Agarwal sir and Neeta Deshpande and my dear friend Shilpa for having me here. And after all that talk, now is the time to talk about time-restricted feeding, where we all know that there are a lot of fad diets which is prevailing, and when it comes to weight loss, we have been always juggling or manipulating the macronutrient content of the food, or even restricting certain kind of food. But now it is the time. We've been always restricting, okay, you've got to eat this food or not, or a certain type of a food. But now is the time where we also need to understand the time of the food, what we are eating. So basically, it's the intermittent fasting which is really prevailing. And there are different types of intermittent fasting. We have the ADF, which is the alternate day fasting, wherein, one day you are fasting, where you have to eat around 500 calories, and the next day you're going to eat the diet which is ad libitum. that is eat at your own pleasure. And then we have the 5:2 diet, wherein the 2 days you have to be fasting, you have to eat around 500 to 1000 kilocalories, and the other 5 days you will be eating as at ad libitum. And here what I'm going to talk upon today is the time restricted eating, wherein you have a eating window of 8 hours and you have a fasting window of around 16 hours. And this is a, pictures say better than words. So this is a pictorial way how the 5:2 and the time restricted feeding goes on. So what exactly is time restricted eating? It is a dietary approach that consolidates all the caloric intake to 6 to 10 hours of periods during the active phase of the day. I know Geeta Dharmate has already talked a lot about the circadian rhythm, so we need to focus on eating at the active phase of the day and without much alteration of the diet quality and the quantity. And this is the most popular method is the 16/8 method, which is also called as the lean gain protocol. It involves skipping breakfast. So eating a breakfast is not really important now when we are talking about the intermittent fasting concept. And so many of the people are now sticking to 16/8 method, and this is also known as popularly also known as the Dikshit diet here in Maharashtra. And so when we are talking about the window period of eating, window period, so there have been clear improvements which has noted that after 6, 8, 9 or 10 hours of protocols of like eating window has given better improvements in the metabolic health. As compared, when we are talking about extending the eating window to beyond 12 hours, there is not any major beneficial metabolic effects. Now, when we talk about the fasting period, so if we think that we need to increase the fasting period, again, if we increase the fasting period, there is less of adherence because there must be much pressure, that if you have to fast a lot. So it may be non-compliant also if we increase the fasting period. So what is the basic pathophysiology? We all know that if any person goes for the fasting, the carbohydrate for the first few, the energy is being used for the carbohydrates are used for energy, and later on the fats are broken for the energy. And the rapid loss of fat by fasting 14 to 20 hours per day, we can also have fat loss if you are fasting for 14 to 20 hours per day, even without exercise or any dietary regimes. So are there any metabolic effects of time-restricted eating? Yes, there is a whole lot of benefits where there is reduction in the weight gain, reduction in fat mass, reduction in glucose intolerance, reduction in insulin resistance, fasting insulin. There is reduction in the beta cell function impairment, and there is an overall better cardiometabolic health if you are trying to go on time restricted eating. But again, this has to be very much planned and with a dietitian, and because you can't just go into ad libitum and you're going to eat anything and any time. So that we need to understand. And so are there any evidence-based health benefits? So there are a number of trials, human trials, but unfortunately the limitation is that they are of short duration. What we can see here, it's of only 1 to 16 weeks, and even the sample size are very small. Again, there are a number of trials which we see, and they all have shown that there is a decreased body weight, there's decrease in fat mass, decrease in fasting, glucose and HbA1c is decreased in insulin resistance and insulin sensitivity, and also in the leptin levels has decreased, and decrease in fasting insulin levels. And at the same time, there is also increase in adiponectin. And there are few questions which are unanswered when we are talking about time restricting. So which time of the hour is better, whether it is morning or afternoon or evening? So again, the circadian rhythm plays a very important role. So it has been seen that, whenever, if we follow the fasting in the rest phase, there is metabolic disarrangement. So always try to focus fasting in the active phase of the day. And are there any weight loss independent effects? Again, effects of intermittent fasting on cardiovascular risk markers. So yes, there are some studies in humans which suggest insulin sensitivity can improve even in the absence of weight loss. And again, can fasting mimic the diets which reduce aging or chronic diseases? Yes, we have the surrogate markers, like we can see the inflammatory markers, which shows that yes, it can reduce aging. So are there any limitations? So there are few points to ponder. We need to understand whether, if the patient, if we have put them on this time restricted eating, so maybe that the patient may feel that, okay, that he does not have to eat for the next 16 hours and he may tend to eat more, for that 8 hours of window where he has to eat. But again, we need to tell them that they have to be, it has to be planned, it has to be structured. So we have to tell them about the postprandial hyperglycemia, dyslipidemia, and glycemic variability, which may cause atherosclerosis. And here I would just like to point our study which we have done on...
Kavita ma'am, sorry to interrupt, but we are running short of time.
Yeah, so which has just shown, I'll just finish it quickly. So which has shown that high-fat meal may increase your inflammatory markers as well. And again, TRF is nothing new to us. It has been carrying on by the Jainism also. And are there any risk factors? I mean to say, we need to carry this time-restricted feeding in diabetes only with caution, because if they are on medications, we have to observe and we have to put them on very close monitoring, and it should not be advised to children, especially in type 1 or pregnant lactating women or elderly patients. So time-restricted eating was actually initiated early in the active phase, shows pleiotropic metabolic benefits, and again in human trials it has shown weight reductions. So again, we need long-term, large-scale studies so that we are able to understand the better that it works better. And again, we just like to add a word of caution that whatever type of fasting, intermittent fasting you're going to follow, it has to be highly individualized. It needs to be simple and structured and even consistent. And we again need to put a thought that, why, when we are just talking about high fat, it's like why the animals do not have metabolic syndrome. So again, this is a food for thought for everyone. And again, it is the evolution of man, with his food, and he was, a sapien, and now he is where we, due to all his, I think the main crux is the diet, and where we all need to work on. Thank you, IDEC, for having me here. Thank you.
Thank you, ma'am. May I request Shilpa ma'am to felicitate the speaker? The next session, may I request Geetanjali Bide to come forward for the next session. The next and the last session is on herbal meal replacers and the evidence for harm. Geetanjali Bide has done her PhD in sports nutrition from University of Mumbai, and she has a rich academic as well as working experience as a sports nutritionist at various renowned institutes. Geetanjali ma'am, over to you.
Okay, 1 minute. Slides, I'm just seeing. Excuse me.
Thank you, Shilpa Joshi and the IDEC team for giving me this opportunity. And after a feast of caffeine, quinoa, cornflakes, and various other things, and with a lot of interruptions, I start my session on herbal meal replacers or supplements. I think even if we are feeding people a lot of food, they still need some supplements and replacers just to pep up and also to do better. I come from the background of sports nutrition, so I deal with a lot of people, athletes coming to me who ask me a lot of things like supplements. So I'll just focus a little bit, and I'm trying to make my talk very crisp. So herbal meal replacers, you must have come across a lot of products that are available in the market, and people are buying supplements. And since the pandemic, I think more and more people have various startups are coming up, and they have started buying and also making supplements on their own. So what are dietary supplements? Basically, it is something that you add on to your regular diet, and it contains some ingredients that can provide you with additional health benefits. And there are different types of supplements coming from multivitamin supplements, protein supplements, and we also have meal replacers, something that can take care of your meals when you're out. But now some of the people have actually replaced their regular meals with meal replacers. Now these are basically calorie controlled pre-packaged bars or beverages that replace a regular meal, and they may contain certain added herbs or botanicals to give them a special edge or some benefit. Herbal supplements are there since ages. We have a lot of herbs which are there in our culinary, as well as we have a lot of herbal day-to-day, even at home, we get advice from a lot of our own family members to use different kinds of herbs for some or home remedies. So herbal supplements are basically plant or plant extracts that are consumed other than calorie or culinary benefits. And nutraceuticals are food components which have a potential to cure a specific disease conditions or also provide certain medical benefits. So it's observed that the Indian dietary supplement market has really increased a lot, especially in the past 2 years. So it is very common for us to see clients who say, I'm taking Limsi, I'm taking calcium, I'm taking iron. They are taking and popping pills as just because to be safe from any kind of illness, and more so with the COVID. So the Indian Dietary Market Supplement Survey indicates that 94% of the Indians are worried about their family health, and consumers have opened their wallets to consume natural foods. They look for something that is natural, that is organic, that is safe, health supplements, and also nutraceuticals. And it is reported that the market is going to reach around 847.9 billion by 2027. So it's a very huge market, and with having different kinds of marketing avenues open to everyone, when you open your social media accounts, before you think of something, that product will be there on your whatever social media account. So you may wonder, I was going to think or search on this, but it's already in front of me. So that is something which is now picking up in the Indian market, and we have a lot of nutraceuticals and meal replacers or supplements available in the market. I don't know, it's not moving. Okay, thank you. So what are the different types of herbal supplements? The different types of herbal supplements are basically classified into 4 major types. The supplement brands are the overall availability of supplements is huge, but the major supplements that are available in the market are weight loss supplements, bodybuilding supplements, sports supplements, and also immunity boosters, which have come up in the last 2 years. So basically, what are herbal supplements? They are used since ages, in time immemorial. And the sources for herbal supplements are basically plant roots, leaves, seeds, barks, and moss. And herbs are said to be the precursors for the drugs that are used in modern medicine or plant-based medicine. And the function of these herbal supplements is that how do these supplements work is they work as adaptogens, and that help the body to adapt to the physiological stress and also normalize body functions. So the main supplements we are going to look at are review regarding what are the effects. Now you must have come across a lot of reports which say that after consuming a weight loss meal replacer, there were certain side effects which were noticed among the patients or clients, or liver toxicity is something which is very commonly observed. And in case of sports, inadvertent doping is something which occurs because of the consumption of a lot of herbal supplements. So here is a review, herbal medicine for the treatment of obesity. It is a review which reviews all the studies related to use of certain herbal medicines or replacers from 2007 to 2017. And what are the supplement herbs that are used is ephedra, Garcinia, Gugul, which is a very original Ayurvedic herb, which is also called as Medhari Gugul, then ginseng, rhizoma. The list is long, and the possible or purported benefits or effects are basically after giving these herbs or herbal supplements, there is definite impact on the body weight. There's body weight loss, there is improved HbA1c level, increased satiety, and also it helps in reducing the fasting insulin level, and a lot of improvement in BMI and WHR ratio is also observed in most of the studies which were reviewed in this article. And some of the adverse effects noted in were gastric issues, skin rashes, nausea, headache, fatigue, dizziness, and sleep issues. And the conclusion statement of this review was that there is a need for increased clinical trials, and also when we review these papers, there is no standardized procedure, and also the composition that is used for these herbal meal replacers is not uniform. So there is no set composition, so you cannot identify what ingredient is actually going to cause that possible effect of having a positive effect on obesity or weight loss. And safety norms are generally not followed regarding the clinical trials, as well as whatever supplements or herbal products are available in the market. So herbal meal replacers, although a lot of products are available, thermogenic effects specifically for weight loss are used, and these brands are very popular brands, and they have, without telling the name, I think the audience will understand that there are certain brands which are commonly used, and they contain a lot of herbs like ephedra, ageline, Camellia sinensis, and they also have hepatotoxic effect, and there are cases of liver failure and transplants. And bodybuilding, the list is endless. There are so many side effects because they are consuming, especially in bodybuilding, they are not only consuming the herbal supplements, but they are also popping in a lot of protein supplements and multivitamins. So basically they are taking cocktail of supplements, and there is one case which is reported on hepatic failure in a woman bodybuilder who was actually taking a cocktail of supplements where she was having different kinds of meal replacers, plus there was protein, there was multivitamins, there was omega-3. So in spite of there is no need for consumption of all this, but because she is instructed by a coach or a trainer, she was consuming these different kinds of supplements, and she had severe effects on the liver. Sports supplements is again something which is contaminated, and it may contain something called as DMAA, which is also obtained from geranium plants, and it is basically used in a pre-workout supplement just to give you a boost when you work out. And the results are like the harmful effects of consuming these kinds of products which may contain certain herbs are like elevated blood pressure, then tachycardia, nausea, vomiting. These are some of the supplements. So supplement side effects. And one more thing to note is that be aware of the combination of supplements that the individual takes and avoid a cocktail of supplements in your daily life. Then, how do you address the major pitfalls in this particular industry? So basically, there is a need of a lot of research on these herbal supplements. Controlled clinical trials are required. And it is also important to identify the mechanisms of the biological activity of how they are good. We have a wealth of supplements. We have wealth of herbs like ashwagandha. We have so many other products that are available, like Shilajit is there, which is used for improving the testosterone levels and also specially used in bodybuilding and all that. But we do not have any documentation about how these products will behave in your body when you are consuming them for a long period of time, and also whether it is going to have any toxic effects, because they are just passed on from one person to another, like the coach is telling the athletes and everybody. So toxicity trials about these herbs and the drug interactions is very important, because a lot of time people or the consumers or the patients do not disclose certain things that they are consuming because they feel that it is herbal and it is safe. So we also come across a lot of products which have come in the market with a very quick launch period, like it's just a recipe is developed and it comes to the market. So most of this industry is market driven, and without evidence we have a lot of products available in the market. So in case of regulatory, whatever pitfalls are there, there are a lot of unregistered products, and also there is adverse event reporting is missing. So people are consuming, but it's not reported. Even if there are side effects, not reported. And many products are available over the counter, so people or consumers do buy them. Third party certification is required for them for proper regulation, so that the entire whatever product it contains or what is the composition will be known. And we need strict guidelines from FDA and FSSI, and FSSI has now started something which is called as foods for special dietary use, which is a new logo which will be coming to, which will be on these kinds of products which are used for performance benefits. And also cross-contamination of the different products is likely to occur. Now,
your time is up, please.
Consumer gets, just 1 minute, consumer gets convinced with multi-level marketing, and different herbs are used because they feel that it is safe, it is natural, and consumer always neglects this to disclose, like he will not be disclosing it to the practitioners. So the way forward is what the health practitioner should be doing. Be aware that large fraction of general population takes supplements, request information to provide optimal care, and consent and assessment forms should have these columns whether you are taking any herb or dietary supplements, and patient education is very important. From the consumer's perspective, seek professional advice. Herbs, natural, organic is not always safe, and declare or disclose what you are consuming to the health practitioner. Read labels carefully, and also do not get carried away by some unauthorized claims like weight loss, quick weight loss, muscle building, immunity boosters, or performance enhancers, or sexual enhancement. So these are some of the things and the salient features, or how do we handle these situations regarding the herbal meal replacers and supplements that are available in the market. Thank you.
Thank you. May I request Prachi to felicitate Gitanjali ma'am.
Due to lack of time, we'll just take few questions. Anyone has any questions from the audience? Yes? Preeti, yeah.
Ma'am, I would like to know your opinions about green coffee beans, about its effect on metabolism, and also about the vitamin-infused coffees that are in the market. So I would like to know your opinion on that.
So there is data about green coffee beans on weight loss is quite a bit. The difference is green coffee beans and the coffee, the regular coffee, is that there is no roasting.
Right.
So when there is no roasting, the toxic effects which come with Millard's reaction do not exist. And hence, green coffee tends to have more benefits than the regular coffee. Right. And as far as vitamin-infused coffees, I'm presuming that they will have higher micronutrient content because they are infused with it, and that's all. Otherwise, it's just the coffee. Now, also, try to understand, like Gitanjali was saying, is the combinations which are important. Right. So if you're going to put vitamin C there, and then you're going to add, say, milk, or you're going to add something else, you really don't know what is the bioavailability post-processing the products that you buy at home.
Right, right. Absolutely. Thank you so much, ma'am.
Any other question? Yes? You can just come. Okay.
I had a question for Kavita, ma'am.
Yeah.
So, ma'am, usually in intermittent fasting, we follow that you have an early dinner and then you skip breakfast. But majority of the fasting period would come during the rest time, that is sleeping period. But it's recommended to follow IF during an active phase of fasting. So, is this method of early dinner and skipping breakfast correct for IF, or is it not? And if it is, then what is recommended?
No, it's correct. In fact, that window period should be 8 hours. So it can be any time. So maybe you can have an early lunch and an early dinner. So like how in Jainism, or how few people, even the farmers, do it. So you can have your, maybe at 11 o'clock, you can have your lunch, and then you can have an early dinner maybe around at 6 o'clock. So the time, the feeding time and the fasting time has to be taken into consideration. So that is important. If you're sticking to that, and of course the total caloric restriction also. So it's not that if you are in the feeding time, you are going to eat anything and everything, whatever is coming with you. So that is what I just wanted to talk about. So again, you have to have a mindful eating when you are eating, you are in the eating phase. And there are studies which has shown that if you are doing intermittent fasting in the active phase, so that will have better effects, metabolic effects.
Thank you, ma'am.
Yes, there was another question. We'll take the last question.
Madam, it will be last question.
Ma'am, what is your take on effervescent supplements?
This is for whom? Is it for Gitanjali, ma'am?
Yes.
Yeah, Gitanjali.
The one there, effervescent supplements. What is your take on effervescent nutraceutical supplements available in the market?
See, they are currently available only for post-training or during training. And too much of effervescence is definitely not good. But there are a lot of products which are available, which have a good composition in terms of the electrolytes that they contain, and help in faster recovery or better recovery.
Like for the general population, is it recommended?
It's not recommended on a regular basis for general population, but athletes, yes. Yeah, they are. It's another form of using the supplement. Otherwise, there is no harm in it.
Like the bioavailability part and all is like how, like in the effervescence?
Yeah, it is good actually. I have tried with a lot of my athletes.
Thank you.
Any other questions? We can take it later. You can meet the experts.
Thank you, Chairperson.
Okay, there isn't any break. Yes, you can.
Yes. Now we are heading to our next session. I request Dr. Nk Joshi sir and Ravindra Kewalkar sir to head the session. CV. Sir, you can start. No, TV. No. They all are dietitian students. They went.
Okay. So good afternoon, everybody. It gives me immense pleasure to start this session. The first speaker is Dr. Srinivas Murthy, who is going to talk about bionic pancreas. Over to you, Dr. Murthy.
So good evening, everyone. I sincerely thank the organizers, especially Dr. Sanjay Agarwal, Neeta, and Dr. Shilpa Joshi, ma'am. Okay. This is about bionic pancreas. So let's look at some basics and some evidence about bionic pancreas and what is the current availability in our country. So the bionics definition I was just going through, and the last one through encyclopedia I felt very apt. Science of constructing artificial systems that have some of the characteristics of living systems. Now, why do we require this evolution in technology in spite of all these CGMs, etc.? The artificial pancreas is required because if you look at this slide, the overall state of metabolic control, on the left-hand side you can see the current A1C, and on the right-hand side you can see the 3 months frequency of hypoglycemias, which includes even seizures and comatose patients also. So this is why you require to address these barriers, especially in type 1 diabetics, to more effectively use current treatments, and these technologies have to be to achieve the optimal metabolic control, especially in type 1 diabetics. That is where the role of this bionic pancreas comes into picture, and that is where we require. Now, look at this slide. There are about 42 factors which can affect the blood glucose of a given patient, especially the day in and day out, intraday, interday, all these fluctuations. And it's humanly impossible to counter this imbalance through our manually the sugars checking or including your pens and insulins, etc. That's why we require a bionic pancreas which mimics physiology most of the times. And look at this evidence. 1 out of 3 high glucose episodes are not followed by the correction boluses, especially in type 1 diabetics, what we are mostly talking about. 1 out of 2 times the correction boluses are wrongly calculated and are managed wrongly. And the carb counting, most of the patients, including doctors as treating physicians, we feel difficulty to educate the patients, and in turn the patients feel it's a burden for them to comply with this carb counting, especially during type 1 diabetics. Now we know after 100 years also, the insulin discovery, there are very few gadgets to deliver this. And the connected devices, what we want now is coming as a smart pens. And one of the things which is already there is such connected devices. They record time and amount of insulin delivered, and there are apps connected to them, and that's with a CGM. And it's a comprehensive diabetes management can be done with these instruments. And to mimic physiological insulin delivery even better, there is a hybrid closed loop system, and that is what we're interested today. So these are the connected devices what we're talking about. The BGM and the CGM, of course, then they're connected, they sync with these mobile apps and give us a better perspective about the patient's sugars. Now the insulin pumps, we know, they provide a continuous subcutaneous insulins, and they basal rates, the carb ratios, correction factors, the target blood, all can be customized for a given patient. And there are generally 2 classes of insulin pumps, which are tube and tubeless. This is how it looks, and these are the shaded areas, shows where these sites can be worn, the pumps can be worn. Now there are sensor augmented pumps, and this is where the sensor augmented pumps display the CGM data to facilitate the dose calculations, but they do not automatically adjust. And that's the difference between sensor augmented and the AI based CGMs. By contrast, low glucose suspend and predictive low glucose suspend, we call it as PLGS systems, which can decrease or stop insulin. The PLGS system attempts to prevent hypoglycemia, automatically suspending insulin whenever there is an impending hypoglycemia. Whereas in the other conventional, the low glucose suspend, in that concept, it is stopped only after hypoglycemia occurs. But there are no comparative studies for the outcomes between those two methods. Now, automated insulin delivery systems, or the AIDs, are known as hybrid closed loop systems. This is what is our topic of interest today. And these use CGM glucose values to automatically increase or reduce the insulin delivery. Now, these AID systems increase basal insulin delivery or deliver the automated correction boluses to treat or prevent hyperglycemia, and can also stop or reduce the basal insulin delivery to prevent or treat hypoglycemia. Now, each AID system allows users to adjust different pump settings and alters insulin delivery using a different algorithms which consider different parameters that can be individualized. And AID algorithms have been shown to improve glycemic control, decrease hypoglycemia, and of course to reduce the burden of care and improve quality of life, especially in type 1 diabetics. Now, this is how typically, I'm sure all of you are aware, these are the various, the sensors, the pumps, the infusion set, before and after insertion you can see there, and the infusion set is the link between the pump and the body. And of course, every 2 to 3 days, this is the cost what most of the patients, our patients cannot. And this is a diagram which can depict the typical artificial pancreatic system, how it works. Let's go into the details, of course, in the couple of slides later. Now, this is how the evolution of CGM has happened over a period of time, and the evolution of automation, that is insulin pump therapy, along with the CGM. You can see there in Minimed, which is there 670G, and then the latest one is the bionic pancreas. Of course, it is in 1979 which first started with this, and insulin pump is not new. Just to tell you that even the DCCT trial, the age old, it had more than 40% of the patients in the intensive arm on the insulin pumps. And of course, the goal of every insulin regimen is to mimic our physiology and of a healthy pancreas, and these pumps use basal bolus insulin delivery, which can literally almost mimic the physiology. Now, when using insulin pump therapy, with rapid acting insulin, you can intentionally program the pump to deliver different amounts of insulin throughout the day to better match the patient's basal insulin requirements. So, how many of us think that through the day, awake or sleeping, that the pancreas is giving the exact same amount of insulin all the day? So this does not happen, and that is why the pumps are very, very handy to handle this. Of course, just to show you the history, 1963, Dr. Arnold Kadish was the first insulin pump you can see, and the biostator, the Dana pump. This was the official, of course, one of the commercialized first Minimed insulin pump. And of course, the Minimed introduced the first popular insulin pump, Minimed 502, way back in 1983. And this system soon underwent significant improvement in size and programmability. Done? Okay. 2004, the insulin pumps in India, it started coming up, and where it was available, and of course the longer time it was required for patients to educate and also to adapt by the physicians. So this was one of the paradigm 722 which came in October 2006 to our country. And of course, later on the transmitter size was diminished, as you can see in size. And this is the real-time CGM which I'm showing. And of course, this depicts the various developmental programs in the CGMs and the pumps. Now, bionic pancreas, it contains basically 3 components: the CGM, the programmer, and the insulin infusion pump. We know the CGM, it tracks the blood sugar levels every minutes, and using a tiny sensor which is inserted under the skin, and the sensor wirelessly sends the information to a programmer, which calculates how much insulin is needed and signals the insulin infusion pump. And of course, the pump delivers the small doses of insulin throughout the day when the blood glucose levels are not in your target range, and there are different types of insulin pumps. So essentially, this figure shows the components and mechanism of how artificial pancreas or the bionic pancreas work. You can clearly see there. And the bionic pancreas, the specialty, it's a bihormonal secretion of both insulin and glucagon is combined, and it's an integrated CGM which fully automated, and the bolus priming can be done on the type of breakfast and the size of the meal also, which can be individually designed. And of course, they are based on the hypoglycemia minimizer. They've been classified as the first generation, second generation, and the third generation. For example, generation 1, it's called very low glucose insulin off pump, where the pump shuts off completely when user not responding to low glucose alarm. Whereas if you see in second generation 4, automated basal or hybrid closed loop, where the closed loop at all times with mealtime manual assist boluses. Whereas if you see the last one, third generation, 6th one, it's fully automated, and there is no manual at all, and it's a closed loop, complete closed loop. And this is what I was talking about, how it shuts down when the sensor senses before the hypoglycemia sets in. Now, Dr. Demenio said it is a platform that makes a great drug better. That's what is insulin after 100 years, wherein the past studies have clearly shown the automated insulin delivery have repeatedly shown that insulin needs very dramatically from day to day and including in the night. For example, type 1 may require 10 units, 7 units, 13 units on different days, and systems like bionic pancreas only can adapt to these variations of insulin needs every 5 minutes. In a personalized manner, the insulin can be delivered. And the best part is only the body weight information is needed to begin the dosing of insulin and glucagon both. And limitations, of course, the low batteries, delayed action of subcutaneous infusion insulin, incorrect adaptations of control algorithms, sensor unavailability due to loss of communications or non-compliance of the patient, and of course, when it comes to the pump, the infusion set can occlude, set leakage, dislocation hardware, and since it's a bihormonal system, again, the problems related to that each system, switching of insulin and glucagon correctly has to happen. If one gets off, then all these are technical problems. Now let us look at the evidence, the effect of bionic pancreas on glycemic control. You can very clearly see there the mean blood glucose and the time spent below 70, how it has improved with the bionic pancreas. And this is another paper which talks about the outpatient overnight glucose control with dual hormone artificial pancreas versus single hormone artificial pancreas or conventional insulin therapy. All three arms have been compared in type 1, which is an open label randomized control trial. And these are the baseline characteristics, and these are the conventional, the single hormone, and the dual hormone comparison. You can very clearly see here in this slide the results of patients with at least one hypoglycemic event, the median time of hypoglycemia, and of course the number of hypoglycemia events. You can see on the dual hormone artificial pancreas, it's literally 0 when you compare with the conventional and the single hormone. And of course, artificial pancreas in India, this is one of the systems which is available, 780G, which is a self-adjusting basal insulin with a new autocorrection, which automatically corrects and adjusts the insulin delivery every 5 minutes. And this is the 3 components of this, which is available in a country. It's about 6 lakhs. And that's the limiting factor for most of our patients which are needy. And of course, it automatically adjusts, as I said, literally corrects everything, including there is a correction doses, which is there in this instrument. And based on this, there is a data which shows that 84% of the subjects achieved the goal and 79% of patients achieved the time in range when it results with this CGM. I mean the 780G pump. Yeah, this was the first generation. Of course, the hybrid system 670G was the dream of closing loop has become a reality with this FDA approval hybrid CL system, the 670G, where pump would increase insulin delivery when glucose is high and reduce automatically. Users still have to use boluses for this in this model. This was an earlier model. But they have been partnering with Dexcom and this another company, this DBGL1, where the closed loop, and they received the CE mark on about 2018 itself, and it is the second hybrid closed loop approved in Europe for adults in type 1 diabetes. And this Omnipod Dash is another one which launched in 2019, which is a very compact one. It's free from the hassles of tubing and these daily injections. And of course, this is one, the "We are not waiting," the hashtag which became a rally cry among the citizen hackers, basically, where they used the various apps in the Apple phones, the Android phones, all that, to combine with the available pumps. This is some evidence to show the do-it-yourself artificial pancreas, a comprehensive review with our own Jyoti Dev and Dr. Bansi and Dr. Sheshadri and Gopal Krishnan. They showed that improvement in quality of life, this is an Indian study which I'm quoting, quality of life after being on pump was appreciated by 92%, and the level of satisfaction was rated as fully satisfied by 52% responders. 26% found the pump is satisfactory, 90% thought that the pump met their expectations. That's the best part of that. And at a glance, if you see the CGM sensor, receiver, and the CAD, which is the algorithm device, with the insulin pump, this is what makes it, the artificial pancreas very handy, very useful for our patients who are affordable, of course. And what are the results of these is improvements in the technologies. You can clearly see the technology effect on improving A1C estimated from mean glucose levels. The pink one is the closed loop ones. You can see the better compliance. And also you can see the effect on improving time in range when it comes to the CGMs. And you can see in the pink areas, this is what is the smart guard technology with suspended automation has significantly showed the overall time in range spent by our patients. And of course, the unanswered questions remains whether it is justifiable to add glucagon to the artificial pancreas is a challenging question to answer. Single hormone and the dual hormone systems are yet to be compared in larger and longer period of studies with important endpoints such as incidence of severe hypoglycemia and A1C concentration. And the dual hormone system will likely produce reduced hypoglycemic events for sure, potentially improving quality of life, but it also necessitates an additional catheter and additional drug manipulation to be there, which again transmits into the cost. And of course, cost we need to keep in mind whenever in our country. Thank you very much for patient hearing.
Thank you, sir, for an excellent presentation. Next session. Questions at the end. Shall we take questions at the end of the session or?
Yeah. Saying the technology man is asking the question about technology.
Machine can communicate to a machine like a smartphone and give alarm of hypoglycemia. Is it a possibility of developing a hypoglycemia sensor? Or
I think it will happen, sir.
Or a cold sweat sensor?
It will definitely happen. I don't know, Sujay can comment if it is there available already in the market, Sujay? I'm not aware.
When the glucose is going down,
yeah,
it does send a signal to the smartphone telling you that it's going down.
Correct.
It will shut off automatically. That you can augment and say that alarm goes off.
Maybe the alarm.
It will not say that it's gone down
Gone.
to whatever.
Correct.
You're talking
Cut
about.
off.
The fact that it is going down, the current pump itself.
Itself will say it.
Yeah. Means can it communicate to the caregiver? Suppose I am.
Sorry,
I am going
this
down.
pump shuts off. It
Yeah.
shuts off the insulin itself.
Oh.
Shuts off.
So there is prevented.
It gives a signal to the smartphone. Now, there must be some technology of transferring that signal which comes to my smartphone as a patient versus going to you or somebody else who's a carer.
Sir, but the beauty of this is the insulin is cut off. By the time you have hypoglycemia, impending hypoglycemia is prevented.
Thank you.
Thank you. Thank you.
Yes, sir. Thank you, sir.
Thank you very much.
The next lecture is by Dr. Sujay Ghosh, Diabetes and Stem Cell Therapy. Are we there yet?
Good afternoon. A big thank you to the organizers for having given me this opportunity to interact with you on a topic that I knew very little about, but it gave me an opportunity to at least read up some of the stuff that I think is clinically relevant for us to know for years to come. So, can I have my slides right? Okay. So if we go back 100 years almost to what Frederick Banting said when he received the Nobel Prize, he said insulin is not a cure for diabetes. It was a way by which we were treating our type 1 children and young adults, but in no way did it cure diabetes. So that understanding was very clear at that point of time. The previous topic was on bionic pancreas, so actually we now can start off from where my previous speaker left, that we have various kinds of so-called artificial pancreases now, in which where you have a sensing arm, you have a program which is there in the pump itself, an algorithm which is there, and then a delivery device. Now the delivery device can be a single delivery device, like only giving insulin and shutting it off. It can be a dual delivery device where you have insulin going in and glucagon going in because when the glucose goes down. And there is now a triple device with amylin as the third compartment. So, but with all said and done, you know, technology is good, but we still haven't reached the kind of level that we would actually want to reach. So, My previous speaker has already talked about all of the possibilities and the pros and cons of this kind of bionic pancreas. The other thing that we had spent a lot of time in the last 2.5 or 3 decades is, are you able to detect type 1 diabetes early enough? And if you are able to detect it early enough, if you go for various kinds of immunotherapy or modulatory therapy as well, can you actually do something about it? It didn't turn out to be great and with a lot of side effects. Then came first the pancreas kidney transplant, followed by islet transplantation. Now we've realized that even that has limitations, but still the Edmonton protocol, which has been formulated in Edmonton, Canada, is still perhaps one of the best developments that we've had in type 1 diabetes in terms of islet transplantation. Now, the beta cells you're putting in somehow, whether in terms of islet transplantation or other, but there are various methods in which you can actually go for beta cell replacement therapies. The first, of course, was the pancreatic transplant. Then we talked about islet transplant. Then selective beta cell transplant. And I'm going to talk about stem cell therapy, the progenitor stem cells. Now, whatever I show or discuss here, we've got to remember we are trying to be oversimplistic because the islet essentially is a microorgan. Just putting in the cells does not help. There is a permutation and combination of cells within it which acts as a functional unit, both with local, neurohormonal, and paracrine interactions, which actually is the beauty of the islet as a microorgan. We still haven't managed that. Even at the end of the talk, I'll show you this is not something that we've managed. We are only going to talk about stem cells. What are adult stem cells? These are undifferentiated cells that occur in differentiated tissues. That means, look at your liver. It's a differentiated organ, but there'll be some cells in it, for example, which are undifferentiated. These cells are able to make identical copies of themselves or something else as well. And they are able to yield specialized types of cells of tissues, mostly from where they originated, but they cannot go on replicating indefinitely. And if you look at the kind of stem cells that we have, I'll just skip this slide, just don't read what's written there, just think of what I've told you is that stem cells are there in every organ. When we were undergraduates, we thought, it's only bone marrow cells where you have the progenitor cells, you take that and you infuse that, that's where the stem cells are. No, it's there everywhere. And if you look at the kind of research that's going on, even for a missing tooth, people want to regrow a tooth. So you name it, people are trying it. So if we talk about stem cell therapy in diabetes per se, we are essentially talking about 3 kinds of origins or mechanisms by which we are talking about stem cells. The first is embryonic stem cells. Then there is induced pluripotent stem cells. And we are talking about adult mesenchymal stem cells. Of the 3, I'm going to talk mostly about the one at the bottom because that's where probably the future is. And this is just a cartoon to try and show you what comes from where, but the next few slides will probably be more illustrative. So first, let us talk about embryonic stem cells. Just imagine an embryo. It has a potential to become an entire new organism. So this has unlimited plasticity. You take an embryonic stem cells, you can grow anything from that. But there are huge ethical concerns because you are taking a human pre-implantation embryo and then extracting those cells from there. It has ethical issues. Technically, it's very difficult. And you've got to remember, all of us will remember when we first read about development of pancreas, maybe a little bit in embryology during anatomy days, and then later on when we talked about diabetes and other things, of all of those transcription factors. Now you take that cell, you have to treat it appropriately with these transcription factors so that it develops into a pancreas. So it's not easy. It's tough. And to get something which is, you are going to make something on a scalable form, like for example, you have human insulin now, recombinant DNA technology. This is probably still very distant in that. And the yield is very low, whatever you try, whatever you do. Now, and the other thing is that there is possibility of malignancies, because whatever is there in that embryonic cell, you are trying to stimulate it, modify it, it will have the inherent properties of the source. But because of all of these stimulants that you are using and playing with the cell cycle, the risk of malignancy in these individuals is going to be high. The other issue is, now let us imagine you've made it, and you're now putting it into the person who's getting it as a donor. There, the immune system of the individual is going to attack it, because it's not having the same MHC class as you are having, and it's going to get destroyed. The other issue will be about the vascularity, development of vascularity in the cells that you provide. So for that, to bypass that, there's now a concept of macro encapsulation. I'll talk about that. And there's always that chance that, like I said, the malignant transformation. And I did try to look at the number of clinical trials that are registered. There are actually several trials that are registered, but there's only one clinical trial that has actually been conducted, which has been done in type 1 diabetes, to show that once you've given this, the hypoglycemia unawareness group of people, there has been some reduction in the insulin requirement. That's it, nothing more than that. And that same company has actually registered for 2 more trials to see whether by macro encapsulation there's better vascularization of the graft and whether that works better. So as of now, embryonic stem cells still looks somewhere close to Pluto or Neptune. Let's look at the next one, that is induced pluripotent stem cells. Now, a lot of us will remember when we were doing our MD and post-graduation, Dolly the sheep came up, and Yamanaka, whatever his name is, he got the Nobel Prize for it. So essentially, what they do is they came up with this concept that you take any somatic nuclei, a cell that has a nucleus, and by subjecting it to various inducers, including certain microRNAs, recombinant proteins, you can transform that nucleated cell into any kind of other cell. So that could be transformed by inducing a pluripotent stem cell. That's the basic concept of induced pluripotent stem cell and its role in developing either a particular tissue, in fact, this is very popular now for skin grafts. Artificial skin grafts is induced pluripotent stem cells derived. And you can perhaps go into and make a pancreas. But the next slide will tell you it's not easy to make a pancreas or a beta cell. And you can see there are so many, various factors in the correct manner, in the correct timing. You've got to go from here to there to create a mature beta cell. And this was a difficult process, particularly because, you see, pancreas has got an exocrine part, it has got an endocrine part. Even the endocrine part has got alpha cell, beta cell, gamma cell, epsilon, kappa, so many cells. So they were struggling. So they came up with certain promoters and certain inhibitors, which would block off the development into other pancreatic cells and help better of producing beta cell. And therefore, they have at least managed to do certain things. But again, this has the same problems. Number one, because you are going through so many inducible factors and inhibitory factors, the risk of malignancy is high. And secondly, because you are treating it in a culture media of so many things, it is very immunogenic. So once you put it into an individual, the chance of rejection is pretty high. So finally, we come to the third bit, which is the mesenchymal stem cells. And like I said, I always thought that most of the mesenchymal, stem cells that we talk about come from bone marrow. But now we know that almost in every organ, you have pericyte mesenchymal stem cells, which are outside the bone marrow. And The advantage of this second group of mesenchymal stem cells is that they come as a package. The stem cell is there, with it X, Y, and Z is there. That X, Y, Z cells has certain immunomodulatory effect, as a result of which that mesenchymal stem cell seems to be less immunogenic and more protected once you put it inside a host cell. So what essentially they do is they go for transdifferentiation of the mesenchymal stem cells into insulin-producing beta cell. That complicated pathway that I showed, that again works here from the inducible pluripotent stem cells. But still, even after transdifferentiation, it's not a very effective way by which you take 100, maybe you will come down finally to 5, 6 cells, something like that. And if you look at mesenchymal stem cells and the number of clinical trials, 850 trials for various different things are there, of which there are about 12 or 15 which are related to diabetes, mostly type 1. And there's only one which completed the clinical trial in terms of transplantation of islet graft survival and function. And what most people have done is they have gone for islet transplantation. Along with that, they have put in mesenchymal stem cells to see whether the combo will actually work better. And what they have shown, this actually one of the first is already published, it reduced insulin requirement in the peri-transplantation period, reduced decline of C-peptide level after 6 months, and lowered fasting glucose level after 12 months. The co-transplanted reduced loss of the islet graft cell because they went and colonized where the islet cells were colonizing as well, and it was like a boost rather than it working alone. Additional studies and long-term observations are needed because this data is actually published in only 3 patients. That's the clinical trial of only 3 individuals. There are other abstracts and other publications of 7 type 1 diabetes studies and 8 type 2 diabetes studies. And the results are pretty heterogeneous rather than me being able to give you a really good summary. And there's been varying degree of partial improvement in glycemia. But one thing was clear in those studies in terms of indication. The ones who received it versus the ones who did not receive it, the ones who received had relatively lower diabetes-related complications. Now, all of us will remember that when we talk about pancreatic transplantation, there are studies to suggest there is reversal of diabetic retinopathy, there is reversal of diabetic kidney disease. So could this actually be reversing some of those things? Now, one of the things that I've already told you is, this is not diabetes educator, by the way, is rejection of a graft, right? Here is now a concept. What they are saying is, before you put those cells into the body, if you separate the WBC and this, and then partially self-treat that with the patient's blood and leukocyte, there is kind of immune tolerance. So once you put it back in the recipient, the rate of rejection is low, as if the stem cells are getting educated about your immune environment.
Excuse me, sir.
So the other thing, just 2 minutes. Sorry. Because it's too complicated for me to finish in 15 minutes. So the other thing that I was talking about is protecting the transplant. So there's a strategy of encapsulation strategy which looks something like this. So that, you're protecting it from the direct immune attack. The contents come out much more easily rather than the WBCs getting into the encapsulated compartment. And there are several other things which are going on, half of which I do not understand, maybe more than half I don't understand, of strategies that people are trying to do to improve things. So when we talk about beta cell from stem cells, how close are we? Insulin gene expression from these cells, we've achieved it. Insulin synthesis and processing from these cells, achieved it. Insulin packaged and storage in granules, that has been demonstrated. Nutrient sensing systems, so that the insulin comes out only when the nutrient is there, that has been achieved. Insulin and C-peptide release, yes, but receptor regulated insulin release, we haven't achieved yet. Regulated insulin intra-islet interactions, which I showed you at the very beginning about alpha cell, beta cell, and all of that, that hasn't happened. Regulated proliferative capacity, this is important because you're playing with God. So you have to make sure that you don't land up with malignancy. That we haven't got yet. So in type 1 diabetes and type 2 diabetes, if we look out at the future outlook, the ultimate goal is what you and I know, unlimited supply of insulin secreting cells that will not get destroyed either by immuno mechanisms and all of the other problems that I've already talked about. Finally, before I finish, do we really need stem cells? Why not reprogram your alpha cells? Because in type 2 diabetes, at least we know that the beta cells become alpha cells rather than so-called beta cell failure. So you can, if you can reprogram the alpha cells back to beta cells, that should be good enough. Thank you very much.
Thank you, sir. Couple of quick questions. Thank you, sir.
Thank you.
Just a minute. And Dr. Srinivas, can you please come on the rise? I now invite Dr. Nk Singh for the immune system in diabetes, clinical implications.
Thank you very much for asking me to speak on the immune system in diabetes, clinical implications. And this kind of carries on from where Shujoy has left off. The problem with the diabetes system, can I have the slides, please? system. And though this chap wants to have the thing work only on the weekdays and not on the weekends, in diabetes it seems that there is a vicious cycle of diabetes and hyperglycemia which impairs innate immunity, which impairs humoral immunity, which impairs T-cell function and impairs cytokine function, which along with problems like neuropathy, which makes sensation of any kind of injury or any kind of stress response or poor diet, adequate insulin therapy and hyperglycemic effect being worsened by antibiotics and corticosteroids, makes infections become even worse than they were originally supposed to be. But why is that? Because different immune functions found in diabetes patients, the innate immunity, the adaptive immunity or the adherence, are all worsened by diabetes. There is a reduction of complements, there's a increase of cytokines without stimulation and a reduction of cytokines after stimulation. Immunoglobulins are not changed. Polymorphonuclear leukocytes do not work very well. Monocytes and macrophages do not have the similar power of swallowing up microorganisms as they did. And T lymphocytes do not remember to kill off the microbes like they would normally be found. And this leads to viral infections. I think viral infections are very topical now. Viral infections can cause pancreatitis with reduced beta cell function, and that leads to type 2 diabetes. And viral infection can also cause immune activation, which leads to the release of cytokines like TNF-alpha, like interferon gamma and IL-6. And these work on the muscle and the liver, worsening insulin resistance, which further pressurize the pancreas to produce more insulin. And this oversecretion of insulin leads to even more immune activation, making viral infections so much more dangerous in diabetes. In bacterial infections, what happens is the sugar molecule binds with protein to increase advanced glycation end products, and obesity, dyslipidemia, circulating free fatty acids, all these things, they all kind of combine, they kind of connive to get together and lead to malfunctioning of the neutrophils. And what does this malfunctioning of the neutrophils lead to? It leads to, on one hand, impaired bacterial clearance, and on the other hand, inflammation and tissue damage. The impaired bacterial clearance is mainly due to reduction of phagocytosis, and also due to reduction of chemotaxis and intracellular ROS coming down. The neutrophil phenotype also leads to apoptosis of the cells and increase in pro-inflammatory cytokine productions and extracellular ROS. So all these worsens the inflammation that an infection causes and worsens the tissue that it is affected by the bacterial infection. Not surprising, we have major infections associated with diabetes, respiratory infection, pneumonia is more common, influenza, tuberculosis, urinary tract infections, gastrointestinal infections including H. pylori. We get fungal infections of the gut. We get skin and soft tissue infections like foot infection, which is very common. There is chance of necrotizing fasciitis and Fournier's gangrene. And also we've recently been exposed to mucormycosis and HIV. Now this is taken from a paper which was before COVID hit our country, but it is no doubt, even before COVID hit, infections were one of the leading causes of death in people with diabetes, which includes infections not affecting the lungs and also includes people who get pneumonia to the tune of 67% higher of incidence of death in pneumonia from diabetes and about 2.5 times death in people with diabetes compared to people without diabetes. Now, this is a quantification and this is a retrospective cohort. Almost half of all people with diabetes will have one hospitalization for infection-related problems. this is about 2 times normal, and death is also increased in people with diabetes. So diabetes in itself confers an increased risk of developing and dying from an infectious disease. And this translates into not only an increased risk of hospitalization, which is increased 2 to 6 times, it also increases the cost of therapy. And in India, this is a very important thing, because 50% of the cost of therapy of diabetes is attributed to infections due to immune failure that we see. In fact, people who get hospitalized for diabetes have a 27% chance of reinfection. Among those readmitted, 87%. So these are not people who are coming for a routine lab chole or something like that. These are people who get readmitted again with a different illness again. We come to COVID, and there is evidence that pre-existing diabetes is associated with an increased risk of having severe and critical COVID illness and a 3 times increased risk of in-hospital mortality. This meta-analysis shows that severity and mortality is very largely increased in patients with diabetes when compared to non-diabetics due to the immune failure, the inability to clear out the virus that I showed you a little while ago. Pre-infection glycemic control and disease severity among patients with type 2 diabetes and COVID-19. This is quite a seminal paper because there's no prospective data as of now. And as you can see, the increase in HbA1c is associated with worsening of immune function and increased risk of severe COVID-19. So it's almost an inflection point that if patients have a HbA1c of more than 7.9%, their chances of developing COVID-19 becomes much more, almost exponentially higher than people without COVID. And not only is that the case, the opposite of it. So if you reduce the glycemia, by as little as 0.21%, you get a reduction of 21% risk of developing severe COVID. Reduction of 1% will reduce 21% risk of getting severe COVID or COVID-related death. Another important aspect is tuberculosis, particularly in our country. But let us just put it into perspective. Even in the United States of America, 1 out of 5 people with TB has diabetes. So this is another infection which is very important because they are very strongly interrelated, one worsening the other. Tuberculosis worsens diabetes control, and diabetes worsens tuberculosis with reduced cellular immunity, worsening of all the infection fighting cytokines, and also in tuberculosis, the stress response to infection is worsened with increased interleukin 1, interleukin 6, and TNF alpha. There is also TB, pancreatitis. All in all, this leads to one making the other situation worse. So there is 2 things that are known to improve tuberculosis and outcomes. Statins reduce the risk of active TB and reduces the TB severity. Metformin also reduces the risk of primary infection, risks of active TB, and also reduces TB severity. In fact, weight loss that is associated with metformin is also associated with an improvement in immune response, which in turn improves the outcomes of tuberculosis. So I'll move on to another area which I think is important, which is vaccination, and I think this is something that we've been missing out on. I think is particularly important for these people who are completely stunned to have proper vaccination. Pneumococcal vaccine for everybody in the age group of 2 to 64. Influenza vaccine, that is just once in a lifetime, and a booster shot at the age of 65. Influenza vaccine every year, preferably the quadrivalent vaccine. Hepatitis B vaccine, 2 or 3 series. These are musts for all patients with diabetes, and all other vaccines should be given, including the COVID-19 vaccine. I thought there's one other area which I will address before I let you go. And one thing that is definitely associated with worsening glycemia is immune response. And this is why a lot of surgeons tend to not want to operate. Now, if you look at the surgical guidelines, there is no reason not to operate on a patient when they have glycemia in the range of 200 or 300. In fact, the surgical guidelines actually say that you should be careful only if a patient has a blood sugar level of 400 or 500, and anything less than that is good enough for a patient to be operated on. And in these situations, there is no kind of worsening of glycemic control. Thank you very much for listening to me.
Thank you, Dr. Sinha, for this excellent. We are sorry for the technical.
No, not at all.
So next, I'll invite Dr. Mangesh Tiwaskar. The topic is COVID and obesity, a bidirectional impact. Dr. Mangesh.
एक talk prior. Well, good evening, everybody, and a special thanks to the entire team IDEC and, of course, Dr. Unnikrishnan for being so courteous. And, of course, Sujay and Sinha sir. It was mind-boggling talk. Of course, the icing on the cake was Srini spoke on a very difficult topic. But Sujay, that was an awesome presentation. You know, there's so much of, I would say, lucidity to such a dry topic that you got in. I was really, truly mesmerized. And I thought that let us exchange a couple of sessions or let us cancel a couple of sessions and allow Sujay a couple of more sessions to continue. So that was my feeling was, right? So let us put hands together to Dr. Sujay Ghosh, please. Thank you very much. Beautiful it was. And of course, Dr. Sinha also has set a stage where immunity starts playing a trick. And what better experience that we all had rather, when we all managed our COVID patients. Where, probably rather than a viral disease, it was an absolute immune blizzard which actually hit the society. And then people were wondering, and all kinds of ideas and thoughts were coming up. We were trying to find out the risk factors. Initially, if you remember, during the first year, Srini, we talked about, it is possible that the patients, those who are smokers, those who have got COPD or bronchial asthma patients, these are the patients who are most likely to suffer with a very severe COVID, but which was completely untrue. In fact, we have found out that smokers were protected. COPDs, those who are on with inhaled steroids were protected, right? And then came a good amount of publications, which started slowly establishing as the knowledge evolved, which still is evolving, that there are so many factors which determine the intensity of the COVID and the COVID-related outcomes in various comorbid conditions. And one such is on your screen is obesity, where you can see that the hazard ratio is nearly 6 times higher. And we all know that obesity is a pandemic. So let's talk about this bidirectional relationship between COVID and obesity when these two pandemics have collided, how it has really impacted all of us. According to me, COVID and obesity was a making of a perfect storm. It was a path of a perfect storm. There are a few disclosures that I have before I really deliberate on this topic, is this that let us understand that our COVID knowledge is still evolving. Don't take COVID as over. It can hit you back, and it still continues to teach us many things. And the discussions based are on the lot of data and publications which have come up. And I'll just give you a bird's eye view because it's a huge topic. Now, sir has already said that COVID and obesity is a bidirectional relationship. But one thing is for sure common, is a very high mortality and morbidity associated when these two combine together. So let's see first what obesity does to COVID. and how obesity treats COVID. And it's not a rocket science. Now we all are very well aware that the moment somebody is obese and the BMI is more than 35, the chances of hospitalization and the related complications, including the invasive ventilations, are technically nearly 6 to 7 times higher. And there's a good UK data which has been published, where you can see that the chance of these patients getting hospitalized because of the COVID-related complication goes up by around 2.5 times. The chances of getting admitted into the intensive care becomes more than 4 times higher. And the chances of being on the mechanical ventilation is nearly 6.5 times higher. So that is the impact of COVID. And it was not just true in adults, but it was true in the French studies related to obese children. And not only that, COVID and obesity also increases the hospital stay of the patients. And not only that, the chances of recovery or the delayed recovery is very, very high. So people living with obesity, they will have a very stormy course if they are hit by COVID, and a small COVID insult can really inflict a huge damage, which is obvious on this slide, where you can see that the chance of being just positive with COVID increases by nearly 50%. Hospitalization goes by around 115%. The intensive care need can go up to 75% up. And most importantly, the chance of dying is 48%. Now, if I say 48% or 50%, it may not really intensively hit you here. But what if I say that every second patient has a chance of higher mortality? Now, that is what COVID and obesity relation is. And they'll suffer longer, they'll develop more complications, and they'll stay a long time in the hospitals. And remember that more the patients are bedridden, the chances of high mortality exponentially goes up. So the million-dollar question comes, why this association? Why this lethal association? Why these intertwined dragons, they prove to be so much mortal? And we all have seen, in fact, beautifully talked by Dr. Sinha, it's the relationship of immune story. But of course, obesity has its own challenges. We all are aware about it. Pulmonary challenges for sure, impaired pulmonary perfusion leading to hypervascularity and hyperviscosity leading to the COVID-associated coagulopathy. Along with it, the chances of, a proper ventilation goes down. The prone ventilation we talked about was not very adequately addressed. Of course, there is an associated endocrine dysfunction where not only diabetes, as probably Unni is going to talk about, but the other endocrine organs, they also suffer, which ultimately leads to high cardiovascular and metabolic challenges. But the most important thing, on the platform of the chronic inflammation that obesity has, with COVID, there is a dysregulated hyperimmune response. So this immune storm which we talked about, or that is never an immune storm, that is usually a dysregulated, desensitized immune response, which is responsible for this high mortality. We all know that ideally, all of us should stay in what is called as an M2 environment, which is a anti-inflammatory environment, where there is a good amount of T helper lymphocytes which are there. The eosinophils are fairly fine. But the moment there is an obesity, it doesn't take longer time to change this M2 environment to M1 environment because of the elevated fatty acid levels, the insulin resistance, the leptin resistance, the high levels of leptin, reduced levels of adiponectin. But the most important factor which actually affects the COVID outcomes is a high expression of ACE2 receptors. Now, Sujaya has beautifully said us that nature is so great, and he actually demonstrated it in his slides that you cannot beat God. And obese people, they have got a natural protection of higher number of ACE2s. And why ACE2s are important? We need to understand the importance of ACE2. ACE2s are important basically because this is the enzyme which will inhibit or neutralize the angiotensinogen 1 as well as 2, which are actually responsible for vasoconstriction, reduced tissue perfusion, or to certain extent elevation of the blood pressure. Now this is how the RAS system works, and this is an inhibitory mechanism which protects. So a 1,9 angiotensinogen 2 gets converted into a 1,7 a protective angiotensinogen through the ACE2 receptors, and they are high in number. But then that has become a challenge in obese people, basically because we know that virus hits the ACE2 receptors and it needs an ACE2 receptor for the cellular entry. And that's how it utilizes all that ACE2 which is available. So there is a high amount of viremia and replication which is happening. So in the obese patients, where there is already a very high ACE2 expression, these patients are extremely vulnerable to develop very severe hyperemia in comparison to the non-obese people. So wherever there is an ACE2 increase, there is an increased viral entry, viral load goes up, inflammation goes up, and of course that ultimately ends up into a severe cardiometabolic and respiratory insult leading to the complications. But apart from that, when it gets combined with obesity, where there is a pulmonary challenge, there is an endocrine challenge, there is an inflammatory challenge on the base, the ARDS, the ventilation perfusion mismatch, which will ultimately increase the chances of invasive ventilation, will also increase the morbidity and mortality. There are a few other roles of some other receptors as well. One is what is called as a glucose regulated protein 78. As ACE2s are, glucose regulated proteins 78 are also responsible to stop the premature cell death or to stop the premature cell apoptosis. But they also need, I would say, a proper regulation, and COVID virus also attacks this GRP78 protein, and which is responsible for actually prevention of cell apoptosis. Another way is this, that GRP plus additional endoplasmic reticular stress, which is basically because of obesity, will increase the viral entry, will reduce down the GRP78 availability, will increase the cellular apoptosis, and the chances of cellular death goes up significantly. Insulin resistance, Unni is going to talk, I'm not going to dwell into that, but also because of the obesity, you have got very high leptin levels because of the leptin resistance, and we all know the impact of leptins. I'm not going to go into the details about it. There are a few other mechanisms which I don't want all of you to remember or go through, but just see this, that these are the proteins and various expressions of the receptors and the receptor proteins which actually increases the chance of complications at the vascular level. They'll increase the angiogenesis, they'll increase the vascular viscosity, and they'll also increase the chances of hypercoagulability that ultimately leads to what we call it as a COVID-associated coagulopathy. And COVID-associated coagulopathy, we all have learned during our COVID times, is a big challenge. Last 2 minutes, I'll be talking to you about COVID and obesity. What is the relation of COVID with obesity? Now, what COVID has caused to the obese people? We always talked about what obesity has caused to COVID people, but let us see what COVID has caused to the obese people. Now, that is last 5 minutes. So, poor mobility, limited access to the medical care, technically, especially in the first 2 waves, all the medical as well as surgical programs for the management of obesity halted. Obesity clinics stopped practicing. Endocrinologists stopped practicing obesity. They were all busy managing the COVID and the related endocrine challenges. That has changed the eating habits of the people because of the lockdown. There was an increased screen time and psychosocial stress. And here I am saying social media stress that the people went through. And these have all impacted not only on the obesity, but you can see that there were strained food systems, processed food consumption was very, very high, changes in the eating behaviors were very high, and there was a tendency to consume unhealthy, high sucrose, high saturated fatty acid food which was available. And that was the challenge. And this is a beautiful study which was published from Italy, where they have shown that you can see that various meals and look at the significance. And apart from that, added psychological disturbance like anxiety, depression, stress, and PTSD added to binge eating, or what we call it as bulimia nervosa. People kept on eating very, very badly. And that's the reason why we need to understand it is just not obesity impacting the COVID outcome, but COVID also has impacted the outcomes of obesity significantly. To summarize, friends, with all this complicated, very intricate relationship that COVID and obesity has, let us understand that obesity increases the risk of COVID-related hospitalization, ICU stay, and COVID-related or COVID-associated coagulopathy. There are social determinants of healthy obesity and chronic diseases, and severe negative outcomes from COVID were all reported not only in India but throughout the world. And these negative impacts also affected a mental health of the people, which additionally caused a lot of psychosocial disturbances, which we probably, being Indians, we do not actually attribute these facts very seriously. But this is the time to learn about addressing these factors very seriously. Thank you very much once again. Thank you, Anjali, for this beautiful opportunity. I really appreciate, and once again, thank you, Dr. Unni, for a favor that you did to me. Thank you very much.
Thank you, Dr. Mangesh. Now let me invite Dr. Unni Krishnan, new onset diabetes in post-COVID era.
First of all, I'd like to thank the chairpersons, also Dr. Sanjay Agarwal, Dr. Anjali, and the team for this wonderful meeting organized at such a wonderful location. May we have the slides? Yeah. So I'm going to just talk about new onset diabetes in the post-COVID era, and lots of what I have to say has already been alluded to by Dr. Mangesh Tivaskar. Nevertheless, there may be some points of new points which I might mention. So let me begin with a case. This is a 27-year-old lady who just came to see me recently. She had COVID and diabetic ketoacidosis together in 2021, and her GAD antibodies were positive. So the doctor wasn't sure that whether it is type 2 or type 1, and the doctor put her on twice daily a mixture of IDEC asp, which is degludec and aspart and metformin, when she came to meet me, and she has been taking that for nearly 1 year or so when she came to meet me, and she was referred by the doctor. And her fasting was 195, and the postprandial was also high, and the HbA1c was 8.4%. So this is a typical case of diabetes having its onset during COVID, but this was unusual because it was like a type 1 diabetes, and the patient also had diabetic ketoacidosis. So there is a lot of theory as to how the COVID virus and the similar viruses affect the pancreas, because the pancreas itself expresses ACE2 receptors, and these ACE2 receptors preferentially attack the endocrine cells, because these ACE2 receptors are expressed more in the endocrine tissue than in the exocrine tissue, and the virus binds to the ACE2 receptor on the beta cells, you get diabetes. So this is a study, and this is done before COVID. It looks at the SARS-CoV receptor protein, and this paper was published in 2010. So here in section A, you will have, you can see the pancreas, you can see the islet, and in section B, you will see the general staining, but here you will see the preferential staining on the endocrine cells and on the beta cells, in particular in the pancreas, showing you that the virus binds to the ACE2 receptors, which are preferentially expressed in the beta cell. And like it was mentioned by Dr. Mangesh, during the pandemic, and especially during the lockdown, there was an increase in high carb food, there was an increase in sedentary activity, there was a lot of stress because people were following the numbers which were going up and down in different parts of the country and the world, and therefore this itself could have triggered diabetes. Now what happens is any COVID or any infection or any inflammation for that matter causes the release of cytokines IL-1, IL-6 and TNF-alpha, which will block insulin production as well as cause insulin resistance. In addition, the same inflammation can also cause glycogenolysis, gluconeogenesis and reduced glucose uptake in the skeletal muscles, and all these can trigger hyperglycemia. So as you can see, hyperglycemia glycosylates the ACE2 receptors, makes them probably more active, and the SARS-CoV-2 virus can bind to it, and that causes beta cell dysfunction. In addition to that, all the cytokines also produce insulin resistance, and sometimes when there is insulin resistance, the beta cell starts releasing antigens including insulin, and that drives an autoimmune disease. And in addition, people have hypothesized that this hyperglycemia-induced glycosylated ACE2 may trigger an immune response which lead to beta cell dysfunction. As Dr. Tivaskar mentioned, the ACE2 is down-regulated, and that causes angiotensin II to rise, and angiotensin II binds to the AT1 receptor. It reduces insulin signaling and causes oxidative stress, and that in turn precipitates both type 1 and type 2 diabetes. So COVID can trigger, it may not be the cause of diabetes. I don't think that there's enough evidence to say that COVID is causing diabetes. It may trigger a tendency to type 2 diabetes or type 1 diabetes in people uniquely predisposed. But there might be a subset of people who actually get post-COVID diabetes. Difficult to make out because people during COVID have stress, inflammation, cytokines, steroid therapy, hospitalization, and that itself might cause hyperglycemia. Now in this paper, which was published in 2022, fairly recently, they looked at the incidence of newly diagnosed diabetes after COVID. And the aim of this work was to investigate diabetes incidence after infection with COVID-19, and people with upper respiratory tract infections, which are frequently caused by the viruses, was looked at as a control group. So in the control group, they took people with upper respiratory infections, not COVID, and in the case group, they took COVID patients, and they found that people who had COVID, when compared to people with a simple URI, had a 28% higher risk of diabetes, and that was compared to normals, and compared to the upper respiratory tract infection, it was about 14%. So therefore, people with an upper respiratory tract infection versus COVID people had almost a 14% increase in new onset diabetes. And when you look at healthy individuals who never had an upper respiratory infection, the chance of getting COVID was even higher. It was about 28%. And this is, they excluded, very interestingly, very importantly, they excluded patients who were in the ICU who received steroids, because that itself can cause hyperglycemia. So they excluded that group, and then they saw, and in the blue color, you will see the COVID patients, and in the red color, you will see the upper respiratory tract infection patients. And very clearly, people with COVID have about 12 to 16%, let's take a ballpark figure of 14% higher chance of developing incident diabetes. And this is the incident rate per lakh of diabetic ketoacidosis diagnosed between January 2019 to September 2021. So the pink color shows people who don't have COVID, and the blue color shows people who had COVID. And this is seen in a nationwide cohort from the US, and you will see this with each month, August, September, October, November, December. You will see that the red line is actually coming down and the blue line is going up. In other words, diabetic ketoacidosis, which was there, started coming down, and the COVID-related decay, going up. Now, is this really COVID-related decay? I don't think so, because as you can see, any diabetic ketoacidosis occurring in the COVID pandemic got classified as COVID-induced. And I also had many patients who had type 1 diabetes after COVID, and In fact, I remember one was also a doctor's son, and they all thought that this is post-COVID diabetes, it won't go away, but actually it's just type 1 diabetes, just got triggered, or it's just simultaneously, by coincidence, both came together. So this is another paper which shows that COVID increases the risk of diabetic ketoacidosis, and you can see that the authors looked at all the articles and they compiled the information. And like I mentioned, SARS-CoV will downregulate the ACE2, increase the angiotensin II, that drives oxidative stress. The immune status is altered, and that predisposes people to autoimmunity. There is a cytokine storm which causes insulin resistance. Pancreatic cell damage causes hyperglycemia. And the management is really nothing but classic management of diabetic ketoacidosis. Just because somebody has got COVID, you're not going to manage in some other way. You're going to give insulin infusion, you're going to treat as DK, and of course, you need to look at long COVID and look at new onset diabetes. This is again the probability of DK going up. And therefore, if you look at people with diabetes and uncontrolled hyperglycemia, both prolonged hospitalization, assisted respiration, comorbidities, nutritional depletion, prolonged recovery, all these can predispose people to long COVID as well as post-COVID and diabetes. And factors which contribute to post-COVID syndrome or long COVID are worsening of hyperglycemia, sarcopenia, which means loss of muscle mass, poor nutrition, electrolyte disorders, worsening of the comorbid diseases which pre-existed, infections, psychological stress, diabetic neuropathy, autonomic dysfunction, and the use of corticosteroids. And what is the solution? The solution is just common sense: good glucose control, blood pressure control, nutrition deficiency correction, counseling, rehabilitation, physiotherapy, exercises, treating infections early, and early stopping of corticosteroids. This is another paper which was published recently which looks at the burden of incident diabetes in long COVID. And if you look at the control group, people who had 30-day survivors of COVID exhibited an increased hazard ratio of about 1.4, as you can see, and an excess burden per 1,000 people of incident diabetes, and increased risk of use of anti-hyperglycemic agents, as well as the composite outcome. So if you look at people, the outcomes were ascertained from day 30 after COVID-19, and from that day to the end of the follow-up, and they looked at adjusted hazard ratio, and they looked at event rates per 1,000 people at 12 months for the COVID group as well as the control group. So at the 30th day post-COVID to 1 year, they looked at these people and they found that people who had COVID had a higher chance of diabetes, a high chance of anti-hyperglycemic drug use, as well as composite outcomes. So newly diagnosed diabetes versus pre-existing diabetes on admission for COVID-19. What are the chances? One important thing is that people with newly diagnosed diabetes at COVID, they had a different profile, a slightly different profile. In fact, so this is a paper which came out suggesting that post-COVID diabetes is mild. But this is half of these people with COVID-19 and newly diagnosed diabetes regressed to normoglycemia or pre-diabetes. But these were probably stress hyperglycemia because of stress of infection, inflammation, steroid therapy, hospitalization. So stress hyperglycemia may be the reason for this, and really it's very unlikely that they just had a temporary beta cell damage because of ACE2 receptor binding, and that went away after some time. Another interesting thing is that people who are diagnosed with diabetes at COVID presentation, their blood sugar levels were not that high, but their inflammatory markers and ICU admission was higher. Again, that suggests that stress hyperglycemia could be the major pathophysiological mechanism, and half regress. In other words, COVID and diabetes, in my view at least, exist quite simultaneously. I've closely looked at most of the COVID patients who say they have got post-COVID diabetes. I found that even before COVID, they seem to have a high or borderline high HbA1c. The second thing is those who regress don't really have diabetes which is triggered, but probably they have stress-induced hyperglycemia which just got better. And the other group, which really had diabetes type 1 or type 2, and COVID nearly gave the final, the final issue that broke the camel's back sort of situation. So coming back to this lady, she was on a co-formulation of insulin and of a degludec insulin and aspart insulin twice a day and metformin with high sugars. So she has got a typical type 1 diabetes. Maybe she had type 1 diabetes before and COVID actually triggered that and she got DKA because of inflammation. So I stopped the IDEC and I started her on degludec and Fiasp, and on that I started also on continuous glucose monitoring, and you can see she's got a good time in range. A time in range of 70 to 180 of about 70% is okay. Her time in range was about 82%, but you can see she's a lot of hypoglycemia, 7%. So the dose continues to be adjusted. So how did I treat her? I just treated her like any other type 1 diabetes with GAD positivity and DKA. Just because she had COVID, that made no difference to my treatment. I really question the concept of a pure COVID related diabetes. So why does all this happen? Why does hyperglycemia happen? It may happen because of inflammation, because of baseline autoimmunity with which patients with COVID get pushed into diabetes, insulin resistance, and yes, ACE2 overexpression in the beta cells of the endocrine section of the pancreas, and the glycosylation of ACE2 might trigger people to get diabetes when they get COVID. How common is it compared to people who never had COVID? Never had URI, it's about 28% higher. Compared to people who had a URI, it's about 14% higher compared to an ordinary URI. And what to do? Don't look at a specific type of COVID-related diabetes or long COVID-related diabetes. Treat the diabetes based on the clinical finding that you see, whether it's type 1 or type 2, and treat according to guidelines. If the patient is in hospital, you'll have to give insulin. If it's type 1 diabetes, you'll have to give insulin. If it's type 2 diabetes, you'll have to manage with diet, exercise. And if the diabetes gets better, I never think that it's because of COVID-related diabetes which got better, because if we see that study, it's clearly stress-related hyperglycemia which got better. Friends, ladies and gentlemen, pleasure talking to you. And thank you so much for listening to me.
So, as we come to the end of this session, if there are any questions, please feel free to ask these questions. Panelists are here. And if there are any questions, please feel free to ask them. I have a question for you, Unni sir.
Yes.
Now that we have come so far ahead in understanding the pathophysiology of COVID and given a choice, would you like to give steroids as initial therapy, or would you like to avoid steroids in such cases?
So, very interestingly, or rather very importantly, we are a pure diabetes hospital, but during the pandemic, especially during the second wave, we transformed ourselves into a COVID hospital. So we could see, we divided our hospital into two. The diabetes patients were in one part because we had a dialysis unit and the cath lab and all that. And the people who were pure COVID were on the other side. We built a new wall. We set up a new casualty for COVID patients. So we had good experience of COVID people. And because it's a diabetes hospital, virtually everybody had diabetes. So what we did at that time, the protocol we did was only in moderate and severe cases we started steroids. Otherwise, we never used steroids for mild cases, and definitely for the OPD patients, our doctors did not advise steroids. So I think that continues to be the situation. And of course, we had to take difficult calls depending on the availability of the other medications which were used and the oxygen. Sometimes when we were thinking that we might have a shortage of oxygen, we tended to be a little more aggressive. But otherwise, we restricted dexamethasone only to the severe and moderate, or more moderate and of course the severe patients.
So we'd like to avoid it as much as possible.
Absolutely.
Only use in life-threatening situations.
Absolutely. So we restricted it to all the severe, and we also found that while we give insulin infusion to all these patients, some of the people, especially on dexamethasone, they required huge doses of insulin for insulin infusion. And also, we used during that time, though continuous glucose monitoring is not really recommended for in-hospital use, we put quite a few patients on continuous glucose monitoring in the wards for two reasons. One is because of the fluctuation of glucose and we had to measure so many times. And also it reduces the contact with the nursing staff who have to keep on doing glucometer tests every hour, whereas a CGM is much more easy to do and time, it can be quickly looked at. So some of these were some of the modifications we made in practice.
Sir, one basic question. People who are on ACE inhibitors and any data about the COVID incidence, going by the pathophysiology of ACE2 expression and the viral entry.
So I know that there is a theory that ACE inhibitors may not be good, and but I think some of the other aspects actually even out that benefit. So I believe that ACE, ARB and COVID are largely neutral in my opinion. In fact, I saw a patient who was, during the early days of pandemic, one of my patients on ACE, ARB, she read about this COVID causing, ACE, ARB causing COVID, and she stopped it and she put herself on some other antihypertensive drug on her own, and her BP shot up and she got epistaxis and she was admitted to hospital for BP control. And then I told her that there's no evidence for changing any antihypertensive drugs. So I remember that. Yes, Dr. Sujoy.
I think one of the other things that's happened during COVID is we know that about 50% of people with diabetes did not even know that they had diabetes.
Yes.
So once they had COVID, they were much more likely to have a blood glucose test. So a lot of people who had long-standing diabetes got mopped up. Yes. And all of a sudden we started thinking that we had more of diabetes diagnosis. The other thing that I have at least told the ones you're talking about, steroid-induced or stress-induced diabetes is, and where they've recovered, I've told them you're as lucky as women having a glucose test during pregnancy. So you've got gestation, just like gestational diabetes.
Yes.
These are individuals who will go on to develop diabetes in future. So once the diabetes is gone, think of yourself like a woman with GDM, where the blood glucose is normalized. Aggressively institute lifestyle measures, aggressively screen, because you're going to become diabetic finally.
Completely agree. And maybe Dr. Binayak Sinha, you published in the beginning of the pandemic, some people tried to say that, people with COVID, they started actually following diet and exercise and their blood sugars became better. But in my experience and in your paper also, the sugars shot up, and we know that even after COVID, everybody's sugar is high. So I remember your paper published, and your insights, please.
So when we actually published the paper, we got shot down. There was a lot of people who actually said that it's actually improved a lot. But we were the first to actually predict that things get worse with COVID and the lockdown.
And it turned out to be true.
And it turned out to be true.
I think it's very heterogeneous. You have publications to show that people with type 1 actually did better because they got aware that you got to keep your blood glucose correct. A lot of women actually did better because the helping hand at the house was no longer coming. They lost weight, they had hypos, they had reduced requirement of medication. And on the other hand, the other group that Dr. Sinha and yourself are talking about is people who sat at home and just kept eating. So you just can't club everyone together. I think we had various different kinds of subgroup of individuals, some who actually did remarkably well, and others actually did really, really bad.
Yes.
We can have questions for other earlier topics for discussion also, if there are any. I had a question for Dr. Srinivas Murthy. Any prospects you see?
Dr. Srinivas, you can come here.
No, it's okay. It's hardly any distance. Any prospects you see about reducing the cost of these devices? Because as you are aware that costs are is a definite sensitive factor, and 6 lakh rupees for the entire lifetime period of diabetes is more than sufficient.
Sir, but if you convince the patients, especially the parents, I think they can do it. There are a lot of insurance companies which comes now, and that is how I provoke the parents, basically, especially the school children. It's very cumbersome, the basal bolus, the breaks.
It definitely is advantageous. And
most of the patients can afford. Mind you, that insurance scheme, when you apply, and the loans what you get for the product is something which is definitely helpful for most of our patients, I would say. I think it's, as physicians, we don't encourage the parents and the patients, type 1s especially, to go for it.
Can I just make a
I just want to add that, type 1 diabetes, wherever possible, has to be managed by CGM and pump. That's the best. Option number 2 is maybe CGM and multiple injections, and option number 3 is pump. Now, there is a new pump which is available in India called YPSOMED, Yepsomed. I don't know how to pronounce it. It seems to be a Swiss company. And unlike Medtronics, which is very expensive, this is coming to about, Medtronics is not the new Medtronics, which is like the artificial pancreas. I have 2 patients on it. That works out to nearly 6.8 or 7 lakh rupees. But the economical pump, which is newly come to India, Yepsomed, is coming to around 3.25 lakhs, which is not that expensive.
Not very high.
Still, it's like buying a small Maruti car or something like that. So people have to really think about it. But
I think
but
one
yes.
more, if you see the number of admissions the patient may avoid by using this thing,
Education is like.
definitely makes a
Sujay, you had a comment.
There are several aspects to it. Number one, when mobile phones first came in, they were expensive. So the more we use and the better the technology is, price is going to come down. So that's the bottom line. I think the technology is still far off from where we ideally want it to be. That's number one. Number two, I work in a government hospital as well as in a corporate hospital. So I do both spectrums of the world, and people can't even afford insulin. The only good news that I thought I would share is, day before yesterday, we had a meeting with the central government. A new health policy and a program is coming in, which is the juvenile NCD program. Day before yesterday, Government of India has decided that insulin, glucometers and strip will be provided to every child with type 1 diabetes for free. I was part of that meeting. I'm probably the only endocrinologist on that. And probably your previous state, that's Kerala, is already having a program called Mithai, in which they are providing the insulin pump for free. Now, Medtronics is after me to try and push this into the national program, but I don't think we can get it in immediately. But that's one thing that we should actually push for. The other issue is there's so much more associated with giving a pump. It's like giving me an iPhone, which I don't know how to use at all.
iPhone?
No, because I use it as a phone for email and for WhatsApp or for that. But there are so many other features on that phone that I don't know how to use. So similarly, for management of type 1 diabetes, you need a lot of education. That's beyond just the pump. That, I think, is something that we should, as diabetologists, educate more people, more educators, more people trained up to manage those aspects. The pump alone will not solve the problem.
So many people who come with pump to me for the first time, their HbA1c is 9%. And I said, why have you put this pump if your sugar is 9%? The only reason why they are wearing the pump is because they want to avoid the insulin injection. That's not the reason for taking a pump. The idea of a pump is to control the blood sugar levels. In fact, in some countries, including the NHS, the patient has to give an undertaking that that patient is going to monitor the blood sugar levels before actually. So even if we are going to give pumps to patients, they should undertake to do glucose monitoring or CGM regularly, because otherwise just wearing a pump like a machine to avoid insulin injection is not going to protect them from any complication.
Yeah, because I was I was lead clinician for pump services in west of Scotland. So they actually had to show that there is improvement in these parameters so that they can stay on the pump.
Yes.
Not just for that, even drugs like Orlistat. The patient has to lose 2 kilograms in 1 month's time while being on Orlistat for the drug still to be eligible to the individual. So we are not going that way, but ideally that's the way forward.
It's because the government is providing. Here, it's out of pocket, so they're.
I think it's out of pocket. So whenever somebody puts a patient on the pump, I think this part is very important. Yeah, it's very important.
Where I come from, Kolkata, I find most of the people have gone down south somewhere, got a pump and come back.
Yeah.
People, that's what is working without the other inputs of how to use a pump. That's the point that I'm trying to make.
Absolutely. And even if they take the pump with the sensor, the pump with the inbuilt sensor, wearing that sensor is very expensive. So there's no point in buying that pump and not being able to wear that sensor. You might as well wear a pump and wear an economical sensor separately. Yes, doctor.
So we too used CGM in COVID patient in first wave. We have almost 50-60 patients data. And what you said is true. avoiding steroid is always good for COVID patient. And major complications are because of increased sugar levels in the ICU.
Thank you for that.
Thank you, Dr. Undi and Dr. Srinivas, Dr. Vinayak. Yes, for this very nice session.
I ask Dr. Unni sir and Srinivas sir to felicitate our chairpersons.
Each other, felicitate each other.
It's a return gift, sir. Yeah. Yes. We'll start with next session. Dr. Sanjay Agrawal, Dr. Nk Singh and Dr. Manoj Chawla will chair the session.
I'll start off the session and I'll leave after the first session.
सर आप बैठो तो लोग आपको देखे तो यूएस से जितने जन सवेरे जाग रहे हैं
अभी अभी जगह होंगे अभी अभी उठे
reminds us of our younger days, you know, we had the JRs and SRs, senior resident, senior resident का मतलब सोते रहो, junior resident का मतलब जागते रहो.
Early should we start?
Can we have Dr. Mudaliar there? हाँ, there. Good morning, Dr. Mudaliar. Good morning, Manoj here.
Dr. Mudaliar, we can't hear you. Vinayak here.
Dr. Mudaliar, I think they'll let them, yeah.
Can you hear me now?
Yes, we can. So, welcoming Dr. Sundar Mudaliar, who I'm sure needs no introduction. He's going to be talking today about the glucose being the journey of a life-sustaining molecule from gut to the tissues. Dr. Mudaliar, all yours.
Okay, thank you. Let me first share my screen. Can you see my screen now? Yep. All right. Good evening, everybody, and I'd like to thank the host for having invited me. And also, just in case you didn't know, it's 4:30 in the morning for me, and I had to get up at 3:30 to get ready for this meeting. So thanks to my friend Dr. Sanjay Agarwal for giving me the luxury of that. This is a talk which I literally put together, and I hope it will be of interest to the audience. get our source of glucose, whether it be plants, starch, ice, wherever. Glucose transporters are needed to take it in. And we have two kinds of glucose transporters, the high affinity transporters, and their Km is between 1 and 5 millimolar. So even if the blood sugar is 18, these transporters are working up to about 90 milligrams per deciliter. And of course, they are responsible for basal glucose uptake. GLUT1 has got a Km of around 2 millimolar. That's about 36 milligrams per deciliter. Very high levels in the red cells, the kidney. In the deep parts of the kidney, there is not much oxygen. The partial pressure is only 10. It needs to do this glucose at whatever level it can get it in. The colon, the blood-brain barrier cells, the glial cells. It has low levels in the liver, adipose, and skeletal muscle because these are insulin-stimulated tissue, so they don't have it. The other cells need it. The red blood cell can only use oxygen. It doesn't have a nucleus, doesn't have a mitochondria, cannot use fat at all. So you need glucose to get into it, even at low levels. GLUT3, of course, is got the lowest. It's 1 to 2 millimolar. Again, basal glucose uptake. It is the major neuronal GLUT isoform, very low Km, and it's the ideal GLUT because nerve cells have to survive no matter what. And they cannot store glycogen, but they have a very high glucose demand. It's also in macrophages, placenta, platelets, placenta, testes. And of course, GLUT4 is what's called the insulin-stimulated glucose transporter. So when insulin around, it keeps, recirculating this GLUT4, brings it back from the cytoplasm to the cell membrane so that it can and keep taking glucose in. Of course, it's present in insulin-stimulated tissue like skeletal muscle, heart, and adipose tissue. What about the low affinity transporters? Their Km is very high. 270 to 370 milligrams per deciliter. Why do we need them? Well, we need them in tissues which see large glucose fluxes. You have a big ice cream, a piece of cake, a pizza. There's a large glucose flux coming into the liver. Of course, it comes to the brush border of the intestine first, the liver, the pancreatic cells, the renal tubular cells. You're filtering out all your glucose. If you have hyperglycemia, there's a large glucose load there. And of course, the CNS, and this is very strange. It has a very high transport capacity. It has to take so much glucose across in these cells. GLUT2 in the liver helps in glucose uptake by the hepatocytes, and it is used, of course, in the liver for glycolysis and glycogenesis. In the pancreas, it serves as the glucose sensor along with glucokinase. It assesses the glucose level and controls beta cell secretion. And in the CNS, this is important. We don't even realize it. GLUT2 dependent glucose sensing controls feeding as well as sympathetic and parasympathetic activities over there. We still do not know why the CNS cells have got a high Km glucose transporter, 270 to 360, when the parenchymal glucose is only about a third of the blood. If your blood sugar is 100, your brain glucose is only 35 to 40. Why is it needing this high transporter? We don't know. Also, GLUT2 is associated with both glucose inhibited and glucose excited neurons. It takes glucose into both kinds of cells, one where it suppresses signals, one where it stimulates signals. And we think it has got signaling properties that are independent of its transport capacity. And just as a, jeopardy point, inactivating mutations in GLUT2 causes the famous Fanconi-Bickel syndrome, where you get hepatomegaly, growth retardation, and of course, various renal syndromes. Let's not forget our famous SGLT2 1 and 2 co-transporters. Of course, we all know SGLT1 is present in the gut. It uptakes both glucose and galactose transporter there. Very minor role in kidney. It is present, as we know, in the S3 distal segment. And of course, if you have a mutation in this, you get the glucose-galactose malabsorption syndrome. It can cause neonatal diarrhea and death if you don't find out and take all the glucoses out of the diet. SGLT2 transporters, we all know that S1, S2 segment in the kidney. Of course, these are sodium-linked glucose transporters. So it takes both salt and sugar inside. The glutes only take glucose into it. And of course, it is potentially transport glucose across the brush border of the tubule and the major glucose transporter in the kidney. So what is the role of insulin in tissue glucose uptake? So glucose is going to go into the cells by the GLUT transporters. Why do we need glucose? Because it depends on the prevailing level of insulin. So when levels are high after we eat a meal, in non-diabetic, it goes to about 100 microunits per ml. Fasting is about 10 microunits per ml of insulin. Now, glucose uptake has to be promoted because a whole bunch of glucose has come in, insulin's come in. It goes into the insulin-sensitive tissues, liver, skeletal muscle, adipose tissue, and it is called insulin-mediated glucose uptake, or IMGO, facilitated by GLUT4. I told you that's the insulin-stimulated transporter. When levels are low, fasting state, now you get glucose uptake into both insulin-sensitive and non-insulin sensitive tissues, CNS, nerves, red cells, endothelial cells. This is called NIMGU, non-insulin mediated glucose uptake, and it is GLUT1 and GLUT3. As we know, GLUT2 is a very special transporter. I've talked about it before. So this was the first study done in San Diego, 1988. So my colleague Steve Edelman is still around, and they called it rates in tissue sites of non-insulin and insulin-mediated glucose uptake. So this is insulin glucose uptake at euglycemia, blood sugar is about 90, hyperglycemia, blood sugar is around 250. So see what happens at basal levels when glucose is 90, insulin is about 10, most of the uptake is going about 70% into the CNS. Of course, non-CNS, about 20% to the red cells, the white cells and platelets and all, and only 13% is going into the muscle, because muscle in the basal state uses fat. It doesn't use much glucose then. But if you raise the blood glucose to 200 in the fasting state, these people have diabetes. Now where is the glucose going? Still going into the CNS, about 42%. Non-CNS is about the same, 20. But now in the fasting state, even when there is hyperglycemia, people with diabetes, they are pushing glucose into the muscle and using glucose. They should be using fat. They're not using it. They're using 38% glucose. And that's really not good, because in the fasting state, you should use your fat. But they can't do it because there is NIMGU because of hyperglycemia. So the other point is, I don't have it on this slide. If you give insulin and you get insulin-mediated glucose uptake, it is about 5 times non-insulin-mediated glucose uptake. What about glucose-mediated glucose uptake independent of insulin? Well, this is a nice article, Rita Basu, Anand Basu. They talked about the forgotten role of glucose effectiveness in the regulation of glucose transport. And it is, of course, the glucose effectiveness is glucose promotes its own uptake by mass transport and pushes it inside over there. It doesn't matter what the glucose concentration is. And people with diabetes, glucose effectiveness is what is important. You don't have much insulin-mediated glucose uptake. So the body tries to push glucose over there. It doesn't like high glucose. Of course, if your renal threshold exceeds about 180, 200, the body says, get rid of glucose. But it raises the blood glucose to about 180, 200 to push it into the cells because insulin's not acting well. And this is a very important role. And again, these studies were done in San Diego many years ago, that if you look at whole body glucose uptake, and your serum glucose is 5 millimolar, is over there. What you see is very low levels of uptake, about 10 micromole per kg per minute. If your glucose goes to about 20 millimolar, 360, it is about doubled. Of course, insulin-mediated glucose uptake is 5-fold that. So at any insulin level, if the glucose is high, you get much more glucose uptake. That's, of course, GLUT4. This is GLUT1 and GLUT3. Let's not forget, insulin acts through GLUT4, but hypoxia also through the AMP kinase pathway acts to increase GLUT4, and exercise, of course, through various pathways. We don't know these pathways, but we know AMP kinase is there, and it also increases GLUT4, pushes glucose into the muscle. So let me look at the glucose, the journey. So once the brain tells you to eat, you eat, and depending on gastric emptying and small intestinal transit, you get into the jejunum and the ileum, glucose is digested, through all the amylases and the monodisaccharides, and then coming down into the gut, you have the GLUT transporters, which are pushing glucose in at the enterocyte. But remember, in the gut, we have the endocrine cells, the K cells, the L cells, and their transporter is SGLT1. It is not GLUT2. And this, we also found out about 15 years ago that SGLT2 is the transporter in the gut to release GLP-1 and GIP. And of course, glucose goes to the liver. What does it do there? It needs to shut down glucose production over there because fresh glucose is coming in. Of course, glucose goes to the liver, to the beta cell, stimulates insulin secretion, goes to the alpha cell through, of course, GLP-1, GIP, and suppresses glucagon, promotes glucose uptake into muscle. 80% of insulin-stimulated glucose uptake is into muscle. And the sum total of liver, muscle, and insulin gives you your peripheral glucose concentration. Okay, we got the glucose, we took it from the gut. How do we take it from the bloodstream into the cell? I told you about the glucose transporters. They took it in. Now what happens inside the cell? Well, glucose goes into the cell through the glucose transporters. I told you about them. And the hexokinases, you get glucose 6-phosphate, and there are 4 important pathways. We all know about the glycolytic pathway. Glucose goes down to be burnt, as it were, in the Krebs cycle or, non-oxidatively. It can be good, the cell gets stored as glycogen over there. Important pathway, hexosamine biosynthesis pathway. And let's not forget the pentose phosphate shunt, and I'll come to this. So glycolysis, as you know, is going from glucose to the Krebs cycle in the mitochondria, but the opposite pathway also exists to reverse the pathway and bring it back from pyruvate to glucose. So these various things, I won't go into it, fructose 1,6-bisphosphate, glyceraldehyde, phosphoenol pyruvate, and of course, pyruvate gets into the mitochondria and goes around, and what you get is 34 ATP. And of course, in states of low oxygen, what we do get is lactate. Pyruvate is converted to lactate, and you get only 2 ATP. But if you have low oxygen, if you're on the red blood cell, you don't have the luxury of a mitochondria, and you get it over there. So what about the glycogen synthesis pathway? Again, 2 ways. You can either store glycogen or you can break it down. It's only stored in the liver and in the muscle. 100 grams, 200 grams in the liver, about 400 grams in the liver. That's all. Because glucose is not your energy store. You have excess fat as the energy store. And excess glucose can be converted to fat. But the problem is in mammals, you cannot bring it back to glucose. You have to use it as fat. Of course, various pathways for glucose to glycogen and back. What about this hexosamine biosynthesis pathway? Very, very important. And Dr. Chawla, I listened to you. So there are 3 components: glucose, glutamine, and glucosamine. And what we get is UDP and glycosylated, this molecule UDP and glycosylated glucosamine. And what does it do? This tells us it integrates carbohydrate metabolism. That's the glucose. Nucleotide metabolism, DNA, RNA, that is uridine triphosphate. Amino acid metabolism, that's glutamine. And fatty acid metabolism, acetyl-CoA comes from this. And you get UDP, glycosylate, and glycosylated UDP and glucosamine. And what is it important for? All proteins in the body undergo glycosylation, let alone your hemoglobin. If your TSH is not glycosylated, it doesn't work. If your pituitary hormone, you need to glycosylate them to activate them. It causes post-translational modifications of proteins and contributes to the synthesis of complex molecules, glycolipids, proteoglycans, other. HbA1c is just a minor pathway, and of course, we use it for diagnostic and prognostic reasons. What about the hexose monophosphate shunt? Glucose, remember glucose 6-phosphate dehydrogenase, and through ribulose, it gets converted to nucleotide synthesis. And on the way, it generates NADPH. See, the Krebs cycle gives you NADH. You need NADPH, very important to make fatty acids, to make steroids, to detoxify intracellular ROS. You can't exist without this. And of course, You have to make DNA, RNA, and all that. So it generates the hexose becomes a pentose, 5 sugar, and of course we make all our DNA, RNA over there. So glucose homeostasis is fundamental to survival in most vertebrate species. And of course, we have to protect and defend the glucose level over there. So we have evolved a large number of counter-regulatory mechanisms designed to restore glucose homeostasis when glucose falls down, because the brain needs glucose, the red cell needs glucose, the inner medulla of the kidney needs glucose over there, and we have to protect it. So how does the body protect us? It's fascinating. So this was Bob Sherman gave his Banting lecture in 2008, and his title was Bringing Light to the Dark Side of Insulin, a journey across the blood-brain barrier. So a few months after Banting introduced the world to insulin in 1922, Elliot Jocelyn, the father of diabetology, said, insulin is not a cure for diabetes, but a potent preparation alike for evil and for good. And today, 85 years later, with all our advances in insulin therapy, there is still a dark side to this potent preparation, and that is hypoglycemia. What happens during hypoglycemia? And this is fascinating to me over there. So if you get hypoglycemia, there are various sensors, organs, counter-regulatory hormones, but it is sensed in the brain, in the hypothalamus, the ventromedial nucleus over there, the brainstem. And what does it do? It turns on the autonomic nervous system, norepinephrine and acetylcholine. Remember, acetylcholine is a parasympathetic. This is why sometimes when our patients they become unaware, hypoglycemia unawareness, but they tell you they sweat because that is the cholinergic phenomenon. They say, I got up in the night, I had lots of sweating, because that cannot be blocked by beta blockers. Anyway, in the pancreas, alpha beta cell, there's increased glucagon, decreased insulin through the autonomic nervous system, goes to the liver, stimulates gluconeogenesis, glycogenolysis to increase the blood glucose. Adrenal gland is very important. Why? Because it makes cortisol and epinephrine, because without these, you're not going to survive. What does it do? It goes through the beta-1 receptors, increases cardiac output. It goes to the muscle, beta-2 receptors, vasodilation. It goes to the skin, constricts the skin and the gut through the alpha-1, because you don't need stuff happening in the skin and the gut. It goes it. And the brain flow is diverted to the 3 main organs when you have hypoglycemia. The brain, you need to think what to do. The muscle, you need to run or whatever you're doing it, and the liver. Now, this is fascinating, because the question I ask myself is, why is the sympathetic nervous system activated in hypoglycemia? And these 3 things, the brain, the muscle, and the liver, they are the ones who are the main players. Because remember, until 1922, the human body had never experienced acute hypoglycemia. Yes, it had seen insulinoma, but it doesn't go down like that. It doesn't go from 250 to 30. You give extra insulin, your sugar is going to go down. Insulinoma does not do that. It does it very slowly. So how did the body respond? It had no mechanism to do that. But guess what the body has? The very primitive mechanism, the fright, fight, or flight mechanism. So that's why the brain is important. You get frightened. Oh my God, this early hunter-gatherer, big animal which came and is going to eat him. So he has to decide, am I going to kill it, fight it? If I am going to do it, I need glucose and I need to throw the spear or whatever, or I need to run for my life and I need my muscle to give me the glucose. So this is the primitive reaction which is turned on in patients with hypoglycemia, and it occurs whenever there's a harmful event. It doesn't matter what it is, and it responds to threat. And this is also what happens in COVID. When there is an acute cytokine storm, all these bad hormones are released. But there is a problem in hypoglycemia because, and this is a great paper by Phil Cryer and Simon Heller, there is reduced neuroendocrine and symptomatic responses to subsequent hypoglycemia after even 1 episode of hypoglycemia in non-diabetic humans. For want of time, I can't show you the data. So you take non-diabetics, you take their blood sugar down to about 36 to 40 first time. You do it the next day again, you get a blunting of it. This is a problem. Why? Because this phenomenon is called hypoglycemia associated autonomic failure. We call it hypoglycemia phenomenon. But why is it happening? Because of various mechanisms. Recurrent hypoglycemia, that's in type 1, type 2. But in a non-diabetic, even one episode can do it. You get a lot of adaptations. It's all happening in the brain. There's increased glucose transport. The brain upregulates its transport. It can switch to ketone. Takes about 12, 14 hours. It cannot do that immediately. There are various transmitters from the glial cells. There's altered glucose sensing in the brain. It doesn't sense 60 anymore. It's going to sense a 40. And all these hormones are released by the peripheral nerves over there. Neurotransmitters are released from the peripheral nerves, the central nerves, and they send out peripheral signals. Bottom line, there is reduced responsiveness to hypoglycemia and impaired hypoglycemia awareness. As I told you, it's called hypoglycemia associated autonomic failure. You get of course, that leads to, you go down to 50, you eat more sugar, you go to 250. And I'm sure in this conference, you'll hear all about the glycemic variations. But in the long term, it probably leads to accelerated cognitive decline. But the point I'm making is, why does the body adapt to hypoglycemia by suppressing its own defense against it? First of all, it turned on a very primitive reaction to hypoglycemia because it never knew insulin before 120 years ago and 100 years ago. And now, if you keep getting hypoglycemic, it turns off that response, which is not very good. That's why we need all, I see Professor Nock over there, we need all these GLPs, GIPs, and all that to help us to do it, of course, by modulating insulin release. I'm almost on my last slide. Thank you very much. This very famous person said, ask the right questions and nature will open the door to her secrets. Who is this? Of course, 1930, Sir C.V. Raman was the first non-white. Before that, it was only given from the 1800s to Europeans. You couldn't get it, but he was the first. Of course, the first to get it was Rabindranath Tagore, but he got it for literature, and Indian to receive the Nobel Prize for his pioneering work on what is known as the Raman effect. And I might share with you that when he went to Stockholm to get his Nobel Prize, he doesn't drink. He was a very strict vegetarian. He didn't drink. So they said, no, you have to drink the champagne toast. So you know what he told the organizers? He says, the world has seen the Raman effect in alcohol. So when light passes from one medium to another, it bends and there's a diffraction. And it bends over there. That's the Raman effect. So he says, the world has seen the Raman effect in alcohol. I do not want the world to see the effect of alcohol on Raman. Thank you very much for your attention. Namaste. And I'm done. Thank you. And I look forward to Professor Nock's talk. Yes, because the brain sensing mechanism has been, its fuel metabolism is now served by ketones. For that, you have to tell the organizers to invite me again next year. Thanks. Bye. Thank you.
So thank you very much for the kind introduction. I hope you can confirm. Let me see. I want to show my slides, but it doesn't turn to the maybe it's working now. No, now is something completely wrong. I have to go back. Just a moment. Yeah, and now I have to go to presentation mode, but it doesn't switch. Why not? Yeah, I'm trying, but I think there is a problem. I'll start again. Here is the incretin revolution, and I'll share it. It's on the first slide, just to make sure, but it doesn't go into presentation mode. That is unfortunate. I think I have to. So let me go back and oh, there is something else. So I will close the other presentations. Now take this one and go to presentation mode. Why doesn't it go to presentation mode? Here we go. This looks much better now. So let me go back, but there is some problem still. And this is not the first slide. So something is going completely wrong right now. Because I can see my presentation and it's in the right order and all fine. But it switches to a slide that obviously is damaged and
On the first slide and probably take it from there.
yeah, but I never get to the first slide. That's the problem.
No, don't get into the complete slide screening. What you are able to see as the first slide, just click there, double click there, rather than the counter down.
Sorry for this problem.
No problems, Dr. No.
So this is the slide deck I want to show.
Yeah.
And well, no, it's not okay. It's not okay. It shows damaged slides. I can try it. Let's see how far we get. So, well, thank you. The incretin revolution for the treatment of type 2 diabetes. Here are some transparency declarations, and this is my agenda. And I want to introduce GLP-1 as a parent compound. So here, obviously, a picture is lacking, and I'm afraid. I think I have to restart the PowerPoint. Sorry for this, but it's not doing what I expected to do. Here we go. Ah, now I know what the problem is. See, I think we are getting closer now. And so how does this look? Again, the title, I can skip the transparency declaration and I will move into the original finding by Jens Holst that if you take the right sequence, oh, sorry. That is, okay, once more. And now the presentation mode. Here we go. Can you see it now? Please confirm. Great. So this is what Jens Holst found, that you need a truncated form of GLP-1, and really this is what is synthesized in the body. And then at very, very low concentrations, you can stimulate insulin in the perfused pancreas. And we took exactly this form of GLP-1 and infused it to type 2 diabetic patients. And here you can see an original recording from 1992, fasting hyperglycemia, extremely high, 260 or above, and 4 hours after starting the infusion, it was below 100, and we now know it would not go any lower even if you continued the infusion of GLP-1. And this got the whole idea started that GLP-1 is a good parent compound for glucose-lowering drugs, and GLP-1 receptors were developed. The first one was a product of serendipity because the saliva of a lizard living in Arizona contains exenatide, which is somewhat similar to GLP-1. It binds to the receptor even better compared to the parent compound, but then people went into the laboratory and designed incretin mimetics. And we have basically two forms of longer acting compounds, the ones that have a free fatty acid residue that would bind to albumin in the body, and then the large proteins like albumin or an immunoglobulin fragment with some GLP-1 modified attached. And they then have had much longer half-lives. And this is the first progress I can report in the field. So as you can see, exenatide, we are talking about 2 hours to get to the peak, and elimination half-life 3 to 4 hours. The next step was towards liraglutide, which could be used once daily and is still a long-acting compound. So during these 24 hours, you never have like zero drug concentrations. And then we have seen a number of even longer acting compounds with half-lives just short of a week, but you can nevertheless use them once weekly. And we have seen one approved oral preparation, again, containing semaglutide plus something else that I will talk about. But what I believe is more important is that over the years after 2007, when the first GLP-1 receptor agonist was introduced, we saw preparations with increasing effectiveness for both glycemic control and body weight loss. Let me talk a little bit about semaglutide for oral use. Basically, you need SNAC, that is another molecule which is an absorption enhancer that creates a pH and a milieu in the stomach so that the peptide that normally would get digested in the stomach and in the intestines like semaglutide will survive and will be absorbed. So it's essential that you co-formulate semaglutide with this SNAC, and we have 3, 7, or 14 milligrams of semaglutide and 300 milligrams of SNAC per tablet, which means a lot more absorption enhancer. And this is still a vulnerable process. You have to take it in the morning, first thing, in the fasting state, and wait at least 30 minutes before you eat or drink or take any other medication. If you don't do this, the bioavailability is not 1%, which it would be if you comply with these rules, but it would be much less and basically wouldn't work. So, but what is really good about the oral semaglutide here shown in blue, that regarding the reduction in HbA1c, it is at least as good as liraglutide. And
if you look at body weight reduction, when you compare it to liraglutide, it is even better, which means it has a higher effectiveness in reducing body weight. And this is a comparison of all available GLP-1 receptor agonists. And I have tried to estimate the average HbA1c reduction that you get. And this is all from head-to-head comparisons between different GLP-1 receptor agonists. And you can see the short-acting compounds are not as good as the long-acting compounds in reducing HbA1c. And within the long-acting compounds, there is one which is no longer available, albiglutide, which is not competitive, but there is one that sticks out, and that is semaglutide for subcutaneous injection. And even the oral semaglutide that is related to the dose that Novo Nordisk has chosen, it is quite competitive with the other long-acting injected GLP-1 receptor agonists. And when it comes to reduction in body weight, there is no general difference between the short-acting and the long-acting compounds. Albiglutide, again, is not competitive in this way, but semaglutide is really much better than any other GLP-1 receptor agonist in reducing body weight. And even the oral preparation, although it is not as effective as the subcutaneous preparation, perhaps again related to the doses, it is at least as good as all the other injected compounds. And what has driven the success of GLP-1 receptor agonists is cardiovascular outcomes trials. They were not done because people wanted to show that there is some benefit. The companies just had to do them in order to get their drugs approved. And what was found out, and here this is a result of a meta-analysis of all compounds, with the exception of Elixir, which didn't have any benefit in this respect. And you can see that you have an approximately 15% reduction in MACE endpoints and in the components of MACE, in all-cause mortality, even a slight reduction in hospitalization for heart failure, and an improvement in kidney-related outcomes. And this is the comparison to SGLT2 inhibitors, which have similar benefits. The clear difference is with respect to stroke. Benefit for GLP-1 receptor agonists, almost no effect, certainly not significant with SGLT2 inhibitors. And the other clear difference is in favor of SGLT2 inhibitors when it comes to the prevention of hospitalization for heart failure and improvement for kidney-related outcomes, especially if you include later stage outcomes like the necessity for renal replacement therapy. I believe that we pretty much understand the process of atherosclerosis. And here you have many steps like endothelial NO production, the invasion of monocytes into the intima, turning into macrophages, foam cells, undergoing apoptosis, and leaving lipid droplets in the intima, or effects on cytokines that are produced by macrophages, or effects on smooth muscle cells in the vessel wall, or on proteases that digest the collagen cap that covers a plaque before it is able to rupture. And these are all steps in the advancement of atherosclerosis. But now I will show you the same figure, and here you see all those dangerous steps in red, and in the next you see them all in green. And if you have watched carefully, all the arrows have switched their direction. And this is what the literature says what GLP-1 receptor stimulation does in a blood vessel. And all these steps are basically reversed, which should lead to reduction in plaque progression and also in stabilization of existing plaques, so prevention of rupturing, which then causes these events. So I think that is good to know. Regarding adverse events. For a while, there was fear that perhaps GLP-1 receptor agonists cause acute pancreatitis. And with the help of these cardiovascular studies, now we have really found out that this is not the case. This is a meta-analysis based on these cardiovascular studies. And there were enough events so that we can now conclude there is no elevated risk for pancreatitis. Maybe it is there for DPP-4 inhibitors, but it's very low-grade risk. So because of these cardiovascular effects, and you all know the current recommendations from guidelines, it is almost mandatory that someone who is similar to these study patients in having evidence of existing cardiovascular disease, in particular ischemic conditions, coronary disease, peripheral artery disease, cerebrovascular problems. They need a GLP-1 receptor agonist, and some perhaps are better off with an SGLT2 inhibitor, or maybe even with a combination of both. So, and this is something that we all wish to see, but it's not true so far. So the GLP-1 receptor agonists for type 2 diabetes, especially in those in whom the prevention of cardiovascular events is key, is not where it should be. So we should talk to our colleagues and hope that they will prescribe these medications to the patients who need them. But as you have seen, there is a significant effect on body weight. And so the idea now is that maybe we should not wait before obese people develop type 2 diabetes, but we might be able to use them as anti-obesity agents before that. And the reason is that we have a mechanism. So this is a study from 1998 from Copenhagen, and people received a breakfast and then they were a little bit more satiated, which gets lost over time. And if you infuse GLP-1, they always feel a little bit more satiated. They also feel a little bit more full, and they have less hunger during the whole period. And they, if you ask them how much would you like to eat, they say, well, my prospective food consumption is lower when I'm under the influence of GLP-1. And then they received an ad libitum meal, which really led to satiation and hunger close to zero. And when you now measure the energy that they consumed, it was more with saline than with GLP-1. So they really had a 12% reduction in energy intake under the influence of GLP-1. And you all know that if you eat 12% energy less, this will reduce your body weight. And again, now we are in a position that we understand what is happening there, and we know that the key area in the brain is the hypothalamus, which has several nuclei, and one of the key nuclei is the arcuate nucleus, where there are two types of neurons, and one of them has GLP-1 receptors. We also know liraglutide and semaglutide really reach this nucleus in the hypothalamus. And then the POMC card neurons are stimulated. They inhibit the neurons that produce NPY and agouti-related peptide. They have projections to other areas of the brain, mainly in the brain stem. So, for example, the lateral parabrachial nucleus, which probably mediates meal termination. So in the hypothalamus, it is decided that you want to eat and you start your meal. And in the parabrachial nucleus, it is decided that you stop eating because you're satiated. And if you take people with obesity but no diabetes, it works. Here, a high dose of liraglutide was used, and this was a study over 3 years. and you can maintain like a 9 or 8% reduction in body weight over this period and in time. And you can achieve weight loss greater than 5% in approximately 50%, and even weight loss greater 10% in 25%. What is helpful in this respect is if you now look for the subjects who will develop type 2 diabetes. If you treat them with placebo, many of them will develop type 2 diabetes over 3 years, but it's much less when you treat with liraglutide. And the reverse is also true. With liraglutide, people with pre-diabetes, IGT, for example, they come back to true normal glycemia. At least 2/3 of them do, whereas the number is much lower when you don't treat with a GLP-1 receptor agonist. So this indicates you can put off weight and you can at least decelerate the development towards type 2 diabetes. What is important in my view is that you have to continue this treatment for as long as you wish the body weight to be down. This is waist circumference, this is body weight. If you stop after 20 weeks, body weight will start to rise again. And this is important, and patients should know this. Another complication of obesity is non-alcoholic steatohepatitis. And there is now a study with semaglutide. This study was performed with daily injections of low doses of semaglutide. And what is important, the patients had steatohepatitis and some had fibrosis stage F2, F3, as you can see here. So these are the patients that would be on their way towards liver cirrhosis. And when you now measure transaminases, they improve. The greater the dose of semaglutide, the larger the improvement is. And this is true for alanine and aspartate aminotransferase. This now is the primary result. And what they counted is, over the period of treatment, how many patients had a resolution of NASH, so no longer steatohepatitis, with no worsening of liver fibrosis. And this is what you see with placebo and with semaglutide. It was always, in all 3 doses, significantly better. So you can prevent the progression of fibrosis, which really brings those patients into trouble. What you cannot achieve is an improvement in liver fibrosis stage with no worsening of NASH. So this is almost the same for all the 3 groups. But I think it's important to note that you can prevent the progression of fibrosis. So last, I want to talk about tirzepatide, which is a novel agent, perhaps a novel class of agents of dual receptors stimulating the GIP and GLP-1 receptors at the same time. And the idea is a little bit related to the successes of bariatric surgery, which leads to changes in the gut-derived neuroendocrine milieu. We have always talked about GLP-1, and GLP-1 concentrations are sky high after gastric bypass. There is also an elevation in glucagon. Some studies show an elevation in GIP as well. Then there is a dramatic elevation in PYY and GLP-2 levels. GLP-2 is not so much an anti-diabetes or anti-obesity hormone, so it's probably not relevant, but PYY is another appetite inhibiting peptide from the gut. So the combination that Lilly chose was a combination of a molecule with some features of GLP-1, other features of GIP. We should note that even GLP-1 and GIP have many amino acids in common, which are shown in the darker green here. So they are very much related. And tirzepatide now has the blue amino acids, which clearly indicate they are like GIP. The dark green amino acids, which are both from GLP-1 and GIP, the light green amino acids, which are from GLP-1, some orange amino acids towards the carboxy terminus, which are all from exenatide for certain purposes. Then there is this diacid promoting binding to albumin, very similar to semaglutide and liraglutide. So it's a very colorful molecule, and basically we have learned it is able to stimulate GIP receptors, maybe even a little bit better than GLP-1 receptors. And now look at one example of a clinical study where patients with type 2 diabetes starting at an HbA1c of 8.3% are treated either with semaglutide, so an established, very effective GLP-1 receptor agonist. It's a selective GLP-1 receptor agonist. It does not stimulate GIP receptors. And tirzepatide, 3 doses shown in blue. And when you look at what happens to HbA1c from 8.3 to 6.4, which is excellent for semaglutide, but with tirzepatide, it's even better, and the high dose takes those patients to below 6% at study end after 40 weeks. And you can see that also fasting glucose is extremely well controlled. So in the end, we are talking about fasting glucose in the order of magnitude of 110 milligrams per deciliter. And this taken together means that you can take like 80 or more % of the patients to an HbA1c below 7%. The majority will also make it to below 6.5, but some, and some is many, up to 46% in this study, have an HbA1c of 5.7 or below, which means this is the range that we would typically call a normal glucose control. So you can turn a type 2 diabetic patient into someone who has normal glycemic control based on HbA1c. And in addition to this, you have a major weight loss. You have the expected 6 kilogram weight loss with semaglutide, but even the low dose of tirzepatide is better, and the highest dose takes them to minus 12.4 kilograms, which again means that a majority loses more than 5% of initial body weight, more than half with the highest dose lose 10%, and a substantial number, more than a third, loses 15% of baseline body weight or more. And this weight loss is accompanied by beneficial changes in triglycerides, in overall cholesterol. It leads to a rise in HDL and a fall in LDL cholesterol, and VLDL cholesterol is also very much reduced. We have seen a dedicated study in non-diabetic obese subjects that shows even more weight loss. And maybe one thing is worth being pointed out, that even after 40 weeks, you have not reached a new steady state. So with all the studies taken together, it probably takes like a year or so before you reach your steady state of body weight. There are some initial analyses regarding cardiovascular events. So MACE-4 was the topic of this analysis. This was a study that was performed for 2 years or something longer than that. And here you see the 3 doses of tirzepatide in blue, and especially the high dose, which will be tested in a dedicated cardiovascular outcomes trial, shows a very much reduced incidence of MACE-4 events. It's reduced by 50% versus the reference, which is insulin glargine treatment in the control arm of this particular study. And when you take the whole tirzepatide program of what has reported results so far, you can do a meta-analysis of all these clinical trials. And then, for example, you find out that you have a 17% reduction in MACE-3, and the upper bound of the confidence interval is 1.18. So this should always be sufficient to have preliminary proof of cardiovascular safety, but it also suggests a chance for benefit if you only examined the right number of subjects. So with this, I will conclude. The class of GLP-1 receptor agonists exploits the glucose-lowering potential of GLP-1, and progressively longer-acting and more effective GLP-1 receptor agonists have been developed. There is a first oral GLP-1 receptor agonist, oral semaglutide with SNAC, that is competitive compared to other GLP-1 receptor agonists that need to be injected. They can also be used for the treatment of obesity, and that would prevent the progression from prediabetes to type 2 diabetes as well. There seems to be effectiveness regarding non-alcoholic steatohepatitis and in the prevention of fibrosis. The latest novelty is the GIP-GLP-1 dual receptor coagonist tirzepatide, which in clinical trials has better efficacy regarding HbA1c and body weight reduction compared to semaglutide, which is the most effective selective GLP-1 receptor agonists. Other dual and triple coagonists are under development with particular efficacy for weight loss and fatty liver disease. And incretin-based therapy has proven a potential for further optimization, hopefully towards an efficacy similar to that we have seen after bariatric surgery. Thank you for your attention. Well, I have never really liked these either or discussions because in the end, I think you want to use the combination. We should not forget about improving HbA1c. So the real question in my mind is, if you have the tools to address both glycemic control and body weight, like we now have with tirzepatide, does this lead to added benefits for the patients versus only targeting glucose and ignoring the potential for reducing body weight? So we know from other studies that with lifestyle interventions, if you only reduced body weight by 15% or so, this means that diabetes will go into remission in patients who haven't had type 2 diabetes for a long period of time. So I've seen a poster about tirzepatide at the ADA meeting, and I think this will convince many people that in contrast to findings with selective GLP-1 receptor agonists, that those patients treated with tirzepatide that had a particular reduction in body weight, they also had the better HbA1c. So I think this is the first proof that I have seen that if you only reduce body weight by enough kilograms, this will further improve glycemic control. So I think it's very likely if we address both HbA1c and body weight, this will help the patients best.
Absolutely. And finally, the question, the way we see the evolution in the GLPs and the twin cretins. Would DPP-4 inhibitors, would they be extinct if not for the cost?
Well, I think what we have learned is that they do not offer any benefits in respect to cardiovascular disease. What they do is they lower glucose, and they have the advantage that all of them can be used in advanced renal failure. That means it belongs to the few medications that we can use in patients with chronic kidney disease. And they lower blood sugar, and I still believe that this will be associated with advantages for patients. One big advantage is that they are very, very safe and very rarely cause side effects. So, given the prevalence of chronic kidney disease in the elderly population with type 2 diabetes and the necessity to use safe and well-tolerated drugs in the elderly, I think they should be used preferentially for that subpopulation.
Thank you, Dr. Nock, for that excellent presentation and those answers. If there are no more questions from the audience here, we thank you for your presence with the IDEC conference this year, and we move to the final lecture in this session. Let's hear it for Dr. Michael Nock. A big thank you to him for being here with us. With that, it gives me great pleasure in welcoming Dr. Vivian Fonseca from New Orleans, Louisiana, USA. And Dr. Fonseca would be speaking to us on hypoglycemia and cardiovascular disease. Dr. Fonseca, we did touch upon the discussion on hypoglycemia earlier, of course, in Dr. Nock's talk as well as in Dr. Mudaliar's talk. So it'll be extremely interesting, and we look forward to your conversation on hypoglycemia and cardiovascular disease.
Thank you very much. Let me share my screen.
Because while we await the screen sharing, for those of you not aware, this is almost home field for Dr. Fonseca, who did spend some considerable time in the past in Pune. Isn't that right, Dr. Fonseca?
Yes, I went to FMC Pune. So I hope that you can see my slides okay. I don't know, it's jumped from the first slide. Let me try to go back to the first slide. Okay, so, you mentioned that other people have talked about the link of cardiovascular events in relation to some of the other treatments in diabetes. Yes, that is certainly a factor, and I think an important factor in the reduction in the risk of cardiovascular disease with some of the newer drugs. But having said that, we still often have to use insulin in people with type 2 diabetes, and that does increase the risk of hypoglycemia, as you know. Surprisingly, we've known for many years hypoglycemia causes a lot of distress and difficulties for patients, but the risk associated with cardiovascular disease has only recently been appreciated in the last 10 or 15 years. And I'll show you some of that data in a moment. First of all, let me define what we're talking about with hypoglycemia. There are many definitions about it. This is the most recent from the ADA, which gives levels. Level 1 hypoglycemia being less than 70. And the reason for that is that you often get and set to get an alert on CGM, etc., is that this is the threshold for activation of counter-regulatory hormones such as adrenaline and glucagon, etc. So the body is sensing that something is going wrong. And as we will discuss later on, this counter-regulation is involved with some of the pathophysiology of cardiovascular disease. The second issue is the cognitive impairment, and that can occur at different levels in different people, but they've set a level of 54 because it's 3 millimoles per liter. And level 3 is classified as a severe event involving altered mental status and requiring treatment. There are some previous definitions that I think are a little bit more descriptive, and it may be important, particularly defining severe as needing the assistance of another person. There's another category, which I think is fairly frequent, and that when people have probable symptoms of hypoglycemia, but they don't measure it. So do we not classify those as hypoglycemia? I think we should, at least in clinical practice, maybe not in research-related things. So hypoglycemia, at whatever level, has a lot of impacts on the patient. It affects quality of life, work productivity. There are a number of studies showing these. But the importance is that it leads to changes in patients' behavior, different uses of maladaptation to this in behavioral terms of not titrating their dose, overeating, more weight gain, and increased cost. But the real problem we are addressing today is the increased morbidity and mortality, particularly cardiovascular disease, but overall mortality also being associated with this. So this is an old paper, one of the early ones to point out that hypoglycemia is very common in type 1 diabetes and is also common in type 2, but it's less frequent than in type 1. So here is a more recent paper, more generalized population in the US, talking about how often people get hypoglycemia. And in type 1, as you can see, it is very, very frequent, occurring in 60% of people at least once a week, maybe more often, and in type 2, almost 25%. And now with continuous glucose monitoring, we're recognizing that asymptomatic hypoglycemia down to levels below 50 are occurring quite often. And some of this occurring at night or when the patient is somewhat vulnerable and events occur. And we are using more and more of continuous glucose monitoring to recognize this phenomenon. And here is one study showing, this is an early CGM study showing this is fairly frequent, just like with the other ones, but maybe more frequent in type 2 diabetes. Now, people who have a lot of fluctuations in their blood glucose due to treatment that's not right or behavioral factors tend to get more hypoglycemia. And that's not also surprising. If you're going to be fluctuating up and down a lot, you might overshoot and get hypoglycemia. The big problem is people are often unaware of their hypoglycemia. And this is very common in type 1 diabetes, but increasingly happens in older people with type 2, particularly if they have neuropathy. We also recognize that there are many risk factors for hypoglycemia. Long duration, as I mentioned, cognitive impairment itself can induce hypoglycemia, neuropathy because you don't recognize it, and other comorbidities, particularly hepatic and renal dysfunction. So sometimes there are self-management issues, medication overdose, taking prandial insulin and not having meals, exercise that's unusual at an odd time of the day without adequate nutrition, etc. So many years ago, we were among the first to describe a very interesting phenomenon that looked at people who had started insulin therapy in the VA population and had an episode of episode of hypoglycemia within the first 3 months. And then we tracked that and compared them with a control group who also started insulin, but did not get hypoglycemia in the first 3 months. And here what you see is that those who had hypoglycemia had more cardiovascular events. Now, is this due to hypoglycemia or just a marker that these people have comorbidities and other problems is not clear, but I think it is the latter. But it's very clear you're identifying a marker of future risk of cardiovascular rate. Big difference in rates of these events, particularly over the 2 to 3 year period. And a lot more seems to occur in people with known cardiovascular disease, as you can see from this study. Now, whether this is because these people are sicker with other comorbidities is also not clear from this population. Clearly, renal insufficiency and other comorbidities make it difficult for people to manage their diabetes well, and they also tend to have more hypoglycemia. Now, there's an increased risk in people with, people who have coded for hypoglycemic events. They also have very frequently increased risk of cardiovascular events, coding sometimes 10 times more. By coding, I mean documentation of both the diagnosis of hypoglycemia and a cardiovascular event. So here is another study from the Scottish group, Dr. Freer et al., who've done a lot of work in this area. And they looked at cardiovascular events in type 1 diabetes. And in people who have had more than one previous episode, their risk is 1.9. And in people with type 2 diabetes, it is 1.5. Perhaps there are other factors in people with type 2 diabetes, such as age and obesity, etc. This problem really came to the forefront with the Accord trial, where the trial, as you know, intensive therapy was stopped early because of an increase in mortality. It occurred actually in both groups, the standard group and the intensive group, and I'll go back into that breakdown. But it was associated it occurred more in people who had prior hypoglycemia, so they were dying more frequently. The Origin trial was another insulin trial, and they too also noted that there was an increased risk of mortality, although the mortality rates were much, much lower in people who had hypoglycemia. As you are aware, there are other studies, such as the ADVANCE study, the VADT. These were all done at the same time in different populations, and they all showed the same thing of increased mortality being associated with hypoglycemia. Now, the question is, are these people actually dying from hypoglycemia? And the answer is no. They're not immediately dying from hypoglycemia where the blood sugar is dropping just too low and the patient doesn't recover. Some of those increased deaths and events are occurring 2 to 3 years later. Now, that raises the question is, why is that happening? What is hypoglycemia doing? And we'll talk about some of the mechanisms later on, but I think an important issue in relation to this is that hypoglycemia is a marker, and it may tell you your patient's ability to recover before the glucose drops below 70, such as renal impairment, impaired hepatic and renal gluconeogenesis, etc., are contributing to their cardiovascular events, and it's just a marker there. And here's a meta-analysis of all these cardiovascular outcome trials that I pointed out to you. Those are at least randomized trials, but there's also a number of observational studies and retrospective studies, non-randomized, population-based, very large numbers, showing very much the same thing. So this meta-analysis is important, although it's mixing the two groups, which I don't particularly like, but it's got almost 1 million people with at least 1 to 5 years of follow-up. Let me just go back to the Accord trial, because we learned a lot of lessons there. If you look at hypoglycemia rate, it is obviously much, much more in the intensive treatment group than in the standard group. Remember, our aim for intensive treatment was to get the A1C below 6%. And I think nobody's really chasing that anymore with insulin. Maybe if you achieve that with some of the newer drugs, that's great. We also identified other factors involved in hypoglycemia, such as renal disease, African Americans, more in women, more as you get older, but high BMI with obesity being protective, maybe because these people have better body stores of nutrition. There are obviously patient-related factors, such as delayed meals, etc. That's not surprising, but it's not surprising in this population as well. What is interesting is that the risk of hypoglycemia didn't just occur in people who were well controlled. In fact, there were a lot of people who tolerated A1Cs of 6 very well. It was the people between 8 and 9 in both the intensive and standard group who had more hypoglycemia because we were trying too hard, and they were maybe sometimes not taking their insulin, so the A1C was high, and then they took too much and went low. And if you break it down into groups, and I won't spend much time on this, it occurred more in people who mortality was higher in people in the standard group who had hypoglycemia. So I think it's very tragic that people have A1Cs of 8% and have hypoglycemia. That is another population at increased rate, risk of mortality. So it's counterintuitive, but although intensive control does increase the risk of hypoglycemia, poor glycemic control also has a great risk of hypoglycemia, irrespective of what treatment you use. Now, as Dr. Nauk pointed out, this all changed when we started using GLP-1 receptor agonists. And you've seen the cardiovascular outcome trials, and clearly in the GLP-1 and SGLT2 treated groups, the hypoglycemia events are less. Now, does that mean that that is the mechanism? I don't think it's the only one, but certainly may contribute. The same thing is seen in people who are inpatients. So I want to spend the next few slides talking about inpatient hypoglycemia, where the responses and the severity and the problems and the end result is very similar to what happens with hypoglycemia. We all say hypoglycemia in hospitalized patients is bad, but so is hypoglycemia, because you get aggravation of ischemia and adrenergic responses and more oxidative stress, etc. So many early studies, particularly from cardiac patients, showed an increase in mortality in those whose lowest blood glucose in the hospital was less than 3 millimoles, almost doubling. So the relationship between blood glucose and death from myocardial infarction is actually J-shaped. The higher you have your glucose, the greater the mortality, but the mortality is very greatly increased in people who have low blood sugars. Here's another way of looking at the same thing with another study. So what's the mechanism? And a number of mechanisms have been proposed. I'm going to show you some data in a moment. They showed QT interval prolongation, decreased perfusion, endothelial dysfunction, increased coagulation, and etc. But before we go there, let's look at the physiological response to hypoglycemia. The first thing that happens when your glucose drops below 80, actually in a normal person, the first line of defense is to decrease insulin secretion. Now, you cannot do that when you've already injected insulin or you've taken a sulfonylurea. You can do that with GLP-1 receptor agonists because that is the action and is glucose dependent. The second is an increase in glucagon, then and around the same time, an increase in adrenaline. You get other responses later on with rise in cortisol, etc., and you start feeling hungry as it drops even further. But this is really the point we need to focus on. Are these things contributing to the events? Also, the brain may adapt to these changes. So brain function is changing, and you get further changes in autonomic function, which might be important in regulation of cardiac function. And I'll elaborate on that in a moment. So here are some studies that have been done looking at hypoglycemia and inflammation. So they did clamp studies, keeping people either euglycemic or hypoglycemic, and they looked at adrenaline increase, and that was very clear. But when they looked at markers of inflammation, such as selectin and markers like PMA, etc., they are clearly going up during hypoglycemia. Here is a study specifically done in normal controls and in type 1 diabetes. And you see the similar kind of things happening during hypoglycemia, that you are getting an increase in adhesion molecules like VCAM, selectin, PI1, which is involved in the fibrinolysis process, and inflammatory agent IL-6 going up. Now, this goes up in both normal individuals as well as in people with diabetes. So it is not something related to diabetes. It is related to hypoglycemia. Also, cardiovascular, these are the tests of autonomic function. They are very good predictors of reflex tests and tests of autonomic function and its regulation of endothelial function, and they're good predictors of mortality. And here's what happens when you have hypoglycemia. Your autonomic function is impaired. When you have little earlier had hypoglycemia, you're unable to to change your baroreflex sensitivity, and your output of sympathetic frequencies are altered. And this is another study pointing out the same thing. And you have an impairment in the longer term sympathetic and norepinephrine responses, but you can still get the burst at times that might lead to hypoglycemia. We did a study very early in 2002 when CGM first came out, doing Holter monitoring and glucose monitoring simultaneously. And we found in this population about 54 episodes of hypoglycemia, 10 of which were associated with chest pain. These were people with known cardiovascular disease, mainly type 2 diabetes. And 6 of them had ECG abnormalities. And some of them were symptomatic, some were asymptomatic. We also noticed a little bit of such events in people who had hyperglycemia, but it was a lot less. What was interesting was people who had rapid changes in their glucose, dropping by around 100, not necessarily dropping below 70. So say you go from 200 to 100, you had a greater risk of having chest pain and ECG abnormalities, suggesting that this can be just fluctuation in blood glucose, and a drop can change it. And here is one recording. This is a single case. It's cerebrovascular disease, and he had simultaneous Holter and glucose monitoring. And you see here he has hypoglycemia during the night. And around the time of that, if you go into more detail on his Holter, you see the start of ventricular tachycardia, just 3 beats. But if that hypoglycemia had continued longer, it's possible that he may have gone into prolonged ventricular tachycardia. So ventricular arrhythmias have been shown in other studies to be more frequent in people who have severe hypoglycemia, particularly in people with type 2 diabetes and CVD. It's very hard to document ventricular tachycardia, but triplets are almost likely to be a precursor to going over and progressing to ventricular tachycardia at some point. Here's a study looking at the QT interval, the corrected QT interval being prolonged during hypoglycemia, and then during recovery, it comes back down. There are other EKG changes that are described: amplification of the R wave, decrease in the ST segment, flattening of the T wave. All have been described in a variety of papers. And we summarized all this in a review article, Cyrus D'Souza and myself, showing the wide range of things that go wrong with hypoglycemia: decreased vasodilatation, increased inflammation, platelet activation, coagulation, and rhythm abnormalities, as I have shown you. So what do we do for patients? Let's get to something more practical. First of all, I pointed out the factors that make your patient at risk. So we need to assess patients' risk for hypoglycemia. We need to determine whether they have hypoglycemia or not. Now, that's a very hard thing to do unless you test more often. But today, even with professional CGM, blinded professional CGM for a couple of weeks, you'll be able to know whether your patient is getting asymptomatic hypoglycemia and therefore hypoglycemia unawareness. And just raising the glucose targets and the A1C targets may help overcome hypoglycemia awareness in some people. Also, any neurological symptoms are suspect, and neuropathy obviously is more commonly associated with this. And then there are strategies to prevent hypoglycemia. There are recommendations from ACE to do more frequent monitoring, use more flexible insulin regimens, and provide some ongoing guidance and support to your patients. The ADA also has similar recommendations: avoiding aggressive targets, adding carbohydrates before exercise, and also limiting alcohol intake. We should educate all our patients to treat hypoglycemia promptly. The 15-15 rule is check your blood sugar, eat 15 grams of carbohydrate, and wait 15 minutes and then check it again. And if it isn't right, repeat this whole process. Now, what has really changed our management of hypoglycemia and led to prevention of hypoglycemia as well with a lower A1C is continuous glucose monitoring. And here's a summary of some of those studies in type 1 showing a reduction in hypoglycemic rates in people with both high A1C and low A1C. And this has really been a game changer in this respect. There are also better treatments. Previously, you had to draw up the glucagon. There are now pens that are available, ready to inject. Some of them do require refrigeration, but there are now newer pens that are available that are pre-filled liquid glucagon. You don't need to mix it. It's a pre-filled syringe with an auto-injector, so very easy to use. And now you have a nasal powder for single use. This is very rapidly absorbed. You can take it during suspicion of hypoglycemia if you don't have time to test. And in fact, even in an unconscious patient, it can be administered by a relative. So it is more expensive, but we are using this in a number of people and found it to be very, very useful. And another form of glucagon called dasiglucagon has been developed, which is water soluble, which might allow this to be used in dual chamber pumps, the true artificial pancreas. So that is on its way. So in summary, hypoglycemia, both mild and severe, is associated with an increased risk of cardiovascular events and mortality and should be avoided when possible. We would obviously try to use more of agents that don't cause hypoglycemia in cardiovascular patients, but inevitably some people will need insulin. They impact quality of life. It may be a barrier to reaching goals that we want. It's a clear predictor of events. So you treat those as high-risk patients. People get hypoglycemia, be more aggressive with their lipids and blood pressure, and maybe avoid future hypoglycemia. So the underlying mechanisms are unclear, but there are some that have been identified, and maybe we should be addressing those as well. So I'll stop there and be happy to take questions.
Thank you, Dr. Fonseca, for that wonderful conversation on hypoglycemia and the cardiovascular risk. Sulfonylurea induced hypoglycemia. Does the management need to be different when it's sulfonylurea induced?
I think what matters is which sulfonylurea, whether it is long-acting or short-acting, renal or not. The more powerful ones, such as glibenclamide and glyburide, are clearly being identified as being associated with more hypoglycemia. So you shouldn't use it in that population. There's a little bit of encouragement in terms of glimepiride. The Carolina trial did give it to people with cardiovascular disease and cardiovascular risk and did not see more events than a DPP-4 inhibitor. So I'm a little encouraged by that. It's not cleared by the kidney. So that is, sulfonylureas are very much more affordable for many patients, and we often have to use it. The failure rates are not very different from DPP-4 inhibitors. So I still do use it for people who don't have access to newer drugs. But it is, we have to be cautious. Another thing is to reduce the dose. And in a few people, I may switch to meglitinides, which are similar in their mechanism of action, but very, very short-acting. Once the patient gets hypoglycemia, one important tip is to not say, well, eat a meal and don't worry, it will go away. If you have a long-acting one like glibenclamide, the patient may get hypoglycemia 2 hours later.
Absolutely. And what about the use of glucagon in such patients who do experience
obviously, if your patient cannot self-manage with glucose and glucose tablets or juice, glucagon is quite appropriate.
Right, and you showed the effects of hypoglycemia and cardiovascular impact. Again, there have been some papers which have differentiated between the impact of nocturnal hypoglycemia and the particular cardiovascular changes and daytime hypoglycemia. Your thoughts on that, sir?
Well, I think, nocturnal cardiac ischemia and cerebrovascular events is actually very well recognized even without hypoglycemia. The reason for that is unclear. It may be that some of your body rhythms and other things that hormonal changes are different at night and you don't respond. Also, you seek less. You're less likely to seek assistance of other people. And finally, your unawareness. You're naturally unaware when you're asleep. Thank you. Thank you. Thank you. Okay. Thank you very much.
Great, thank you so much, and sorry that Can you hear me?
Dr. Krishnan, are you not able to hear him over there?
Can you not hear me?
Dr. Krishnan, are you able to hear him, Dr. Gabby over there?
Can you hear me? Great, okay, perfect. Well, thank you so much for the invitation to speak, and sorry that I could not be there in person with all of you, and look forward to sharing my presentation. I'm going to pull up my slides, and I'm going to hope that, let me just, oops, I'm hoping that they are visible to you.
Yes, sir, they are visible.
Great. Okay. So we got through the hardest part of the presentation. What I'm going to talk about is the American Diabetes Association standards of care, and I'll review some of the new things in our standards of care, tell you a little bit about it, and then spend a little bit of time of the work that we're doing to go from those guidelines to ultimately having impact to improve care. So for those of you that may not be familiar with the American Diabetes Association Standards of Care, each year we publish this comprehensive set of guidelines that are really recognized globally, and they cover all aspects of diabetes. And they are put together each year by an amazing group, the Professional Practice Committee, that includes interprofessional leaders of all types, from endocrinologists, nephrologists, cardiologists, diabetes educators, dietitians, pharmacists, really pediatricians, pediatric endocrinologists, a wide variety of professionals that look at the evidence each year, pull all the papers, and then discuss, debate, and sometimes argue until we develop a consensus. And that is published yearly in the end of December, beginning of January in Diabetes Care. Because so much has been happening in the world of diabetes, a few years ago, we moved to something called the living standards, where because of the rapid changes, a year is too long to wait to update these guidelines, and therefore we update them during the course of the year as well, some important new information that's out there. So what I want to do is share with you some of the highlights of what's new in the guidelines. This is a comprehensive document, some 200 pages, and so obviously can't cover everything in the few minutes that I have, but I will tell you about the key themes. And I would say the key themes of what's new fall into 4 areas. New information about screening that I'll talk about, individualizing care, and I'll focus really on type 2 diabetes, but there's information about individualizing care for people with type 1, the importance of comorbidities, and share some information about that. And then finally, around glycemic assessment and technology, an area that is moving very quickly in the world of diabetes. So what's new in screening, and a few things that I want to alert you to. One, the recommendation that for individuals that are either obese or overweight and have other risk factors for diabetes, they should be screened starting at age 18 because there are many individuals being diagnosed with diabetes at much younger ages. And then the second recommendation is that everybody should be screened at least starting at age 35, and that is a change. Used to be at age 45, but the recommendations now are screening all individuals starting at age 35. And if those individuals screen negative at that point, then every 3 years they should be rescreened, or sooner if they develop new symptoms that are suggestive of diabetes. So that is a change. The other changes relate to pregnancy and preconception counseling, and specifically, oh, my battery's running low, specifically around women that are planning pregnancy should be screened for pre-existing diabetes, because that rate is much higher than we realize. And so all those individuals should be screened. And in addition, if they, women should be screened during that first trimester before 15 weeks of pregnancy for pre-existing diabetes. And that's in addition to the typical screening that occurs at the third trimester for gestational diabetes. So let me move on. So the next is around individualizing care. And here, this has been a journey. We think of individualizing type 2 diabetes care and particularly pharmacological therapy based on these 5 issues: the presence of comorbidities, hyperglycemia, weight, and how important that is, access and cost, and finally, efficacy. So this is a complex diagram. And I'm going to walk you through it. I'll point you to the very top, and I'll magnify that in a moment. But I want you to see that there are sort of 2 halves. There's all of this on the left, and then there's the information on the right. And essentially, the decision about treatment is really moving from one, making that decision as to which of those two issues are important. So this is magnifying the top, and it says that first-line therapy depends on comorbidities and then those other factors, but the comorbidities really dominate, and the comorbidities are the presence of atherosclerotic cardiovascular disease, the presence of cardiovascular disease or atherosclerotic risk factors, presence of heart failure, or CKD. And here's the new information that we think of metformin as first-line therapy, but the recognition is that even in the absence of metformin, if you have one of those comorbidities, you should be started on the agents that I'll describe in a moment, regardless of the presence of metformin. So no longer does one have to wait to use metformin and then move to these other therapies. So now let me move to the diagram below, and this is magnified. So again, atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease, you're on the left side of the diagram, independent of the use of metformin, independent of A1C. And here are the three comorbidities described. If one has atherosclerotic cardiovascular disease or high risk on the far left, it's really an SGLT2 or a GLP-1. If the individual has heart failure, SGLT2 here in the center. And if they have chronic kidney disease, it really depends on the presence of albuminuria. And I'll walk you through that in a moment. So let me move to the next diagram here. And here is if someone has chronic kidney disease, and it's a matter of whether they have albuminuria, in which case SGLT2 is preferred, and that's on the left-hand side. And in the new standards, you'll see some changes around the cutoff for albuminuria. So really the preference is SGLT2. In the absence of albuminuria, then one can think of either a GLP-1 or an SGLT2. So let me highlight this in a case, and I'll ask the audience to think about their response. So this is a patient, Edward. He's 45 years old. He comes to see you because he checked his glucose with his mother's glucometer. So hint number one, his mother probably has diabetes, and therefore he has risk factors. And he was found to have a blood glucose in the 200s. His A1C is elevated at 9.1. He already has a history of coronary disease, and he's on appropriate statin therapy and aspirin, and he's on an ACE inhibitor, lisinopril. And you can see his BMI is elevated. He is obese. So he has a number of risk factors, newly diagnosed, and the question I want you to think about is, what is the first line of therapy beyond lifestyle? And so here, I will give you a series of choices. If you have access to put it in the chat, please do. Otherwise, just at your seat, write down what your choice would be. Would it be starting a sulfonylurea, glyburide? Would it be an SGLT2 or metformin, GLP-1? Or the fifth choice would be, would you start two antihyperglycemic medications? So I'll give you a moment to think about your choices. And I will say that any of these choices are not wrong. I mean, you could use any of them, but I want to use them to highlight how we think about it within the ADA standards of care guidelines. So you've got your choice. So this individual has atherosclerotic cardiovascular disease. So he falls into the left-hand portion of the algorithm. Remember, The first step of the algorithm is, do you have one of these comorbidities? You go to the left-hand side. He has atherosclerotic cardiovascular disease. So he, regardless of the use of metformin, should be on either an SGLT2 or a GLP-1. The choice of those really is something that I would discuss with the patient, and the willingness of taking a tablet or a GLP-1, which of course is available at oral dosage as well, but typically is an injectable, and how willing they are to take the injectable, with the understanding that they will likely have significantly more weight loss. So that really is the treatment. And the question is, so it would be either one of those is a reasonable choice, SGLT2 or GLP-1, but metformin alone would probably delay the initiation of these therapies. You could, and this is probably where I would go personally, would be to consider two agents, because Edwards A1C was 9.1, and any one agent is likely to lower A1C probably 1.5 points. And to really get to below 7, they probably need two agents. And so it might be metformin plus SGLT2 or GLP-1. So a little bit of the thinking that goes on, as I said, whatever choice you made is a reasonable one, but I wanted to use that to illustrate the guidelines. So we talked about new screening. We talked about individualizing pharmacological treatment for type 2. You will see at the EASD meeting in Stockholm next month the final consensus recommendations by ADA and EASD will be presented there. We presented a draft guidelines at the ADA scientific sessions, got a lot of comments, and now we're finalizing it, and those new recommendations will be released in both diabetes care and diabetologia late in September at the time of those presentations. So tune into that. These are the Boston Gardens. I live in Boston, Massachusetts. Lovely place. And I'm going to move now. We talked about screening, individualized care, and now we're going to talk about comorbidities. And, largely the management of diabetes has moved beyond a glucose-centric view. It's not all about blood glucose, but the importance of managing comorbidities. And this diagram that I think you'll see reproduced in a lot of places helps to conceptualize that, particularly for our primary care colleagues, that if you want to ultimately reduce diabetes complications at the top here, it is lifestyle management and diabetes education. And then the 4 pillars of care that one needs to consider. So glycemic management to the far left, always been there, and we know that's important. But we want to really highlight that it's the importance of blood pressure management for macrovascular disease, probably even more important than glucose in terms of reducing morbidity and mortality. It's lipid management, and then the use of agents that reduce cardiorenal risk, which is what we just talked about. So important considerations there. Some of the other updates of what's new in the standards of care is, for the first time, providing a guideline around reduction of albuminuria. And so that not only should albuminuria be measured and followed in all people with chronic kidney disease, but one should target a reduction of that albuminuria by at least 30%. The other new consideration is the important use of finerenone, a mineralocorticoid receptor antagonist that should be added as therapy in individuals with chronic kidney disease to lower not only their progression of chronic kidney disease, but also congestive heart failure and atherosclerotic disease. And then finally, ongoing follow-up of individuals with diabetes should be not only eGFR, but ongoing measurement of albuminuria. Other important comorbidity considerations are around COVID vaccination, which continues to be a problem globally, and I know there in India as well. And then some important recommendations, and you'll be seeing more and more about this, around liver disease and diabetes. So diabetes is now becoming the leading cause of liver disease, both of NASH and NAFLD, non-alcoholic fatty liver disease. Recommendations about screening for those diseases, as well as recommendations on medical therapy that can be effective. Pioglitazone, GLP-1 have both been shown to be effective agents. There are some early studies on SGLT2s, and I think we'll see more studies on those. And there are a number of new medications in the pipeline that will also be potential treatments for liver disease in people with diabetes. The other important consideration is cognitive impairment. We now know that people with diabetes are at higher risk for cognitive impairment. It does appear to be linked to glycemic control. We should be screening for that cognitive impairment and adjusting therapy and complexity of therapy based on cognitive impairment that might exist. And there are randomized controlled trials that show that simplification of therapy in those with cognitive impairment can reduce hypoglycemia and lead to better outcomes. Okay, so we have gone through 3 of the 4 themes, and now I want to move to that 4th theme. We did screening, individualized care, comorbidities, and I want to end talking about glycemic assessment and technology, and then talk finally after that about implementation, which I think is where we are really focusing a lot of our attention at the ADA. So in terms of glycemic assessment, continue to focus on time in range. And for those that are using blood glucose monitoring alone, then it can be readings in range. And the importance for those that use blood glucose monitoring instead of continuous glucose monitoring is to not only check at one time a day, only at fasting, but to stagger the times that the measurements are made. And you can see the AGP report here. This is the kind of data that we recommend people looking at. 14 days of measurement is sufficient to make medication adjustments, and there are different target ranges defined that are helpful. And the other important consideration here is that when one is looking at this kind of data, the first thing to look at is the hypoglycemic range and what change in treatment or recommendations or education should be done for the area in the red zone, that hypoglycemia. That's the first point of addressing, and then one moves on from there. Other recommendations really are around that 14 days are really sufficient for continuous glucose monitoring measurements to be able to make recommendations and change in therapy. I think that's something we learned during the pandemic when really a lot of diabetes management was virtual, and those that had continuous glucose monitors were really a great way to be able to assess their glycemic control and make adjustments, and that data should be used for medication adjustment. One does not need to wait for A1C measurements. In addition, came out very strongly based on the evidence, and you'll see all the studies summarized in the standards of care, that continuous glucose monitoring should be used for really all people in the pediatric age group, in children, in adults, in older adults, whether they are on insulin pump, multi-dose insulin, or basal insulin alone, based on, again, RCT results, and that really is a strong recommendation. And we understand that this not all individuals have access and something that we are working on from an advocacy point of view. So I went through the 4 areas that are new, and I want to just share a little bit of our strategy of moving from those guidelines that I just shared with you, and how do we get them to impact? And we really think of this in 4 stages. And the first being what I sort of described is creating evidence-based guidelines, letting the science drive what those guidelines are. The rigorous process of the standards of care have been in place, and I shared those guidelines. The next step is to the right here, and that is really disseminating those guidelines, because again, just having them really does not impact care, and that's one of the things that I'll talk about. And then it's about educational programs to make them more clear, and that's in essence this kind of program is so valuable in doing, and appreciate the invitation. And then finally, the quality improvement in the lower right. How do you implement that into practice? And many times this is at the local level, looking at how your clinic is organized, who else on the team can help. So on the first step, in terms of the dissemination, we've been successful here. These are the standards of care. We've already, each year, we disseminate this to 4 million people around the world. We're looking to expand that in a number of different ways. And not only do we have this large document that describes the standards, but we've moved to new ways of disseminating this, and I'll show you what's listed here. These are all available free on the website below, professionaldiabetes.org/SOC. There are the full version. There is an abridged version for primary care that you can see. There's a wonderful app that you can download so that you have that information in real time. It is interactive. It allows you to enter patient information to guide therapy, but it also allows you to search the entire standards of care for keywords to find the information that you want. There are podcasts, pocket cards available, webinars, and we've been moving to creating visuals that make it easier for people with diabetes and their caregivers to understand. And this is just an example of that. So for women with diabetes or planning pregnancy, a quick way to see what those recommendations are. This could be something posted in your clinic. It also is being spread through social media to both healthcare professionals and again to patients so that they can quickly understand what is necessary. So that's how we are working on disseminating the standards of care. Educational programs are what we're doing today, and I've done grand rounds around the country, speaking at programs like this with a global impact that you have, and appreciate the invitation. And then, you know, moving to sort of quality improvement. And we have an initiative that has been going on called Overcoming Therapeutic Inertia. And quickly described, therapeutic inertia is the observation that a patient sees their healthcare provider not at goal for therapy, their A1C is elevated, and they leave without any change in therapy. And it turns out that this happens very commonly, and it is not the fault of the provider or the patient. There are a number of different factors that need to be addressed. I will point you to our website where you'll see short videos that help one address this. And then on the right-hand side is systematic review that has looked at all the interventions that have been looked at to overcome that problem of therapeutic inertia and what has been effective. And it is quality improvement efforts like the ADA's Diabetes Inside that, for example, our previous speaker, Dr. Fonseca, implemented across his health system with great results, and largely spreading the work beyond just the physician to other healthcare team members. So with that, I gave you a sense of what's new in our standards of care, what we're doing about implementing those standards to have impact. And again, appreciate so much the invitation to speak to all of you and to answer any questions you may have. Thank you so much.
Thank you very much, Bob, for that excellent and exhaustive presentation. So I am also joining virtually. So I have a question. I have a question to you. So we have been discussing about the AGP report, and we have also been in India following the same. So how do you decide on the frequency in type 2 diabetes on continuous glucose monitoring? For example, in well-controlled diabetes, in poorly controlled diabetes, in very poorly controlled diabetes, what should be the frequency of the 14 days of CGM to decide on the percentage time in range? And the second question is, historically, we were not recommending glucose monitoring routinely in those patients on oral agents. But majority of those on oral agents were very poorly controlled diabetes. So how frequently you will recommend continuous glucose monitoring and an AGP report in those only on oral agents?
Wow, that's a lot. They're great questions, and they really, thank you for asking it, and they really represent the cutting edge of where the science needs to go. So in the first case, for people with type 2 diabetes and use of CGM, for individuals on insulin, really continuous use of continuous glucose monitors are recommended because that information helps them to make decisions and treatment in real time. But really the area where we're less sure, and I suspect was really the target of your question, is what about those on oral agents and what the frequency should be? Because the evidence of those individuals using continuous glucose monitors all the time is really lacking. The best evidence there has really come from the world of digital health companies that have been engaging individuals with diabetes using intermittent CGM use. And like most monitoring for individuals with diabetes, some of the frequency is dependent on how far they are from goal. And so those that are poorly controlled, one might think of a 2-week use, because that does seem to be the amount of time necessary to get a good set of glycemic assessment to balance out the day-to-day variation of lifestyle. So that 2-week use then should include some feedback from the healthcare team about change in therapy or change in behavior, then giving that individual some time to make those changes, an agreed upon frequency of, okay, let's look at this another 2 or 4 weeks, you're going to work on these changes, and now reassess. That reassessment frequency will depend a little bit on how far from goal they are. So I think that's that first question of frequency of use of CGM in type 2. Now, the second issue is blood glucose monitoring. And the studies that have looked at the efficacy of that in individuals on oral agents has been a mix. And largely, if you look at that data, the reason that they've been a mix is if you have somebody just monitor their blood glucose, but the healthcare professional does nothing with the data, well, then, yeah, it doesn't do that much, right? That's maybe no surprise. In the studies where the individuals have done glucose monitoring at home, shared that data with the healthcare professionals, and they've given them feedback, yes, then we do see value in that. And the value is really in two opportunities. One is it provides feedback for the individual with diabetes on what they do and how it affects their blood glucose, what they eat. Wow, I had more rice this time, or I had some delicious, I'm blanking on the name of the delicious rice pudding that I've had in India. Those types of things, wow, they see, oh, it went way higher than usual, and maybe I should have a little less of that next time. So feedback on behavior is one place where that blood glucose monitoring can be effective. And then the other is to make changes in medical regimen by the healthcare professional much quicker, not waiting 3 months for an A1C, but getting that data over 2 weeks and seeing, wow, all the blood glucose levels are high, let's add an additional agent.
Thank you so much. I'm passing on to you, Dr. Unnikrishnan and Dr. Sujoy. Right.
Well, thank you all very much. It's a delight to join. It's an amazing program that you have and a wonderful talk about the guidelines. I have a very broad topic that's basically your entire program. I'll talk about and try and be complementary with the next talk that'll focus on renal disease. And Ian DeBoer and I nicely worked together on the ADA guidelines a few years back. So it's a delight to join everyone. These are my disclosures that have research grants or consulting on advisory boards with all sorts of companies, many of which have the diabetes medications, also a lot of lipid related drugs. So lots of disclosures for me. So just to start somewhere, we all know this, but a nice summary slide where diabetes causes everything. And makes everything worse. Cardiovascular disease is seen at a 2 to 4 times higher rate. I think with the new therapies, we're realizing that a big opportunity for a reduction in heart failure, which turns out to be a very common component of diabetes, although for decades, I've mostly thought of it as vascular issues with stroke and MI and cardiovascular death. And so, it does take off about 8 years of lifespan when looking, at how long people with diabetes live versus without. This is a nice summary of how patients present with cardiovascular disease. And kind of interesting. So patients on the left don't have diabetes and on the right do. So there are many similarities. But standouts at the top of the list there are peripheral arterial disease, where diabetes is a huge risk factor. Smoking is its other big risk factor. But then heart failure is there as the very next thing. And then angina, MI, stroke, coronary disease, all the vascular events. But heart failure really is the second most common way that patients will first present with some type of cardiovascular disease. And so thankfully, we have therapies targeted at both aspects. And so I think we just saw this, but this is from the guidelines. I think this is a new figure this year that is a wonderful, simple, but framework for all the different things that we need to think about in managing patients with diabetes. And so there are 4 pillars of areas that we think about, but you'll see on a foundation of lifestyle modification and diabetes education. And so the education part is key of explaining what is diabetes, what are the risks. Surveys have found that patients don't realize that cardiovascular disease, and as we'll come to in the next talk, renal disease are huge factors in the evolution of diabetes and really the complications. And so patients to understand that is really a first basic step, that we're really trying to move their understanding beyond, oh, what's my glucose, to what's my glucose, my blood pressure, my cholesterol, oh, how are my kidneys, what else do I need to do to prevent, heart attack and stroke? And so really educate patients about all the things that we have to worry about. So then the pillars listed here are many of the basics, glycemic management, blood pressure and lipids, but then this, focus on the kidney, but also on cardiovascular outcomes and doing that sort of independently of the risk factors. So it's a little bit of a change in mindset where one has to think of, oh, I'm going to manage the risk factors, but then also think, am I getting my patients onto the therapies that are shown to prevent cardiovascular and renal events? So this is a slide a colleague did, Mark Banaka, who's at the CPC research group in Colorado. And it's kind of daunting to see, but all these things are proven to help. So it's just amazing, basically. We always think about diabetes, high risk, look at all the things that we have to offer that are now shown in large clinical trials to be of benefit. And so we have to then take a few visits really to get people onto, or many visits really, and an ongoing engagement with our patients to tackle each of these domains of management. And so upper left, blood pressure, that was the first, after glycemic control, the pillars, and the diabetes is on the right of managing the glycemic control, but then lipid modification, antithrombotic therapy, therapies focused on the kidneys. It's more than just ACE inhibitor and ARB now. So there are 3 other new classes of drugs that have been shown in just the last few years to be of benefit, and Ian will go through all those. But then same thing for heart failure, that now at the top of this list is SGLT2 inhibition, then some of the basics, but new data showing all of the benefits on heart failure. So this slide sort of becomes, and I think I've made it as my conclusion slide as well, of just a list of all the things that we have to remember, and then look over each patient and say, are they on all these different things? And the short answer is very few people are, because there are so many things that we have to think about and offer. But what a wonderful time to be practicing medicine, to have all these things to offer. And so I try and convey that optimism to patients, to say that we have lots of good therapies to offer and improve their outcomes. So this is, again, from the guidelines that we just covered, but to show that there's a very nice algorithm. I think Ian DeBoer first published this as an extra thing for the ADA, and then it's been a cornerstone of the standard of care document, making a very nice point that sometimes one has to start 2 agents if blood pressure is very poorly controlled, but then also to look at albuminuria and presence of coronary disease to start choosing and adapting which therapies exist. And the part 2 of the figure I won't show, but very nice algorithm that one can manage. So for lipids, I've listed here the figure from the ESC and EAS document. This is from 2019. It's the sort of the simplest rendition of what I do in practice, and I think is nicely evidence-based, that we obviously start with statin therapy, get patients to their highest dose. So if they have documented disease, that you want to be on high dose statin, and then you check the LDL and see, is it at goal? And so for primary prevention, we'll aim for an LDL less than 100 or roughly 2.5 or 2.4, I guess, millimoles. But then 1.8 millimoles or less than 70 for patients with atherosclerotic disease. So if one is not at that goal, then you add ezetimibe, recheck, and if not, then think about PCSK9 inhibition. So all of these are nicely evidence-based, and we have to walk through patients and help them get to their goals. Beyond LDL, though, there's also a therapy now for patients who have high triglycerides, which is hugely prevalent in India, but now worldwide, certainly in the United States, it's becoming, a huge issue. And we now have an evidence-based therapy. And this is split out in patients who have diabetes, who also have high triglycerides, and adding icosapent ethyl, the EPA-only omega-3 preparation at the higher dose of 4 grams a day, shows a huge benefit, both on first events, but the top curves you can see over a 5-year period, patients with an LDL on average at 70, had 50% of them had cardiovascular events, and that could be reduced to less than 40%. And that's actually a cumulative number of events per patient, so it's per 100 actually. But in any case, a huge benefit with a therapy targeted at the high triglycerides. And so this is the concluding slide of my lipids talks, where this is how I practice, and I'm spending a lot of my time in lipid management now. Of with primary prevention, that same algorithm, usually just statins and ezetimibe there, targeting the LDL less than 100. One thing I've been doing more of is in patients who have a lower ASCVD risk score, but say high lipids, and they're not sure they want to start treatment, I've been doing a calcium score to see whether or not patients have atherosclerosis. And if so, then I push the target down to the ASCVD target of less than 70, and it becomes clearer for the patient that, oh, there's atherosclerosis starting. We have to really get you onto therapy and get things lower. For patients with statin intolerance, using 3 times a week dosing of a half a pill of the smallest dose of rosuvastatin is a little trick that I found that I try, that sometimes people who've had trouble with statins can tolerate what is about 1/10 of a normal starting dose. And then if not, move on to statins, PCSK9, bempedoic acid is also another option as well. And then as we just touched on, the icosapent ethyl. So for antithrombotic therapy, the issue in primary prevention has been a hot topic, and guidelines in the United States and worldwide have been revised. In patients with diabetes, there's the very nice ASCEND trial that showed that there is a significant reduction in cardiovascular events by 12% when taking low-dose aspirin for primary prevention. But it's balanced by an increase in bleeding. And so in absolute events, for every one cardiovascular death or stroke prevented, there's a major bleed created. And so it becomes a discussion with patients of whether they could tolerate it, had they had bleeding issues before or GI issues. Taking a proton pump inhibitor will decrease the bleeding risk by half. And so it's a discussion there. I think without diabetes, and certainly in older patients, it's really no longer recommended because there was no benefit in the ARRIVE trial. And then in secondary prevention, it's obviously a cornerstone of treatment that we do keep it. Sometimes we're adapting and dropping the second antiplatelet, but in patients with atherosclerosis or acute coronary syndromes, you basically follow the standard recommendations for dual antiplatelet therapy, et cetera. So on to glycemic management or use of glycemic agents for cardiovascular management, as we would say. And this is a blow up of the figure that, we've probably been seen like 10 times during this Congress. But very nicely, and sorry, it's a little fuzzy, but the language has been very carefully crafted to say that first-line therapy depends on comorbidities, patient-centered management, and generally includes metformin. But you can see it softens that to acknowledge that in some cases, using other agents that are necessary for the other patient characteristics, such as atherosclerotic disease, heart failure, or CKD, might take a higher priority than starting with metformin. And so then the third, this red box here says that the key management that I think we're all now starting to incorporate is to not just focus on the glucose, but to risk stratify patients into whether they have these other major comorbidities and then tailor the therapy accordingly. So then this is done really independently of the baseline hemoglobin A1C, their target, or whether or not patients are on metformin. So it really is a clinical diagnosis and then adding these indicated therapies. So for ASCVD, it's either the GLP-1 receptor agonist or SGLT2 inhibitors. For heart failure, really the benefits have been seen with SGLT2 inhibition. And then Ian will go through for CKD that SGLT2 is given preference, but GLP-1 has benefit on albuminuria, and the outcomes trial for CKD is pending. So we'll know more coming up. So I'll go through the first two of these segments. So nicely, when Ian and I were part of the group, there was a partnership with the American College of Cardiology that they published a parallel document that is displayed here that now is a figure 10.3 in the 2022 ADA guidelines, so that we're getting cardiology and the ADA totally in sync on how to approach management of patients with diabetes. And the key thing right in the middle is that we address concurrently all of the optimizing of the various risk factors, including glucose, but then do this patient-specific targeting of the cardiovascular and renal benefit for outcomes. And so we really do two thought processes to try and say, are they on the right preventive therapies, and am I managing all the risk factors appropriately? So here, the mechanism I think you've already covered in earlier in the day here, but the benefit of SGLT2 inhibitions really is still being understood, but lowers glucose and hemoglobin A1C. There's some weight reduction, but cardiovascular risk and renal progression is what's been seen and why we're pushing so hard. I think, again, Ian may show, but the bottom right corner has been my takeaway out of all of these different factors. The effects in the glomerulus of unloading the pressure inside the glomerulus is my simpleton's understanding of how these are so powerful. But all of these different factors contribute to the benefit that's been seen on both cardiac and renal protection. So the clinical trial database in both of these classes of drugs, SGLT2 and GLP-1, is huge. We have like 22 trials, major outcomes trials now across the two groups. I think it's 22. It's amazing. This is a quick overview of 4 of the initial trials in ASCVD patients. And so what's been seen is basically benefit across these 3 different endpoints of major adverse cardiac events, cardiovascular death, and hospitalization for heart failure. The green are significant p-values and the yellow are trends, but you can see that there's a benefit seen on, with lower hazard ratios on each of these. And so it's really been a nice, consistent finding. We did a formal meta-analysis of the first 5 of the trials. I guess we included credence. And I think these numbers have and percent benefit have largely held up when you add in more and more of the trials. So for major adverse cardiac events, it's about a 10% reduction in MACE that's been seen across the trials, largely consistent with them. For cardiovascular death, it's overall about a 15% benefit. More benefit was seen in the first trial in EMPA-REG and more moderate benefits seen in others, but it averages out to about a 15% reduction in cardiovascular death, highly significant. And so this is a therapy that's saving lives and a really nice thing to share with patients. So for the GLP-1 receptor agonists, also multiple mechanisms, and I'm not the person to speak to this. I'm still learning all of these things on this slide and trying hard, because this is a class of drugs that is having a terrific benefit and is evolving with dual incretin agents as well, with here, slowing of gastric emptying, so more satiety, but then, changes in the metabolism are my hand-waving understanding of how these agents have wonderful benefits, but changes in lipid metabolism and reductions in inflammation. So as therapies are seen to be of benefit, we look back and understand all of their positive mechanisms for that. And there are many with this class of drugs. This is a meta-analysis of the MACE outcomes. It was about a 14% reduction across the 8 trials included here. So, and a nice consistency. So really nice benefits seen on each of the different endpoints of cardiovascular death, MI, and stroke. And so thought in some people's minds to have a little bit more of a vascular effect. And so, better impact on MI and stroke with this class of drugs. Ian, again, will touch on the kidney outcomes, but a benefit seen most markedly on albuminuria, but, wonderful findings there. There is not an effect that's been seen so far on heart failure with the GLP-1 receptor agonist. So it's, not significantly reduced, not surprisingly. And so that ACC-AHA document had a nice table that helped us pick and choose. How would you choose, if you have a high cardiovascular risk patient, between these 2 terrific new classes? And so I think the key for me are the second, third, and fourth lines, where for heart failure patients or patients at risk of heart failure, the SGLT2 inhibitors really have a known benefit. And the next segment, I'll go through all of that. weight loss is much bigger with the GLP-1 receptor agonist. And so very often my patients are in desperate need of help. They've been trying diet and exercise and, doing all they can and not really making as much headway as they would like. And so for those type patients, a GLP-1 receptor agonist could be really a wonderful way to add cardiovascular protection, but then also help them on their weight management. And again, for renal diseases, as will be covered, a little preference to the SGLT2. So I'll do a segment now about 10 or 12 slides on heart failure. And this has been really a revolution in the last few years, where suddenly we have multiple new drugs that are available. So there's a new guideline that was published this year from the American College of Cardiology, AHA, and Heart Failure Society of America, where it talks about the different classes of drugs that one can offer. And they put in a new staging where they have patients at risk for heart failure, so stage A. And so these are patients who have some of the risk factors, notably diabetes, as we just saw, as a risk factor to develop heart failure. So a patient who's not had anything. But then stage B is the pre-heart failure, where patients would fall into this category if they had documented low ejection fraction, but without heart failure symptoms. Or be cardiomyopathy patients or recent MI. So there, the LV dysfunction, but without symptoms, would be that stage B. And then stage C is symptomatic, and stage D is markedly symptomatic. So here's the treatment algorithm, where you can see 5 green boxes on the left as step 1. And this is for managing stages C and D, so symptomatic heart failure, where you use diuretics as needed, the bottom one. But then there are the 4 pillars of therapy. And so it used to be ACE or ARB, but we now have the data showing an ARNI, or neprilysin inhibitor with ARB, as superior to ACE and ARB in different trials. So that's one pillar, to try and get patients onto an ARNI. Then beta blockade, especially for the low ejection fraction, a little bit less data for the preserved ejection fraction for beta blocker. But then mineralocorticoid receptor antagonists and SGLT2 inhibition, the newest addition. And then as patients get onto those 4 pillars, there are other considerations of an ICD or CRT, resynchronization therapy, and then obviously transplant if all else fails. But our focus is really on the left bar to try and get patients onto those 4 pillars of therapy. So some of the trial data to support this. So the use of an ARNI, sacubitril valsartan, was seen to be better than enalapril in patients with HFrEF in the first trial. A highly significant benefit, 20% benefit. So most of my patients are on ACE or ARB, and then when I'm seeing them, or if they land in the hospital, trying to get them onto ARNI, it's usually a long process, because the blood pressure, is often low to begin with. But this is definitely something we want to try and work on. Aldosterone antagonists, these are the 3 trials that have low ejection fractions, or heart failure population from years ago, a post-MI with low ejection fraction, and again, the emphasis trial as well. So, clear, highly significant benefit of MRAs. So then for SGLT2 inhibition, the top part are from patients with atherosclerosis or the renal disease. The bottom are the HFrEF trials. A consistent, very interesting, about a 30% reduction in every single trial. It's the same benefit that's been seen, regardless of the patient population, whether you're stage B heart failure or even stage A, which would be most of the top panel, or stage C would be the bottom panel, the HFrEF patients. So, clear benefit for the SGLT2 inhibition. One of the more recent trials has looked at this following an acute heart failure admission. So this is with sotagliflozin in the SOLOIST trial. You can see an immediate benefit starting within a week or two, and an amazing benefit. So here are the data at 1 year. You only need to treat 4 patients with an SGLT2 inhibitor to prevent a cardiovascular death or hospitalization for heart failure or urgent heart failure visit. I mean, it's incredible. I don't think there are many things in medicine that have a number needed to treat for 1 year of 4. So this is the highest risk setting of a heart failure patient. The stable atherosclerosis patients are at risk of developing heart failure. So there's really this full spectrum where there's always benefit of this class on heart failure. So a wonderful reminder that this is really a key therapy. So the issue is, how do we get people onto all these treatments? And so the traditional sequencing is shown on the left that actually is on the basis of sort of a chronologic series of when were these therapies shown to be beneficial in clinical trials, with ACE or ARB as step 1. I should mention my dad was actually part of the very first captopril trial in heart failure many years ago. But anyway, then beta blockade is a cornerstone of heart failure treatment from, again, 20, 30 year ago trials. Then we looked at the data for MRAs, and then the most recent comparison for the neprilysin ARB, and then the SGLT2. So that would be a traditional, I've got to get them on the basics and then start adding the new therapies. But we're realizing we need to rearrange that order. And, many people are on a beta blocker, and this is especially for HFrEF, where beta blockade is important. It's really less, there are very few data in HFpEF about beta blockade, but the others apply. But SGLT2 inhibition, we just saw, has almost an immediate effect. It's very easy to start with, very few issues. You check the creatinine to make sure there's not a huge detrimental effect, but there very infrequently is. Then, converting over ACE or ARB to the neprilysin inhibitor could be a second step, and these aren't cast in stone, but then an MRA might be the final step. So the SGLT2, because it's easy and has a big and early effect, is something that could move up in our thinking of how do we try and get patients onto the different 4 pillars of therapy. And there are some trials now starting up of how do we do this and what's the sequence. And it's an area that's really difficult. And when I'm on service, it's really hard to get people onto all 4, for a hospitalized patient because of, hypotension or renal disease, et cetera. So here are the data in HFpEF. So again, with the ARNI as compared with an ARB in this setting, a benefit was seen on total hospitalizations for heart failure or cardiovascular death, and this was approved by the FDA for use. So really a benefit that's been seen largely across the full spectrum. When they've analyzed the fully normal ejection fraction of above 60, it's sometimes a little bit of a question mark of whether there's added benefit, but certainly everything from basically normal to any reduction, there's a clear benefit of converting over to the ARNI. These are data from the HFpEF trial that's been done with spironolactone. Overall, a non-significant finding, but a benefit on hospitalization for heart failure. And then, they had issues with probably inappropriate patients enrolled in Russia. And so when you set those aside, it's beneficial. So this is likely a beneficial therapy, but the data are just sort of medium strength, I would say. There's a new trial in HFpEF with finerenone that's just getting started. And so we'll have more data with this general class coming soon. And speaking of finerenone, I think Ian will speak more about this, that this is one of the 2 trials that, was focused on, could this new MRA agent prevent progression to renal failure? But in the middle, you'll see that cardiovascular death, MI, stroke, and hospitalization for heart failure, they're all reduced as well. So very similar findings as we've seen with the SGLT2, but with an MRA. And so more data coming in the heart failure setting, but certainly a benefit seen on cardiovascular outcomes in a largely, kidney disease, which overlaps with ASCVD in a big way. And so that was added into the guidelines as well, more from the renal endpoint. And so these are the data for SGLT2 inhibition in the 2 dedicated HFpEF trials. We have the published data from Preserved, and we've had announcements on the Deliver trial, but similar benefit seen. So really that same story, that regardless of the patient population, the SGLT2 inhibitors prevent heart failure, or in this case, CV death or heart failure. And a final reminder that for heart failure management, just as for atherosclerosis and diabetes, that we do have to remember all the non-pharmacologic components of this. And so dietary counseling and patient education, physical activity, emphasis on compliance is huge, and good follow-up. Thinking about other things like sleep disorders, and thrombotic risk. So there's lots of other things to think about in our heart failure patients, and especially in those with diabetes. So final data slide, how are we doing? And answer, not so hot. This was a lipid registry that Mikhail Kosabora and I helped lead, where we looked at lipid therapies, but then this was a focus on the patients with everyone had ASCVD who also had diabetes. And then we looked at the use of SGLT2 inhibition. This is about data from this snapshot was 3 years ago, but just 8 or 9% of patients with ASCVD, diabetes, were getting the proven therapies, and so quite low. And then when you start adding up all the different things, we have a long way to go. And so I again come back to my very exciting list of all these wonderful therapies that we try and work with patients to get onto. And it really takes a while to optimize all of their treatments, but each one of them will provide benefit to them. So thank you very much for your attention.
Yeah, thank you, Unni, thank you. So anyway, it has been a very extensive presentation. We really enjoyed it, and our doctors in India are going to have a real benefit out of your presentation. So thank you so much. So Christopher, I have a very silly question. So we have been going through the EMBARK data, I have been going through the data from other cardiovascular outcome trials, and you have been highlighting the cardiovascular death reduction with empagliflozin. So after the real world evidence and with the accumulation of further data, do you still believe that all these are the same in the same family, or are these drugs different?
It's a very good question. I think it comes up with just about every agent. The answer is, I think it's a class effect, because there aren't any magical things necessarily about one drug versus another. They obviously can have different potency, sometimes bind differently. I think the best example of that are in the 2 HFrEF trials, where and I forget which one is which, but in one of the HFrEF trials with empagliflozin, there was a significant reduction in mortality, but not with dapagliflozin, and then vice versa in the other. So, in the cardiovascular outcome trial versus the heart failure. So to argue, I guess it was in EMPA-REG, there's a mortality benefit, but in EMPEROR it was not. Yeah. But in dapagliflozin in the ASCVD, there was no CV benefit, but in DAPA-HF there was. So that's the comparison. So what I've come away is that there are confidence limits around any point estimate. And the statisticians always try and remind the clinicians there are confidence limits for a reason, that you get an individual answer, but if you did the study again, it could fall over on this side or on that side. And so the consistency with all these different trials that we have, the consistency, especially on heart failure, it's just amazing how consistent it is in vastly different patients. That to me really helps argue that it's the class of drugs rather than the individual type. I think here in the United States, our choice is often dictated by the insurance company. And so, what little hair I still have, I pull out every time that we face this. But it actually doesn't matter quite so much, that it's really a matter of trying to get all that long list of therapies, to try and offer these to the patients as the key, as opposed to which specific one.
Thank you. Thank you very much. Good.
International guidelines for rapidly emerging new evidence. Dr. Andy Bose is a professor of medicine at the Division of Nephrology and has done his nephrology fellowship at the University of Washington at Seattle, and also has been a specialist in kidney disease.
Well, thank you for that very kind invitation. It's really a pleasure and honor to be part of this session with this audience and joining two fabulous speakers, in Dr. Gabay and Dr. Cannon, whose presentations I immensely enjoyed. And I think it's interesting that as endocrinologists, cardiologists, and nephrologists, we're really coming together around this concept of improving clinical outcomes for people with diabetes and improving the complications of this disease. And I think you'll find that our recommendations continue to be highly aligned, that we're sending a similar message. My perspective comes from the kidney disease perspective as introduced, and I'll be focusing on what are called the Kidney Disease Improving Global Outcomes, or KDIGO guidelines. KDIGO is the preeminent kidney guideline agency internationally, and they've recently issued diabetes and chronic kidney disease guidelines, which are being updated this year. And I'll give you a preview of some of the changes and recommendations and new recommendations, which Chris Cannon alluded to as well. Here are my disclosures. I have consulted for a number of companies that make SGLT2 inhibitors, GLP-1 receptor agonists, and other agents that I'll try to talk about in an unbiased and fair way. And I just want to take a few slides to address the question, what's the big deal about kidney disease? And the first answer to that is that kidney disease is common in both type 1 diabetes and type 2 diabetes. And I'll show just one slide on that. On the left is from the DCCT IDEC study of type 1 diabetes, looking at the cumulative incidence of albuminuria by duration of type 1 diabetes. And you can see here that in the top line, people who had conventional diabetes therapy had a rapid increase in the incidence in the prevalence of albuminuria during the second decade of type 1 diabetes, with a leveling off around 40%. With intensive diabetes therapy, that was reduced to about 25%. And on the right, you can see data from type 2 diabetes looking at the prevalence of chronic kidney disease, either manifest as albuminuria or low eGFR or either one. And I'll focus on the left here, the either one column. This is stratified by the duration of type 2 diabetes, and you can see kidney disease prevalence is strongly related to the duration of diabetes and type 2 diabetes as well, exceeding 40% with people who have had 20 years of type 2 diabetes. And so from these sorts of data, and there are other cohorts as well, we generally say that about 40% of people with type 1 or type 2 diabetes eventually develop kidney disease. And of course, kidney disease is the most common cause of kidney failure in the world. These are data from the United States Renal Data System, showing the incidence of new kidney failure requiring dialysis or a kidney transplant over time from 2000 to 2019. Diabetes is the leading cause, accounting for about half of all cases of kidney failure in the United States. It's a major impact for individuals who develop this and for the healthcare systems in the US and around the world. And even short of developing kidney failure, chronic kidney disease is a very strong risk factor for cardiovascular disease and mortality, as Chris pointed out. And these are data, again, from the United States, looking at the association of kidney disease with all-cause mortality over 10 years. This is the absolute risk of death over 10 years of follow-up. According to diabetes and kidney disease status, the dotted line is the expected 10-year mortality for people with no diabetes or no kidney disease. What you can see on the left side here is that people who have type 2 diabetes but no evidence of kidney disease do have a slightly increased risk of mortality, 4.1% excess risk. But that excess risk goes up dramatically with albuminuria, low eGFR, or particularly both manifestations of chronic kidney disease. And this is attributable to atherosclerotic cardiovascular risk, myocardial infarctions and stroke, as well as heart failure and other causes of cardiovascular death, making the point that preventing cardiovascular complications is really critical for people who have chronic kidney disease. All right, so now I'm going to focus on these KDIGO clinical practice guidelines. And KDIGO, I noted, has made a number of kidney disease guidelines over time, everything from kidney transplantation to glomerular diseases, to complications of CKD like anemia. And they decided, given this background that I've introduced and all of the new trials and drugs assessing diabetic kidney disease, that it was time for a diabetes and CKD guideline. And this was commissioned in 2017. I had the honor of chairing it along with Peter Rossing, who's an endocrinologist from Denmark. And KDIGO is very rigorous, as is the ADA, in developing their clinical practice guidelines. We had a work group leading this that was quite diverse. In addition to nephrologists and endocrinologists, we had a cardiologist, a primary care doctor, a nutritionist, a pharmacologist, and 2 patients who were involved from the very beginning, who kept our work very much grounded with a patient perspective. These experts came from 6 different continents and had really deep and complementary expertise in endocrinology, nephrology, et cetera. And we were supported by the Cochrane Evidence Review Team from Australia, who did a very thorough evidence review and helped us assess the quality and strength of recommendations using grade criteria. So the first guideline was introduced in 2020, published in Kidney International in that year, and it really is quite comprehensive. It addresses comprehensive care of the whole patient with type 1 and type 2 diabetes, glycemic monitoring and targets, lifestyle interventions, anti-hyperglycemic therapy, and approaches to management, including self-care and systems approaches. And these are summarized using this pyramid, which has become somewhat emblematic of the guideline here on the right. And I'm not going to go into this pyramid because after just 2 years with all of the new data that's come out, as you've heard from Dr. Gabe and Dr. Cannon and throughout the day, we felt the need to update this guideline in 2022. And we've taken a similar approach, but updated the pyramid. This is not yet published, but will come out in the next month or two in Kidney International. And you can see some themes that are quite similar to what you saw in the prior lectures, including that comprehensive care for people with diabetes and chronic kidney disease should be based on a foundation of lifestyle. You can see here diet, exercise, smoking cessation, and weight. It should also include a foundation of first-line drug therapy for proven drugs with proven benefits. You can see here Metformin and SGLT2 inhibitors for people who have type 2 diabetes, as well as renin-angiotensin system blockade for people with hypertension, and statins, as Chris nicely went over, with goal-directed therapy layered on top of that, including for appropriate patients, and I'll go into this, GLP-1 receptor agonists and non-steroidal mineralocorticoid receptor antagonists, antiplatelet agents, specifically named as agents to consider. So obviously in this talk, I can't go through the whole clinical practice guideline, but I do intend to touch on lifestyle interventions, the foundation of this care, and then focus largely on some of the newer classes of agents, including the evidence behind them and how to select patients and implement those newer therapies, and the changes that are coming in the 2022 guideline compared to the 2020 guideline. So there's a lot to consider for nutrition for patients who have both diabetes and chronic kidney disease. Mostly these patients hear about things that they're not supposed to eat, and there can be recommendations on anything from carbohydrates to proteins to micronutrients, electrolytes like potassium and phosphate, et cetera. And so with discussion, we felt that the most important thing to do for this population was to emphasize general eating principles of consuming what most would consider a heart-healthy diet, which is also kidney healthy. And that is one that's high in vegetables, fruits, whole grains, fiber, legumes, et cetera, and lower in processed meats, refined carbohydrates, and sweetened beverages. This is not rocket science, but I think it's very important before telling patients all of the details of what they can't do to provide an overall picture of what can be done. And as noted here, this is an international guideline, and it's very important to acknowledge individual cultures and preferences when instituting this sort of nutrition guidance, as you can see in the figure. We do then have some specific recommendations about tailoring nutrition from there. And one is about dietary protein, which has received a lot of attention in the kidney disease world, with the hope that lower protein diets might improve kidney outcomes by reducing stress in the kidneys. And in fact, clinical trials to date have not shown that dietary protein restriction markedly improves outcomes in humans. And so the guideline issues a recommendation to maintain a protein intake of about 0.8 grams of protein per kilogram of body weight per day. That is the World Health Organization recommended diet. So it's no different than people without kidney disease or diabetes. We do recommend avoiding high protein, which there are signals for deleterious outcomes, except in the case of hemodialysis and peritoneal dialysis patients who are catabolic and may lose protein, for whom slightly higher protein intakes are recommended. We also recommend low sodium diets and as shown here, some approaches to reducing sodium in the diet. This is mainly to improve blood pressure and to improve cardiovascular outcomes, which I noted are critical for people with kidney disease. And also, physical activity is critical for improving both kidney and cardiovascular outcomes. And I won't go through all of these. Our recommendations are consistent with the American Heart Association and other organizations to try and exercise cumulatively about 150 minutes per week, tailored to patients' comorbidities, fall risks, etc. Well, what about drug therapy? And I have only one slide. I think you're all aware of the importance of renin-angiotensin system inhibition for people with chronic kidney disease, and Chris covered this as well. There were really three critical pivotal trials establishing RAS inhibition as important for people with diabetes and chronic kidney disease. One was the Captopril collaborative study in type 1 diabetes, not shown here. And then in type 2 diabetes, the Renal study on the left and the IDNT study on the right. All three of these trials enrolled people with high blood pressure, heavy albuminuria, and looked at an ACE or an ARB compared with placebo, or in the case of the IDNT, also an active comparator, amlodipine, and looked at the risk of chronic kidney disease progression, and found modest but clinically important and statistically significant reductions in progression. For example, 16% reduction with losartan in the Renal study, and a 20% reduction in CKD progression with irbesartan in the IDNT study. So we make a very clear recommendation that for both type 1 and type 2 diabetes patients, if you have hypertension and albuminuria, a RAS inhibitor needs to be part of the treatment regimen to prevent and slow the risk of kidney function decline. Now, one thing I also want to point out on the slide is the large residual risk of patients with these characteristics. At 4 years in the Renal study, even in the losartan group, half of patients had substantial kidney disease progression. This is doubling of creatinine, kidney failure, et cetera. Similar in the IDNT study. And so RAS inhibition alone does not substantially prevent kidney disease progression among people at high risk. And so this is why SGLT2 inhibitors have become so important, and as I alluded to in the pyramid, really part of the new standard of care for people with diabetes, with type 2 diabetes and chronic kidney disease. And Chris introduced these trials, and I think you heard them earlier today as well. There are now 11 published high-quality clinical outcome studies with SGLT2 inhibitors, with 2 additional ones, DELIVER and EMPA-KIDNEY, that have been stopped for benefit, and results are pending this year. That will be 13 such trials. Really a wealth of evidence looking at the effects of SGLT2 inhibitors on the kidney and cardiovascular system. I tend to lump these trials into 3 categories. In blue are the cardiovascular outcome studies that enrolled people with type 2 diabetes and high atherosclerotic cardiovascular disease risk and looked at ASCVD outcomes. In yellow, the heart failure trials, which enrolled people with heart failure with or without type 2 diabetes and looked at heart failure outcomes. And in green, the CKD studies, which enrolled people with chronic kidney disease with or without type 2 diabetes and looked at primary kidney disease outcomes. One exception there is SCORED, which enrolled people with chronic kidney disease but looked at cardiovascular outcomes. And Chris nicely summarized these results as well, so I'll go through this rather quickly. But the benefits of these drugs are impressive, and they do appear to be a class effect. I agree with the question asked at the end of the last lecture and Chris's response to that. Here is the effect of SGLT2 inhibitors in meta-analysis on heart failure or cardiovascular death. It's grouped first by the category of study, heart failure, CVOTs, and chronic kidney disease studies. And you can see quite consistent reductions in heart failure across the populations and within each population across the drugs within those populations, and a 23% reduction in that outcome shown here. Also an 11% reduction in major atherosclerotic cardiovascular events. And very importantly, and one of the reasons that kidney disease is focused on this class of drugs so heavily is the 36% reduction in chronic kidney disease progression, defined by substantial reductions of EGFR or kidney failure. That's a very large effect. And again, a class effect with some outliers, but generally a class effect, strong differences in reductions in cardiovascular death as well. So the KDIGO recommendation for SGLT2 inhibitors is to treat all patients with type 2 diabetes, chronic kidney disease defined as either elevated albuminuria or low EGFR, and an EGFR of 20 mils per minute with an SGLT2 inhibitor, and that's given the highest level of evidence and strength of recommendation with 1A. So in other words, we're recommending SGLT2 inhibitors for the whole heat map of chronic kidney disease classification. And that's because these studies that I have described really have covered this heat map, with the cardiovascular outcome study covering people with all levels of albuminuria and EGFR of 30 or more, the Credence and DAPA-CKD studies really enhancing the evidence for people with high levels of albuminuria and high chronic kidney disease risk, SCORED, and the EMPEROR trials, both pushing down the level of EGFR for eligibility and including patients with lower EGFR, which we'll also see when data come out from the EMPA kidney study. So there's oftentimes questions about, well, what do you do with people who have chronic kidney disease and with low EGFR but no albuminuria? Well, they're included in this recommendation, both for the kidney and cardiovascular benefits, and there's abundant data to support that. I will note that the 20 mil per minute threshold is something that comes up a lot as well, and that's new from 2020. In the 2020 guideline, KDIGO suggested initiating SGLT2 inhibitor down to 30 mils per minute. In the 2022 guideline, we recommend initiating down to 20 mils per minute. And why is that? The first bullet is probably most important here. Glycemia lowering decreases as EGFR goes down. That's because less glucose is filtered when GFR is low. However, the benefits and risks of SGLT2 inhibitors with regard to kidney and cardiovascular outcomes are preserved across all levels of EGFR and all levels of albuminuria for that matter. And so despite lower glucose lowering efficacy, the clinical benefits are maintained. And then you can see, and I won't read through each of these bullets, but new trials have included people with lower EGFRs. Post-hoc analyses of previously published trials have also demonstrated clinical benefits of these drugs, even at low EGFRs. And in the last bullet, I'll note that several trials, while they've have thresholds for inclusion of participants and starting in SGLT2 inhibitors, the clinical trial protocols included maintaining the patients on study drug, even if the EGFR dipped below the eligibility threshold. And in fact, that's how the KDIGO guidelines recommend implementation of SGLT2 inhibitors for people with progressive chronic kidney disease, that is continuing the drug as long as it's tolerated, even below this initiation threshold. There are a number of practice points guiding the implementation of SGLT2 inhibitors. They're summarized in this slide, and I'll just pick out a few to note. First, in the upper right, in follow-up of initiation of an SGLT2 inhibitor, a small dip in EGFR is commonly seen and should be anticipated and is generally not a reason to stop an SGLT2 inhibitor. How much of a dip is okay? Usually up to about 30% seems to be okay based on post-hoc analyses of the EMPA-REG and Credence trials. I'll also note in these bottom two rows that in general, SGLT2 inhibitors can be safely and effectively added to existing regimens for glycemic management and volume control, as was done in all of these trials. However, patients who are at high risk of hypoglycemia or volume depletion may need attention to concomitant medications that could cause hypoglycemia or volume depletion, such as diuretics. So more broadly, the KDIGO guideline has this diagram to help guide in glucose-lowering drugs for patients with type 2 diabetes and chronic kidney disease. It suggests that glucose lowering should be based again on lifestyle, and that first-line therapy should include an SGLT2 inhibitor down to an EGFR of 20, is noted here, as well as metformin. Further discussion goes, it suggests that both metformin and SGLT2 inhibitor are logical co-first line therapies for most patients with this combination of conditions. That's consistent with what Dr. Gabay suggested for his first patient, even though that patient didn't have chronic kidney disease. I think if that patient had chronic kidney disease, the combination of metformin and SGLT2 inhibitor would have been particularly compelling in that case example. And then for patients who need additional drug therapy to control hemoglobin A1C, glycemia, that should be guided by patient preferences, comorbidities, eGFR, and cost. But a GLP-1 receptor agonist is recommended and preferred for potential kidney benefits, but mainly for the cardiovascular benefits that Chris outlined as well. I do want to comment on glycemic monitoring briefly, and there's one recommendation in the KDIGO guideline that seems quite basic but is important, and that is recommending hemoglobin A1C to monitor glycemic control in patients with diabetes and chronic kidney disease. Why is it important to make such a basic recommendation? Well, there's a widely recognized bias in hemoglobin A1C in people with advanced chronic kidney disease, particularly patients treated with dialysis. And in the lower right here, you can see some of the reasons that patients treated with dialysis have a falsely low hemoglobin A1C on average. We conducted a review of the literature and found that hemoglobin A1C actually performs quite well down to an eGFR of about 30 mils per minute, after which it becomes a little less precise. And then in the dialysis population, bias low is noted here. It's important, though, that most patients with diabetes and chronic kidney disease do have eGFRs more than 30, and hemoglobin A1C should continue to be used. We discuss in the guideline that directly measuring blood glucose, for example, with CGM, is a very valuable adjunct in this population, very logical. There haven't been a lot of studies conducted in the dialysis or advanced chronic kidney disease patients, but that is a logical alternative when hemoglobin A1C is not performing well. Like the ADA, the KDIGO guidelines recommend a spectrum of individualized hemoglobin A1C targets, including potentially quite aggressive targets for patients who have few comorbidities and a low risk of hypoglycemia. And of course, these lower targets are facilitated by the new medications that can effectively control blood glucose with low risk of hypoglycemia. Patients who have more comorbidities and more risk of hypoglycemia, as in the ADA, are recommended to have higher hemoglobin A1C targets. I'd like to talk more about GLP-1 receptor agonists today, but for the sake of time, I only have one slide. And there is a lot going on in this field, as Chris said, with a lot of studies looking at the kidney effects of GLP-1 receptor agonists and one outcome study underway. I do want to summarize some of the effects of GLP-1 receptor agonists from clinical outcome studies, and note first that most of these have had major atherosclerotic cardiovascular events as the primary outcomes, and many of these studies have shown benefits, and Chris summarized that data very nicely. Most of these studies have also looked at kidney outcomes as secondary outcomes and found benefit, mostly with regard to albuminuria reduction. Albuminuria reduction is an important intermediate outcome for kidney disease, but it is not an accepted surrogate outcome or a clinical outcome. And what we tend to want to see to really promote new drugs is a benefit with regard to eGFR loss. And as you can see in the second to right column here, in the secondary analysis of these trials, we've had not clear evidence of whether GLP-1 receptor agonists will, in the long term, slow eGFR loss. The FLOW trial is the trial currently underway to address that more rigorously. And we're hopeful, based on some of the provocative data, including benefits in the REWIND trial for dulaglutide, that we'll see benefits there that will further promote the use of GLP-1 receptor agonists in this population. Chris noted there's a new agent on the scene, and that's finerenone, and I will talk about that in a little bit more detail. And finerenone was evaluated in a pair of sister trials called Fidelio DKD and Figaro DKD. This is a visual abstract showing the results of the Fidelio DKD trial. It was a double-blind trial enrolling people with type 2 diabetes who were treated with RAS blockade and had an eGFR of 25 to 75 with albuminuria. That was a key eligibility criteria because albuminuria is such a risk factor for chronic kidney disease progression and cardiovascular events. For Fidelio DKD, the primary outcome was kidney failure, or a kidney composite, which included kidney failure, sustained decrease of eGFR of 40% or more, or death from kidney disease, and that was significantly reduced by 18%. A key secondary composite outcome, which was MACE plus heart failure, was reduced by 14%, also statistically significant, with a modest increase in hyperkalemia, a known adverse event for mineralocorticoid receptor antagonists. There were no deaths due to hyperkalemia in the trial. I won't show results for the Figaro DKD trial, except to note that it was also a type 2 diabetes population treated with RAS blockade. It was at higher cardiovascular risk and lower kidney risk. Also, everybody had albuminuria. The outcomes were reversed, and the cardiovascular outcome was the primary outcome, and it was significantly reduced. And in my mind, this really validated the effects seen in Fidelio DKD. So there is a new recommendation in the 2022 KDIGO guideline suggesting a non-steroidal mineralocorticoid receptor antagonist with proven kidney or cardiovascular benefit. Right now, that's just finerenone. For patients who have type 2 diabetes, an estimated GFR of 25 mils per minute or more, normal serum potassium concentration, and albuminuria despite maximum tolerated dose of RAS inhibitor. And that's given a 2A level of recommendation. And I view the most likely and most appropriate application of this drug as layering on top of standard of care therapy, which includes a RAS inhibitor, which is explicitly stated here, and probably also on top of an SGLT2 inhibitor, for which we now have such incredible evidence, and including that in the standard of care. And I'll note, as noted in the bottom here, that a non-steroidal MRA can be added to a RAS and an SGLT2 inhibitor. Subgroup analyses suggested that the benefits of non-steroidal MRA were similar with or without the presence of an SGLT2 inhibitor at baseline. I noted that hyperkalemia is the most common problem with finerenone treatment, as with other MRAs like spironolactone. And so there's guidance about how to appropriately select people to reduce the risk of hyperkalemia and for monitoring throughout the trial. Essentially, we recommend that you select patients with potassium of 4.8 millimoles per liter or lower, and have regular monitoring with dose adjustments and holding finerenone as needed throughout treatment. It is very important to think beyond lifestyle and drugs to other ways to improve outcomes in this high-risk population. And self-care is, of course, very important. And the KDIGO guidelines take a nod to the ADA guidelines in recommending structured self-management education programs to improve diabetes knowledge, self-management, reduce risk factors for complications, and improve emotional and mental well-being for patients with diabetes and chronic kidney disease. This is an important aspect of care not to be overlooked. And these are complex patients, as Dr. Gabe and Dr. Cannon said nicely. And in order to effectively deliver the interventions that we now have that are effective, we really need systems level approaches, integrated care, supported by decision makers and delivered by a diverse group of providers to identify appropriate patients for implementing these therapies and getting them to the people who need them most to improve outcomes for the population. I'm going to summarize, or before I summarize, I'm going to note that there are a lot of clinical practice guidelines out there. This can be overwhelming, and sometimes people focus on what they perceive as differences in the guidelines to suggest that there are problems or reasons not to implement these. And I want to start by noting that there are a lot of guidelines out there. They really are, in my mind, quite similar, complementary, and aligned. And recognizing this potential concern, KDIGO and the ADA partnered over the last year to write a consensus statement about management of patients with diabetes and chronic kidney disease. And our charge really was to look at the two guidelines, the standard of care for 2022 and the KDIGO guideline for 2022, and look and see where they're aligned, where there are any discrepancies. And I'll say they're almost fully aligned. And you heard, I think, similar statements and recommendations from Dr. Gabe, Dr. Cannon, and I. And they really are pointed towards the same direction. This is a flow diagram that the group came up with to highlight the high priority shared recommendations from the two organizations. It looks familiar to what you saw in Dr. Gabe and Dr. Cannon's presentations, and sort of like the pyramid that I showed in the beginning of this talk, but the other way around, from top to bottom. And notably, as always, management rests on lifestyle modification. There are important first-line drug therapies that are proven to improve outcomes, and those include, for all patients, statins. This is all patients with diabetes and chronic kidney disease, I should emphasize. Statins, RAS inhibitors for people with albuminuria hypertension, for people with type 2 diabetes, who are shown in this color box here. SGLT2 inhibitors with metformin are considered first-line therapies. Regular reassessment of intermediate targets, including glycemia, blood pressure, lipids, as well as cardiovascular risk, and albuminuria, as Dr. Gabe noted, is important to guide additional risk-based therapy. And you can see that GLP-1 receptor agonists, non-steroidal MRAs, and some of the important cardiovascular agents that Chris was talking about, antiplatelet agents, ezetimibe, PCSK9 inhibitors, et cetera, are recommended in that alignment as well. So this, I hope, is a useful figure, will be published in the next couple of months, that summarizes some of the high priority consensus approaches to improving outcomes for people with diabetes and chronic kidney disease. And with that, I'll stop and summarize. I'll note that this KDIGO guideline, the 2020 version is currently available. The 2022 will be published in the next couple of months. It really does provide recommendation and practice for points on a wide range of care for people with diabetes and CKD. It includes lifestyle management as a foundation of care. SGLT2 inhibitors really now are part of the standard of care for type 2 diabetes and chronic kidney disease, with new guidance for GLP-1 receptor agonists and non-steroidal MRAs. Self-management and systems levels approaches are critical. And I want to thank all of you in the audience for listening to this talk, the organizers for inviting me, and the KDIGO work group for all the work they put into these guidelines that I presented today. Thank you.
It's a pleasure listening to you, and thank you so much for tuning in. And there are no questions from the audience, so we'll conclude this session. Thank you again for joining us at this hour, and pleasure listening to you.
Thank you very much.
Thank you. And with that, we conclude today's program.